Before this, because it is a just start, I will just say few lines in Punjabi, because in our Punjab culture, ji aaya nu kya jata hai. Ji aaya nu. The topic is research on 3 waves of psychotherapy in India. Basically, there are 3 waves in psychotherapy. First wave came when there was a behavioral therapy. Personal behavior was changed. Then come the cognitive behavioral therapy, and then these days mindfulness-based cognitive therapy. Talk is the medium used to transfer therapeutic techniques and encourage quiet rest in the human-to-human therapeutic relationship. There is need to differentiate between psychological intervention and psychotherapy. Everyone becomes counselor, psychotherapist in our country, but this is not right because they do not follow the protocols. All psychotherapies are psychological intervention, but not all psychological intervention are psychotherapies. Numerous psychotherapy have been developed worldwide, some have endured, while others have failed. Various formats are first wave, exposure response prevention, second wave, and the third wave. Those psychotherapy that survived have one thing in common. There is evidence-based, science-based. In the current scenario, several professional organizations mention cognitive behavioral therapy, this is different ways, and psychoanalytic are the 2 major psychotherapies. The American Psycho Association division talks the only treatment with Robert's evidence is 80% of 36 disorder is with this type of cognitive behavioral therapy. Our national body, Indian Psychiatry, published guidelines for running psychotherapy program in India, and there is a special journal for this. Most evidence-based psychotherapy practice in India are based on Western models of psychotherapy. The momentum has increased in last 2010. The most common practice in India follows the cognitive behavioral model. There are 3 things. One is thinking, other is behavior, other is feeling. So this triad goes on. There have been attempts both to replicate the Western model in Indian setting and to innovate new techniques for our global practice. So this study was planned to review the various research work done by Indian researchers in the last 20 years. The methodology was a manual search and a digital search of the Indian studies was keywords were these psychotherapies, cognitive behavioral therapy, dialectic behavioral therapy, other mindfulness-based therapy, and psychoanalytic therapy. Research in general PubMed, Google Scholar, and Scopus databases. Indian journal were also searched. The inclusion criteria were only those studies were included which have PubMed index journal that describe an evidence-based techniques, and other therapy like grief therapy were also included because it is very, very important in our Indian context. The other study which were having other parameter like yoga therapy, chess therapy, or other surveys, reviews, articles, which were not as much RCT trial like, so they were excluded to make it a more robust finding. Now briefly about the findings. If you see this chart, it is very, very interesting. The sample size is around 20 per trial. There are 4 RCT, randomized controlled trial, done by Indian authors and published in various articles. The most common clinical condition are adults and depression, panic disorder, social anxiety disorder, other agoraphobia, obsessive compulsive disorder, and schizophrenia. Another is very interesting that there were majority were found research is case report and case series. They were also very, very important. And another is third wave therapies, mindfulness-based cognitive therapy model, which was developed in AIIMS Bathinda. That was also found in this literature. It was published in international journal. So another brief therapy, brief intervention for substance use disorder, attempted suicide, and post-traumatic stress disorder, and borderline personality were also found. I am talking about the mindfulness-based cognitive therapy, which is developed in AIIMS Bathinda, only center in India, which this has been done. And we have a particular Friday clinic based on this. This single model of mindfulness-based cognitive has been replicated in 30 adolescents suffering from depressive disorder and suicidal behavior, and we reported a very good results. Similarly, this is third wave therapy, acceptance and commitment therapy. Most of the problem is that we do not accept the clinical condition. When you do this therapy, it is very, very interesting. This article, this was published in International Journal. We have done with the OCD with substance use patient, and it has a wonderful result. This is practiced in our clinic. Online psychotherapy is doing wonderful work. Telepsychotherapy has found useful for client evidence strong for this modality. This is very, very virtual and is going to last in future also. Now coming to the current role, taking time into consideration, the last 2 decades have been modest interest among many researchers trying to implement evidence-based psychotherapy in the clinical population. Their attempt to introduce science-based psychotherapy in the light of the day, a consensus and achieved formality evidence-based psychotherapy in India. Our views are restricted to Indian studies, so we try to do at this. We found 37 articles, very good article, and national body has given us a review article, and we are going to publish it. At the individual level, evidence is used in depression, anxiety disorder, obsessive compulsive disorder, social anxiety disorder, schizophrenia, tic disorder, and other. At the community level, evidence is used in severe depression, perinatal depression, adolescent depression, alcohol use disorder, and suicide. With these, I thank the organizer and wish all of the best for the coming 3 days. Thank you very much.
Very nice presentation, Dr. Vitull Singh.
Thank you, sir.
I think probably it's the need of the hour these days, you see.
Yes.
With the sort of era of a super specialization.
Yes, sir.
Most of the doctors, you see, probably they are not trained or they are not trained enough for their own psychological or psychotherapeutic part.
Yes, sir.
And day by day, as depression and anxiety is increasing, on the increase,
Yes.
I think we need more and more people to address this sort of a topic, whatever you have done today.
Yes.
Because in our days, you see, medical school days, most of the doctors, I mean, this was a part and parcel of our sort of a study. I mean, still, you see, rather than my medical practice, probably I am doing more of a psychotherapy than the medical practice.
Definitely, sir.
I mean, more as a psychiatrist than as a medical specialist.
Definitely.
I think with the present era, probably with your all this study and everything, it's the need of the hour, it's a very good thing.
Yes.
We appreciate it.
Thank you, sir. Thank you so much. Basically, talk is very, very important. What is our training is doing? We are not talking with the patient. Doctor-patient relation is worsened because you see in our OPD, pharmacology drug is very good. I am not talking against that, but this doctor-patient relation is going to last. If you see the famous doctor, who is the famous? He has a very good talk therapy. So this is very, very important.
Very true. You see, because we are more dependent upon writing more drugs rather than real...
Any investigation.
Yeah,
Any investigation. Yeah.
Investigation rather than interacting with the patient.
Yeah.
That is more important. Thank you.
Thank you, sir. Thank you very much.
Thank you, sir, for the presentation. I request the next speaker, Dr. Kevin Khatri from AIIMS Bathinda, to present his presentation on pain relief after operative treatment of multiple extremity fractures with NEFAPAM randomized control trial.
Hello, good morning everyone. I'll be speaking on this important topic because we are facing a challenge. Why this is important actually? We are facing day by day multiple patients with multiple injuries, and the opioid is one of the drugs which is very commonly used in the post-operative period. But the problem in our part of the world is not available. One. And the reason is our good friends, if you see. So why it is important? The death related to opioid administration is increasing day by day across the countries, across the world. Sorry for interruption. Just and there was this paper in 2017 which focused on this thing, whether we can replace the opiates or not with non-opioid analgesics in our emergency department. And they come up with NACIDs, the non-steroidal anti-inflammatory drugs. But the problem with these is that they inhibit bone healing, which has been proved to be in other various studies across the sections. So, do we have an answer to any replacement or answer to non-opioid drugs? Maybe not. And we are still searching for it. And nifopam is one of the drugs which is a non-opioid, non-steroidal analgesic that inhibits the reuptake of serotonin, norepinephrine and dopamine. Post-operative analgesia is required to achieve adequate rehabilitation comfort in orthopedic patients. And non-narcotic analgesics are given in combination with opioid to achieve desired side effects. The satisfaction with pain relief is being used as a measure to assess the quality of care in patients. And many patients can be treated with non-opioid analgesics, but still a large majority is prescribed opioid medication. And acetaminophen is frequently used in management of fracture pain, but is not adequate. And it is not achieved with the pain is not achieved, pain relief is not achieved in isolation with these things. Especially in patients who have sustained multiple fractures. It is combined with tramadol or NSAIDs, and sometimes all across you combine the opioid and the NSAIDs to achieve the pain relief. So in our study, the objective was to ascertain the non-inferiority in pain relief of drug combination of acetaminophen with nifopam to that of acetaminophen with tramadol, and to identify difference in pain intensity between groups and factors associated with greater pain satisfaction or pain intensity. It was a randomized controlled trial with 2 weeks before. The study was carried out over 5 years, and the patients included were of periarticular multiple extremity fractures presenting in the emergency department. The sample size was calculated based upon a previous study, and we plan to enroll 46 subjects in each arm. The excluded were pathological fractures, females, pregnant females, patients below the age of 18 years, breastfeeding females, persons who require opiate medication after 2 days in a hospital stay, and those with head injury, chest or major abdominal injuries. So we included all the adult patients who had periarticular or multiple shaft fractures. The random number were generated in a computer 1:1 allocation, and the staff was not involved in the care of the patients was who performed enrollment and data collection. During the post-operative period, patients were given post-operative analgesia including acetaminophen, tramadol or diclofenac as needed for first 2 days, and no track of that was maintained. After 2 days, they were prescribed oral medication. They were shifted to oral medication of either acetaminophen with a 1000 mg every 6 hourly along with 50 mg of tramadol every 8 hourly, or acetaminophen with separate prescription of 30 mg of nifopam every 8 hourly. So acetaminophen was same in both the groups. So we had tramadol in one group and nifopam in the other group. The assessment was made by the response to nociception by pain self-efficiency questionnaire, and anxiety was made by pain anxiety symptom scale, PAS scale. Mood was of the patient was made with patient health questionnaire. At the time of suture removal, the pain at that moment was noted. Worst pain since injury was noted. Mean pain since injury was noted. All were made on a 10 ordinate scales from 1 very unsatisfied and 10 on a very satisfied. Disability in these patients were made using short musculoskeletal function assessment scoring. The analysis in both was carried on both intent to treat principle and per protocol principle. So we have used multiple variable regression analysis and single regression imputation for the data analysis. This is the flowchart of the patients. We had 243 patients who were assessed for eligibility, and at the final 92 patients were randomized into 2 groups. One group with acetaminophen with nifopam and the other with tramadol. At the end of the study, we had 44 patients in group 1, that is in the nifopam group, and 45 patients in the other or tramadol group. The baseline characteristics were similar in both the groups. So the difference between the pain at the movement, worst pain, mean pain, and these 3 scales which we had used for nociceptions and the mood assessments were the p-values were almost similar. There were no significant differences between the two groups. And the satisfaction in the both groups were also similar, though the adverse events were seen more in the tramadol group. In the multivariate analysis, we have shown that the only factor which was associated with greater pain relief was the males. They had better pain relief. The factors independently associated with higher worst pain intensity were young age and lower education. Patient and other factors which had independently associated with greater mean pain intensity were young age and lower mood. These were the two things which we had noticed in our study. I have 2 minutes. Combination of acetaminophen with nifopam is not inferior to that of tramadol. This will be had to note in our study. The patients taking opioids for a long time after surgical procedure experience more stress and less effective coping strategies. And nifopam has been extensively used in the management of post-operative pain in non-orthopedic procedures, but the use in orthopedic procedure is very limited. And patients who continue to take opioid medication weeks or months after surgical procedure have greater stress and distress and less effective coping strategies. Opioids are used in attempt to treat psychological distress or less effective coping strategies. The limitations of study was it was a single blinded study because of funding limitations. We could not blind the patients and they were asked to bring the medication. A single center study reduced the variability in treatment protocols, but we cannot just say that we can apply it to across all other centers. So to conclude, we have to be careful when considering the prescription of habit-forming and risky opioid medications in patients, especially the multiple fractures, the patient who experience multiple fractures. And nifopam in combination with acetaminophen is good alternative in periarticular multiple extremity fractures. Thank you, sir.
Thank you, Dr. Khatri.
Thank you, sir.
You see, my concern is, I mean, the short experience of using nifopam. I thought it's probably very weak analgesic, but you have opened a Pandora's box, as far as the analgesic part of treatment concerned in this multiple injuries. And if it is true, I think probably we need more studies to really confirm it.
Yes.
And I still doubt it that it can be that effective as compared to tramadol and the acetaminophen combination. The dose of acetaminophen, 1 gram 6 hours, which means almost 4 grams.
Yes.
I think anything more than 3 grams will probably have hepatotoxic, So one has to be very careful in that part, and we have to rule out whether they have any underlying hepatic or renal problem before using any of this.
Yes, we had.
I don't know about nifopam whether it is renal safe or not.
It's safe.
I think we need more and more
Yes.
studies to further substantiate your study. That's my feeling.
Yes, so we had just we were looking for the substitute to tramadol. Actually, that's a very big problem in our part of the world. The prescription of opioids, and this is really getting at the problem.
The tramadol is a habit forming,
Yes, sir.
That the patient, particularly elderly patient, is a lot of constipation and that's a part of the problem with the tramadol. That's why we are looking for an alternative. And if this study proves it, probably it will be much more for the future, more effective than the present analysis.
Yes, sir. And so we have excluded the first 48 hours. We are not giving the patients all. We have included that so that they don't get.
First 40 hours, probably you need parental.
Yes, sir. Parenteral and the breastfeeding.
Thank you, Dr. Khatri.
Thank you, sir.
This nifopam is a psychostimulant, and is there any chance of with continued use any addictive abilities?
Sir, I have not. I have gone through literature. Not the habit forming as compared to the tramadol, which had more problems, and we have seen the issue with the medication. Not compared to that, it's very less, very low reported cases.
Thank you.
Thank you.
Thank you, sir. Now I would like to call upon the stage Dr. Ashita Mahajan from DMC Ludhiana to present her oral presentation on the topic Evaluation of Depression and its Association with CD4 count in HIV/AIDS patient undergoing antiretroviral therapy.
Good morning, everyone. Thank you for giving me this opportunity to present my study. So, the topic for my presentation today is evaluation of depression and its association with CD4 count in patients living with HIV and AIDS and undergoing antiretroviral therapy. So, as we all know that any severe physical ailment can have an effect on mental health. Excuse me. Sorry for the interruption. So as we all know that any severe physical ailment can have an effect on mental health. Similarly, HIV can have a significant impact on mental health, with depression and anxiety being very common. In recent studies, it has also been found that HIV has a direct neurobiological action, which can be a factor for origin of depression in such patients. Talking about how depression can affect the treatment in HIV patients, it can lead to poor adherence both of the treatment pertaining to depression as well as the antiretroviral therapy. Furthermore, we also know that CD4 count serves as a predictor for HIV severity, which was part of the study. So the objective of my study was to explore the prevalence of depression among patients with HIV undergoing ART, and if there was any correlation between depression and CD4 count. The methods, material and methods, this study was conducted in a tertiary care hospital, and it was a questionnaire-based study design. Prior to the study, permission was taken from Institutional Ethical Committee and consent was obtained from the patients during collection of data. Socio-demographic characteristics were obtained from the patients using a performer, and to study the severity of, explore the severity of depression in patients, Hamilton Depression Rating Scale was used, which is commonly known as the HAM-D scale. It is a 17-point depression scale, on basis of which severity of patients' depression can be categorized in mild, mild to moderate, and moderate to severe categories. And the CD4 count at the time of recruitment was also recorded. So, according to my results, total of 111 patients were evaluated, out of which 60 were males and 51 were females, and significant results were seen in the following scenarios. Patients from extended families had a higher depression severity as compared to those from nuclear families, and lower income bracket people were more prone to severe depression. Patients diagnosed less than 2 years ago had a higher depression severity, and lower CD4 counts were associated with more severe depression. There was no significant correlation found in other socio-demographic characteristics in the performer, such as there was no correlation between depression severity and age, gender, occupation, disease duration, treatment duration, history of any IV drug abuse, presence of comorbidities such as tuberculosis, hepatitis, which are a few of the common comorbidities which are found in people living with HIV. So in conclusion, this study was a point prevalence assessment of depression in HIV patients. And depression, although I mentioned that there was no correlation in patients with depression and their occupation, but there was found that depression ranging from mild to very severe was observed among housewives, and depression was least common in patients working as drivers. The CD4 count showed variable associations with depression. I understand there were a few limitations in my study, which were small sample size, a single center design which can limit the generalizability of my findings, and also the self-reported nature of the data, which can introduce response bias from the patient side. So I would like to conclude it by saying that depression is prevalent in patients living with HIV, and there should be regular screenings done for the psychiatric comorbidity, as it can affect compliance to the HIV treatment itself. And to improve patient cares and outcomes, it is important to approach it in a holistic manner. Thank you.
Thank you, Dr. Ashta. What made you to study depression in this HIV? Because I feel personally, HIV itself is such a, social stigma with it. All the patients with HIV, they will be depressed anyway. So why especially you choose HIV for this sort of a combination of depression and HIV?
Sir, I wanted to see what was the prevalence, what was the severity of depression, and I also did study about the anxiety and as well as the depression, just to see the correlation in what amount of people are affected with this psychiatric comorbidity.
I feel probably there are more limitations than the real study, you see.
Right.
There's a lot of limitations there to see in the study.
Yes, I understand that there are.
Anyway, good luck.
Thank you.
Thank you.
Thank you.
Thank you, ma'am. Now I would like to call upon the stage Dr. Ajit Lal for his oral presentation on the topic Clinical Profile of Newly Diagnosed DVT in Cancer Patients of Tertiary Care Center.
Good morning, everyone. I am going to present my thesis on the topic Clinical Profile of Newly Diagnosed DVT in Cancer Patients of Tertiary Cancer Care Center. Introduction. Deep vein thrombosis is a blood clot that forms within the deep veins. Risk factors include reduced blood flow, increased venous pressure, mechanical injury to the vein, increased blood viscosity, and increased risk of coagulation. Cancer-associated thrombosis is influenced by a number of cancer-related risk factors including cancer site, cancer stage, histological subtype, time since diagnosis, and chemotherapeutic agents. The aim and objective of study is that to study the association of DVT with type, site, and stage of cancer, and to study the time interval between the diagnosis of cancer and development of DVT. Materials and methods. The study was conducted after the approval by the Ethical Committee of Mohandas Hospital, Ludhiana, after signing the informed consent by the patient. This is a non-interventional cross-sectional observation study. The study was conducted in OPD, wards and ICU of Mohandas Hospital on cancer patients newly diagnosed with DVT. The study was conducted in 50 patients. Inclusion criteria. All cancer patients presenting to OPD were admitted in ward or ICU with suspected DVT and screened positive for DVT using screening investigations. Exclusion criteria are patients who are already on anticoagulants, patients who are already diagnosed of DVT, already diagnosed as a case of pulmonary embolism. Methodology is that identification of patients with symptoms and signs of DVT, screening of those patients for inclusion in the study, informed consent from patients and recruitment in the study, finding out the risk factors, causes of DVT, and treatment given to each patient as per performer. Data entry was done in Excel and descriptive statistics was used. Final report was read. The results was that the study, which was conducted in 50 cancer patients with newly diagnosed DVT, observed that adenocarcinoma is having more risk of developing DVT when compared to squamous cell carcinoma. Most common site of cancer causing DVT is cancer breast, followed by cancer ovary. The usual time of development of DVT is within 1 year of diagnosis of cancer. This pie chart shows that adenocarcinoma has 29% of development of DVT. This bar chart shows that about 30 cases out of the total 50 developed DVT. Time to diagnosis is DVT is usually seen less than 1 year after the diagnosis of the cancer. Conclusion. DVT is one of the common complications seen in cancer patients. Early identification of symptoms, proper screening and diagnosis followed by treatment can decrease the mortality and morbidity. Prevention of DVT is important in at-risk patients. Thank you.
Do you recommend using prophylactic treatment
in my study it was found that breast, CA ovary are having no risk of developing DVT. So if such patient come...
Unfortunately, the fair sex is more involved, no?
Yes.
Because it's both ovaries as well as the breast, you see that the maximum incidence you see.
Yes.
But you don't recommend a sort of a prophylactic treatment for all of them.
Yes, sir.
Thank you.
Thanks.
Thank you, sir. Now I would like to call upon the stage Dr. Riya Gautam for her oral presentation on the topic Bacteriological Profile and Antibiotic Sensitivity Pattern among Cancer Patients in a Tertiary Care Hospital.
Good morning, everyone. Respected teachers and my dear friends. My study is Bacteriological Profile and Antibiotic Sensitivity Pattern among Cancer Patients in a Tertiary Care Hospital. Under the guidance of Dr. Ashwin Phillips, Dr. Hardeep Singh, Dr. Ankur Mittal and Dr. Utkunj Mehta, we started this study in Mohanda Yoswal Hospital, Ludhiana, Punjab. Bacterial infections increases the length of hospital stay, causes significant morbidity and mortality, and increases the cost of stay. Situation further deteriorates with increasing incidence of multi-drug resistance. Culture and antibiotic sensitivity pattern is the single most reliable procedure for bacterial isolation and detection. Empirical treatment of infection in the cancer patient is often arbitrarily attempted by administration of broad spectrum or combination antibiotics until culture and susceptibility results are available. This could be made more evidence-based if the clinician has adequate information on the spectrum of microorganisms and the susceptibility patterns prevalent in that particular setting. It is possible that these patterns may differ from one geographical region to another and even from one hospital to another. Keeping in mind the ever-changing microbiological profile of infections in cancer patients, it is imperative that data about the locally prevalent pathogens and their antimicrobial sensitivity patterns should be generated and analyzed to decide appropriate empirical therapy. So, we did this study with the aim to study the bacteriological profile and antibiotic sensitivity pattern with the objectives to start the effective empirical antibiotics in infections in cancer patients so that we can decrease the morbidity, mortality, duration and cost of hospital stay in a long run by prescribing the appropriate empirical antibiotic therapy based on the bacteriological profile. This cross-sectional study over a span of 14 months included 150 biopsy-proven patients who were admitted with fever with age 18 years or above. Relevant cultures had been sent before starting antibiotics and was conducted in Mohanda Yoswal Hospital, Ludhiana. All the samples were processed and isolates were identified as per CLSI guidelines 2023. So we included all patients with biopsy-proven malignancy with fever, which is defined as skin temperature more than 37.2 degrees Celsius or 99 degree Fahrenheit, core temperature of more than 37.5 to 38.3 degrees Celsius or 99.5 degree Fahrenheit to 100.9, or a morning oral temperature of more than 37.2 degrees Celsius or late afternoon oral temperature of more than 37.7. We included all the patients of age 18 years or above, all patients with malignancies admitted for fever management, and all patients with proven active cancer. We did not include the patients less than 18 years age, patient who was not having any active form of cancer, that is cancer under remission, and patient with already proven culture sensitivity report, or patients who were already having any documented evidence of receiving any form of antibiotics prior to getting admitted. So coming to results, in a study of 150 patients, mean age was 56.9, among which 57 were male, that is 38% were male and 62% were female. 32% were hematological malignancies and 68% were solid. 8% of the patients were having central line. Median duration of stay in the hospital was 7. 4% of the patients were having febrile neutropenia, and most of these patients are hematological malignancy. 48% patient in 48% of the patient we modified the treatment, and 88% patient improved and discharged. 21% of the patients were growing multi-drug resistant organisms. Coming to positivity percent, The maximum positivity we found it in urine, that is 39%, followed by blood, which is 20%, followed by sputum, 11%, and then the wound, 9%, and then the stool and other samples, 2% and 3% respectively. Positivity percent in solid malignancies came out to be 21.9%, and hematological malignancies came out to be 31.8%. Most common organism which we found in blood was Staph aureus, followed by E. coli. In urine was E. coli, followed by Klebsiella. In sputum we found Klebsiella being the most common, followed by E. coli and Staph aureus. In stool we found E. coli was the most common, followed by Klebsiella. In wound we found Staph aureus being the most common, followed by E. coli. And in others we found out E. coli was the most common, followed by Klebsiella. Coming to the sensitivity pattern. First of all, E. coli. We can see that it is 100% sensitive to the drugs like ceftriaxone, sulbactam, EDTA, polymyxin B and tigecycline. But these are the restrictive antibiotics. We cannot use them empirically. So coming to the first group of antibiotics, that is penicillins, we can use piptaz as empirically because it is showing more than 50% sensitivity. Among cephalosporins, cefotaxime, cefuroxime, ceftazidime, they are showing less than 50% sensitivity, may not be very much effective empirically. But with that, what we can use is ceftriaxone, sulbactam, cefepime, as well as ceftazidime, clavulanic acid, because they are mostly showing more than 50%, approx 50% sensitivity to E. coli. Coming to fluoroquinolones, moxifloxacin, ofloxacin, they are showing less than 50% sensitivity, which will not be that much effective empirically. And carbapenems almost all are showing more than 50% sensitivity, so we can use. In a nutshell, for E. coli, we can use piptaz as well as carbapenems and few cephalosporins. Klebsiella. In our hospital, most of the Klebsiella were multi-drug resistant. So we cannot, only drug which we can use empirically we found was doripenem. Others are mostly multi-drug resistant.
The time for this presentation is up. Could you please wrap it up?
Among Acinetobacter, piptaz is showing more than 50% sensitivity. And but we can use empirically was piptaz, ceftriaxone, sulbactam, and among carbapenems we can use imipenem celastin as empirical drug of choice. Staph aureus, most of the gram-positive in our institute was MSSA, that is methicillin sensitive. 79% we can use methicillin, but in 21% we can go for vancomycin, linezolid, and other drugs for MRSA. Among enterococcus, most of the organisms are sensitive to linezolid, vancomycin, and levonorgestrel. In conclusion, there is in general a very high level of antibiotic resistance among gram-negative bacilli, particularly Klebsiella and Acinetobacter. Resistance among gram-positive is not that acute. So it is recommended that every institution should regularly revise their antimicrobial policy based on the microbiological data. Thank you.
Thank you, sir. Actually, as far as hematological malignancies are concerned, you see, I mean, my experience is that most of the time they present with fever, you see, pyrexia of unknown origin.
Yes, sir.
And I think once you diagnose hematological sort of malignancy, if you treat the hematological part, the fever automatically settles down rather than using antibiotics unless blood culture or something else you see shows some bacteria or anything else. So probably hematological malignancies are little different than the other malignancies as far as the fever is concerned. Regarding the resistant part, you see, as you know, haphazard use of antibiotics everywhere, you see, we were all using it day in and out without any sensitivity or anything. That is the basic reason for getting more and more resistant to all the antibiotics.
Yes, sir.
That is again a big problem, you see, with most of the doctors and physicians. But in a tertiary care hospital, because we have the facilities and everything, and the patient can pay for it also. So that's why you go for the test. And we feel that they should all get be tested before starting any antibiotics.
Yes.
That is the basic reason for getting more and more resistant antibiotics. Anyway, nice study. Thank you.
Thank you, sir.
With this, we end the paper session for today. Now I'd like to invite on stage Dr. Maninder Singh Joda, MS, MCH Urology, urologist and kidney transplant surgeon, Delhi Heart Institute and Multispeciality Hospital, Bathinda, to deliver his talk on emphysematous pyelonephritis, surgical perspective.
Good morning, everyone present. I am Dr. Maninder Jora, and presently I am working as a urologist and kidney transplant surgeon at Delhi Heart Institute and Multispeciality Hospital, Bathinda. Today's topic I have been asked to present a surgical perspective on emphysematous pyelonephritis. We all know this pyelonephritis is more of a medical ailment rather than a surgical ailment, but we will be discussing the conditions in which a physician needs to call a surgeon as soon as possible. That's basically the motive of today's talk. Coming on to the definition of emphysematous, we all know emphysematous means bulle or air. So emphysematous pyelonephritis, although it is rare, but it is a life-threatening. Even in today's scenario, the mortality for patients untreated emphysematous pyelonephritis, it shoots up to 50% in some studies. So it is a life-threatening urological emergency, and it is characterized by acute necrotizing parenchymal and perirenal infection caused by gas-forming uropathogens. That is the catch. It is caused by gas-forming uropathogens. As these terms suggest, it can occur anywhere in the urinary tract. If it is in the kidney, we call it as emphysematous pyelonephritis. If it is inside the collecting system, the renal parenchyma is not involved, it is only into the collecting system, then we call it as pyelitis. Then emphysematous ureteritis is when it is involving the ureteral walls only in isolation. And emphysematous cystitis is when it involves the urinary bladder wall. The objectives of today's talk is that we'll be discussing about definition, diagnosis, then we'll also discuss about the risk factors, clinical features, pathogenesis, diagnosis, treatment, and these things I have mentioned, but I'll not be discussing about renal perinephric abscesses, pyelonephrosis, and XPN or xanthogranulomatous pyelonephritis. We'll be focusing more on the emphysematous pyelonephritis part. Now, a bit of the history. The first case, it was reported in JAMA with the patient with nematuria, and nematuria was the patient was passing air bubbles in his urine, and in this term emphysematous pyelonephritis, it was coined in 1962 for the first time. The various studies which were done, they took these symptoms of upper urinary tract with fever, with urine positive cultures, and or pyuria with or without other identified infectious foci. Radiological evidence of gas in the collecting system, renal parenchyma or perinephric or pararenal spaces, and there should not be any fistula between the urinary tract and bowel, which can explain which can be an alternative cause of air in the urinary tract. So if these things are not there, the fistulas are not there, then we assume that it is because of the gas forming bacteria which has caused the infection. Now coming on to the risk factors. The risk factors are most of the patients, almost 96% of the patients who have emphysematous pyelonephritis are diabetes, whether diagnosed or undiagnosed. So, and a large majority, approximately 2/5 of approximately 80%, that comes up to 4/5 of the patients are females, and it is more prevalent on the left kidney for reasons unknown. And urinary tract obstruction is also present concomitantly in 29% of the patients, and 24% of these patients have stones, which may or may not have caused the urinary obstruction. Mean age of these patients are 55 to 60 years of age, and they have poor diabetes controls with HbA1c more than 11. Clinical features, usually patients have features of pyelonephritis, that is fever, flank pain and pyuria. Symptoms can have acute presentation or chronic presentation also. Nausea, vomiting, dyspnea, change in level of consciousness, and signs, shock and rash. Rash is because of it is because of the air which comes into the subcutaneous tissues of the lumbar area, and it shows off in the clinical examination as rash. So patients who have advanced emphysematous, neglected emphysematous pyelonephritis can present with rash also, along with all these features. Isolated rashes are not commonly seen. Coming on to the clinical features, we can all understand that leukocytosis and thrombocytopenia also in half of the patients they have thrombocytopenia. Leukocytosis is present in almost all the patients. Urine analysis will show pyuria, and hematuria is also there in 13% of the patients. Severe proteinuria is present in 21% of the patients. Now the pathogenesis, all bacteria are the culprits. E. coli is the most common bacteria causing emphysematous pyelonephritis in 67% of the cases. Klebsiella is the culprit in another 20%, and miscellaneous bacteria like Proteus and Pseudomonas are culprits in the 10% of the patients. Some patients, the urine culture reports, they show that there was a polymicrobial infections also, including streptococcus and staphylococcus aureus. Then bacteroids and superinfections with candida are also seen. What is the pathogenesis of these emphysematous pyelonephritis? It is because of the high tissue levels of glucose, as all the patients are who have uncontrolled diabetes, and it is the presence of glucose fermenting bacteria we discussed in the previous slide, and because of that there is impaired vascular supply and decreased tissue perfusion, which causes impaired host immunity, and obstruction of the urinary tract contributes to these things, which leads to this florid emphysematous pyelonephritis. Host factors for emphysematous pyelonephritis is poor glycemic control, and some people also give history of low urinary tract instrumentation also, which causes infections leading on to emphysematous pyelonephritis. Pathologies, patients who undergo nephrectomies in desperate conditions, who need the specimens, they reveal multiple abscesses filled with purulent exudates, as we can see. There are cavities. If I can, cut specimen with parenchymal abscesses which are filled with pus, which are seen in the specimens. Now, coming into clinical perspective or the clinical aspect, when should we think of emphysematous pyelonephritis? A patient who is diabetic, females, patients who have signs of urinary tract presenting with fever, flank pain, chills and rigors, sepsis, patients who have poor glycemic controls, patients who have kidney injuries, whether they are acute or chronic, poor response to antibiotics, patients who do not respond to first line or second line antibiotics in 48 hours, we should suspect emphysematous pyelonephritis, especially in diabetic females. Now, what are the differential diagnosis of gas in urinary tract? I have been talking about it's by gas forming bacteria. There is presence of gas in the kidney. What all conditions can cause this gas in the urinary tract? Slides are not being displayed. Okay. One is instrumentation of the urinary tract, whether because of iatrogenic injuries, incidental or catheter insertions. Then surgeries, cystoscopies, transurethral tumor resections. Then patients who have had ileal conduits for carcinoma, urinary bladder, or for any other reason for supplementation of ureter, and then post-ureter sigmoidostomy for after radical cystectomies. Then fistulous connection with hollow vesicles like gut, like vesicovaginal fistulas. Then penetrating trauma or blunt trauma. These all also can cause gas in the urinary tract. So basically we have to rule out these causes before labeling the patient as having emphysema pyelonephritis. Now we can see there is a air bubble in the renal parenchyma. So this is a plain film of KUB. Now this is a cross section of the CT. Sorry, this is a cross section of the CT scan showing. Coming on to the diagnosis part, on plain films we can see a collection of gas. I'll be showing it in this thing. As we can see, there's only on plain. It's not. It's there. We can see that there is gas in the. Excuse me. उसका व्यू चेंज करके उसको सेंटर में नहीं आ सकता. It could be in the renal parenchyma also. So ultrasound is usually the first line modality that we apply for diagnosis of pyelonephritis, and it can give you idea that yes, it could be emphysema pyelonephritis. And the limitations of ultrasound is that it is limited by body habitus, especially in patients who are obese, morbidly obese. The window for renal windows are not sometimes available, and obviously it is less sensitive than CT. Now CT scan is the gold standard investigation for diagnosis of emphysema pyelonephritis. In patients who have preserved renal functions, we'll like to get contrast-enhanced CT scan. In patients who don't have preserved renal functions, whose creatinines are high, we definitely go for non-contrast CTs. Even non-contrast CTs can give you an idea of where the air is in the renal parenchyma, how much loss of renal parenchyma has already been done, and it is definitely the preferred modality. It assesses the extent of involvement. IV contrast can provide information about function, definitely yes. 100% sensitive in the larger systematic reviews. Now this is an image where we can see that the right-sided kidney, almost half of the parenchyma has been replaced by gas. Now classification, why we need to classify this emphysema pyelonephritis. As you can see the figures on the extreme right side of this thing, these are the mortalities. Patients who have class 4 emphysema pyelonephritis, it's almost 50% mortal for the patients. So we need to classify on the initial imaging that my patient is in which category and how aggressive I need to be in these patients. So a class 1 emphysema pyelonephritis is that the gas is only in the collecting system, or it is only a pyelitis. And class 2 is the gas is in the renal parenchyma. Class 3A is that the gas has extended on from the renal parenchyma into the perinephric space, whether it's a perinephric space, is a perinephric fat, or anteriorly into the peritoneum. Then class 3B is gas is in the pararenal space, it has gone beyond the Girota's fissure. So 3A and 3B are similar almost, but the mortality figures are different. If it is limited to perinephric space, it's And class 4 is if emphysematous pyelonephritis is involving both the kidneys or a single kidney in a patient who already has lost one kidney. This is the figure. In this, we can see the arrow marked. It shows that the air is only in the pelviculation system or the pelvis of the right side kidney. So this is the class 1. Class 2, we can see the kidney parenchyma has been involved. The gas has occupied the. In class 3A, there is a perinephric space. The arrow is marked there. It's extending from the renal parenchyma into the perinephric space. Then class B is pararenal involvement. As we can see, it has gone anteriorly also. Posteriorly also, Gerota's fascia has been breached and it has gone into the almost till the parietal wall. This is class 4, as both the kidneys have been involved. So this is the class 4 emphysematous pyelonephritis. Treatment mortality. Treatment and mortality ranges from 11 to 42%. Even this was a meta-analysis which was done in 2007, and patients, which all patients have higher mortality, we can screen out those patients who keep on undergoing conservative managements, patients who have bilateral emphysematous pyelonephritis, patients who have thrombocytopenia at presentation, patients whose systolic BP is less than 90 mm mercury at presentation, and patients whose initial creatinine levels at presentation are more than 2.5 mg per deciliter. Patients who have altered sensoriums at presentation. So these patients have poor prognosis. We should be alert from the very first minute. Now treatment basics. Obviously a patient who is unconscious, who's in shock, has to be admitted. ICU admission, we can always decide whether he needs an ICU admission or not, depending on the initial vital screening of the patient. Fluid and electrolyte correction is to be done. Appropriate antimicrobials. We'll talk about these microbials, antimicrobials, which all antimicrobials, antibiotics we have to use. Then treatment of diabetes is the first and most important thing which has to be done, because it is the most important cause leading to this pathogenesis of emphysematous pyelonephritis. Blood sugars have to be strictly under control, whether with oral hypoglycemic agents or we need to use insulin. Then after the diagnosis, after the initial investigations, we need to relieve obstruction of the affected kidney if it is already there. If it is there because of the stones, because of necrosed papillae, because of any malignancies, it has to be relieved. Then we have, in cases of unilateral disease, we have to establish function of the other kidney. This is important because in desperate conditions, we may need to do a nephrectomy in a patient who is not responding to conservative management. So the function of the other kidney is of paramount importance, and we need to counsel the patient pre-hand whether he will be on a maintenance dialysis after that or his other kidney is functioning well. Then antimicrobials. These are the Canadian guidelines which they have reported high rates of clinical and microbiological cure. But they recommend using aminoglycosides, fluoroquinolones, piperacin, tazobactam, ceftazidime, carbapenems. At least 14 days of antimicrobial therapy is necessary in a patient who has a diagnosed emphysematous pyelonephritis. In our clinical practice, our first line of antibiotic is piperacin, tazobactam, which we use 8 hourly. And in patients who do not respond to piperacin, tazobactam, we switch over to meropenem. By the time we need to switch over, the culture reports are already there, and we can have culture specific antibiotic which can be used. This I have already talked about. Yes, if the patient already has some kind of a stent, DJ stents, Foley's in situ, they have to be replaced immediately, and their tips to be sent for urine for culture, so that to guide us in the further antibiotic course. Then there comes in which all patients we need surgical treatment in emphysematous pyelonephritis. In patients who have obstructions of the pelvic calcium system like stones, malignancies, necrosed papillas, in these patients we can do internal drainage in the form of DJ stenting. or external drainage in patients who are not fit enough to be shifted to OT. We can do bedside percutaneous nephrostomies also. These are done under ultrasound guidance and they are minimally invasive and life-saving procedures. Percutaneous or open drainage of the collections in patients who have class 3 or 3A or 3B emphysematous pyelonephritis in which the collections are outside the renal parenchyma, involving the perirenal or the pararenal spaces. We may need to put in drains, percutaneous drains under ultrasound guidance to take out those pus and gas, or if it is not feasible, not available, then we'll have to do an open drainage of the abscess. In patients who do not respond to these conservative or relatively conservative modalities, they may need desperate emergency nephrectomy or a planned nephrectomy in patients who have total loss of renal parenchyma. Now, this Somani and his colleagues, they did a systematic review in 2008, and they came out with these figures that in patients who have emphysematous pyelonephritis, if only medical management is done, there's 50% chances that we'll lose the patient in due course of time. And 25% patients in which medical management and emergency nephrectomy was done, they also had 25% mortality. Patients who needed only medical management with percutaneous drainage, the mortality came to around 13%, and patients who had medical management with percutaneous drainage and later on elective nephrectomy was done, obviously because these patients were stable enough to go for elective nephrectomy, the mortality rate was only 6.6%. So a conclusion is that fluid resuscitation, aggressive antibiotics, correction of the precipitating factors like obstruction, and early percutaneous drainage with or without elective nephrectomy when indicated gives best outcomes. Complications of emphysematous pyelonephritis, we all know that sepsis, death, and failure to respond to medical treatment, then relapse. Some patients did come back with the recurrent emphysematous pyelonephritis. The infection can extend to the adjoining organs, lungs, bones, vessels, liver, spleen, and skin, causing infections of those organs. Now, this is my last slide before I conclude my talk. Take-home messages: be suspicious in patients who are diabetic and who are females, who present with fever, flank pain, and chills and rigors. Patients who rapidly deteriorate in spite of starting broad spectrum intravenous antibiotics. In these patients, please suspect complicated pyelonephritis which may need surgical intervention. Thank you. Sorry, sir, I think you need a mic.
Thank you, sir, for the talk.
Thank you, Dr. Joda. First of all, we welcome Dr. G.S. Wander, Chief Advisor, And since we are short of time, you see, the only one thing I think the carry-home message is diabetes and pyelonephritis is very, very common. And anybody you see who is having a resistant sort of pyelonephritis, not responding to conventional treatment, probably should be subjected to further investigation to rule out emphysematous pyelonephritis. That is I think my carry-home message for today. Thank you very much. Thank you.
Thank you. It is my proud privilege to introduce our next speaker, although he doesn't need any introduction. But I have known him as family over the years, and he is an excellent academician, clinician, and in spite of all his achievements, he is so humble, which astonishes me. Especially nowadays when students, right after getting admission in MBBS, start behaving all high and mighty. So I'd like to invite on stage Dr. G.S. Wander, DM Cardiology, Chief Cardiologist, Hero DMC Ludhiana, Chairman, Board of Management, Baba Farid University of Health Sciences, Faridkot. He'll be delivering his talk on hypertension guidelines, what is new in 2023.
Thank you, Meghna, for this lovely introduction. It's indeed a great pleasure always to be visiting Bathinda and attending the MAPICON. My good friend Dr. Vitull has always been very, very obsessed, and he starts working on the next MAPICON right away, in fact, after the MAPICON finishes. So it's remarkable his level of commitment to MAPICON. And now that MAPICON has come to this beautiful hall, I think it is only going to move further, and more people are going to reap benefits of the academic sessions that we have in this conference. I have been asked to talk to you about the commonest public health problem that we today face. You all know we have communicable and non-communicable disorders, and as our population is aging, we are having more and more non-communicable diseases, because the average longevity of life of an Indian, any student would like to tell me, males and females, what's the average longevity? Anybody? Okay, there's some inertia. It's 67 years for males and 70 years for females. And when we became independent at that time, it was about 44 years. So significant number of years you can see have been added to the longevity. And the non-communicable diseases, whether it is hypertension, diabetes, cancer, COPD, coronary artery disease, stroke, they are all actually related to age. Of course, they are related to the risk factors that we always enumerate, but they are also related to the aging process. And as we all now are at the anvil of a stage when we know that India is today the most populated country in the world. In April, the UN announced that India has surpassed the population of China. And so what we are talking here essentially is of a very large segment of people who have hypertension, and whatever we will do in terms of control of hypertension in this population, it will have bearing in the larger perspective of the world. There are some aspects of hypertension which are very important for our population. It's responsible for almost more than half of the strokes and 1/4 of coronary artery disease. And recently the global burden for disease actually was a 20-year study which has given us a lot of information regarding the non-communicable disease and so also communicable diseases that affect our country. The contribution of hypertension in terms of CV deaths actually is much higher amongst Indians as compared to the Western population. And if you look at this GBD data in terms of death and disability associated life years due to high systolic blood pressure that happen, actually is much higher as compared to 1990, what we have today. At that time it contributed almost 9% of deaths. Today it contributes almost 16 to 17%. And 4% to 8% increase. So the contribution of hypertension in terms of disability, morbidity, deaths in our population is increasing. And this is what we showed actually in the Indian guidelines of hypertension, which we published, that although in 1990 diarrheal disorders, lower respiratory infections, neonatal preterm birth, these were some of the diseases of an evolving civilization. And today we have diseases like ischemic heart disease, which is the commonest cause of death of an Indian, chronic obstructive pulmonary disease, cerebrovascular accidents. The strokes have come up from 12th to the 5th commonest cause of death. So whatever atherosclerotic diseases that we talk of, actually their contribution towards, as our civilization is getting more and more advanced, we are catching up some of these diseases. Blood pressure, we wrote in an editorial in the Indian Journal of Medical Research recently that hypertension in Indians is not the same as hypertension in others. It starts relatively early in our population. There is a rural-urban divide actually, almost double the prevalence because it's not only a genetic disorder, it is also a lifestyle disorder. What you eat, salt intake, alcohol use, sedentary lifestyle, obesity, fat intake, all these things have bearing. Of course, it overlies a genetic predilection that you have for these polygenic disorders. Hypertension and diabetes are polygenic disorders. But of late, we have seen there is a rural-urban convergence now. The ruralites are almost adopting the same lifestyle as urbanites, and so India is now actually witnessing a new epidemiological phenomenon of convergence of the rural and urban divide that was happening. We know we have syndrome X, the metabolic syndrome X, which is characterized by central obesity. What is the male pattern or the apple type of obesity, which brings in hypertriglyceridemia, insulin resistance, hypertension, and even our dyslipidemia amongst Indians is different from other races. We have more of low HDL and high TGs as compared to high LDL in the other races. So our coronary disease is peculiar, our hypertension is peculiar, and obviously our management methodologies will be different. This is an area in which we have done a lot of work actually here. There is a significant variation of, in winters we have to upregulate therapy and in summers we have to downregulate, because the region in the tropics that we live in, there is wide variation of temperature that we see in the winters and summers. And of course, as I said, the average blood pressure of our population is going on, is increasing. So these are some of the peculiarities actually of hypertension that we have in our country. This is an additional very important factor actually, the environmental pollution that we are seeing today. And environmental pollution has today been linked with the non-communicable diseases, whether it is coronary disease, stroke, hypertension, because what is happening is that these molecules which are less than 2.5 microgram, they are entering through the lungs into our vasculature, and then they are generating an inflammatory process. So anyhow, I think you can see in between even if it is flickering. So what we have today is a significant contribution of this environmental pollution, which you know in a couple of months in India is a very big issue. Salt is a very important factor actually. Eating sugar doesn't cause diabetes. That's primarily, it depends upon what you genetic milieu that you have. But eating excessive salt certainly causes hypertension. And it also causes impairment of response to the antihypertensive therapy. And there was an ICMR study which said actually that an average Indian, through papad, pickles and these salty things that we have, and now this entrance of the fast foods that has happened, we consume 9 to 10 grams of salt, whereas the Western guidelines and so as our own Indian guidelines suggest that one should not have more than 2.5 grams of sodium or not more than 4 grams of salt. So we almost double. We are very high consumers of salt, and salt has a direct link with hypertension. This is a very important slide actually. This comes from the European guidelines on hypertension. And if you will notice, there is a risk, we don't have a risk score of our own, but there is a risk of coronary artery disease. We all know the risk factors for coronary artery disease are hypertension, diabetes, positive family history, obesity, smoking, sedentary lifestyle, stress, central obesity, dyslipidemia. These are the 8 risk factors. But even if someone is harboring the same number of risk factors, we have actually a YY chromosome mechanism by which our risk of having coronary disease is 1.4 times as compared to an average European. And this is because of the thrifty gene hypothesis McCaig gave, who said that our forefathers were actually living in famines. And our body metabolism actually is not able to handle the amount of calories that we are today exposed to. So with the same amount of risk factors, racially Indians have more coronary disease, more stroke, and this data has primarily come from the Western world, where Indians have migrated, whether they have migrated to Singapore, US, to Canada, Australia. World over, heart attacks occur 10 years earlier. So all these risk factors contribute towards occurrence of atherosclerotic cardiovascular disease to a larger extent, with the same milieu, same risk factors as compared. So racially we are more prone to coronary disease and effects of hypertension. This is some data which has come only a couple of months back actually, and we all know hypertension is related to disease, to the age, and as we age, an average adult who reaches the age of 80 years has a 75% lifetime risk of having hypertension. So the prevalence of hypertension increases as we age, and this is what is depicted in this pie chart. And this is data which has come last week only, which shows that today actually almost 30% of Indians have hypertension. Same data in males and females. Only about 30 to 40% of us are diagnosed, about 20 to 35% are treated, and the control levels are dismally low actually. And that is why people are now working in hypertension towards implementation research as to how we know a lot of, we have a lot of knowledge about antihypertensive agents. We know a lot how to manage hypertension, how to diagnose hypertension, how to risk stratify. But the problem is it has not percolated to the grassroots level. The patients, the public has not yet got the benefits. And that is why we in fact gave the Indian guidelines on hypertension in 2019. This is a year when we are going to come up with the next edition of Indian guidelines, because as you can imagine, Indians live differently, our seasonal conditions are different, we eat differently, metabolically, genetically we are different. So obviously we will need to treat hypertension differently in our country. And this is what the classification of high blood pressure we have given actually. Optimal blood pressure is less than 120/80. You keep adding 10 to it to move from optimal to normal to high normal, and keep adding 5 to the diastolic pressure to go from 80 to 85 to 90. Hypertension is defined by the Indian guidelines as a blood pressure of more than 140/90. The American guidelines have lowered this by 10 millimeters of mercury. But world over, whether it is the International Society of Hypertension, whether it's the European Society of Hypertension, Indian guidelines, they all uniformly actually classify or define hypertension as a blood pressure of more than 140/90 diastolic. You can have isolated systolic hypertension, person can have an isolated diastolic hypertension. As we age, our vessels become more and more sclerosed, more and more fibrotic, and so systolic hypertension is a phenomenon of the elderly, whereas diastolic hypertension occurs in people between 30 to 55 years of age. Systolic hypertension is more difficult to treat than it's more resistant actually. And systolic hypertension results in end organ damage, whether it is the eyes, the kidneys, the heart, the peripheral vessels. It affects the target organ damage actually occurs much more with systolic hypertension than with diastolic. But you can add 20 to move from stage 1 to 2 to 3, and add 10 to the diastolic to move from 90 to... So hypertension grade makes a big difference, and this is what I have shown actually last year. The American guidelines came and they have just put it very simplistically. A blood pressure of more than 130/80 is actually stage 1 hypertension. And what we call as hypertension, they are calling it as stage 2 hypertension. So and by this actually there was a lot of criticism, because almost 50% of the population of America actually falls into this category, and they would be defined as hypertension. So that's for another day. But this is the guideline which has come latest actually. Alberto Zinchetti presented in June 23, and I will just talk a little bit in the next 5-10 minutes about these European guidelines, because the topic Vitull gave me is what's the current perspective how we manage hypertension. And this is what they have given actually. They have changed the way we have to think about treating hypertension. It's not just the numbers. Look at the numbers. You move from grade 1, 2 to 3. As I said, add 20 to the systolic and 10 to the diastolic. Isolated systolic hypertension I mentioned, isolated diastolic. But look at the bottom of this actually, this slide. Stage 1 is uncomplicated hypertension, when there are no actually target organ effects. Stage 2 is when there is hypertension mediated organ damage. And stage 3 is when there is cerebrovascular disease. So you will see in the subsequent slides, it's not only the numbers, it is the other risk factors that your patient has. The age that your patient is, more the age, more are the risk of the effects of hypertension, and whether the patient has hypertension mediated organ damage or cardiovascular disorders, that is going to determine how aggressively you are going to treat hypertension. So rather than being just number centric, we today look at the other risk factors that a patient has, like diabetes, obesity, dyslipidemia. These are other factors which can cause atherosclerotic cardiovascular disease. And we also see what are the effects, whether the kidneys have been affected, whether there is proteinuria, whether there is a higher ACR, albumin-creatinine ratio. We look at whether hypertensive retinopathy is there, whether there is, so all this total holistic approach has to be made of the patient, and then you have to make a decision as to how aggressively you are going to treat your patients. This is a beautiful slide actually which is there, which I thought I'll share with you. It talks about the environmental factors, as I said, noise pollution, ambient temperature, air pollution, they all have. And blood pressure we know is dependent on the renin-angiotensin-aldosterone system, the sympathetic nervous system, the endothelins, the arginine vasopressin, all these, the metabolome, all these actually metabolic factors make a difference. In terms of nitric oxide is a vasodilator. We know there was a Nobel Prize given for nitric oxide invention about 15 years back. We know natriuretic peptides have a role, prostacyclin, adiponectin in obese. So all these factors make a difference. Genetic, of course, we know genetics has a great role to play. And we actually published in Nature Communications the association of autozygosity with a broad range, and we showed that there are some markers of hypertension that we can find in genetic population. So having looked at what hypertension is and what is the definition, what blood pressure levels you will count as hypertension, what levels are normal, what are stage 1, 2, 3. Let's see what is the correct method of measuring blood pressure. Because measurement of blood pressure by the medical personnel is somehow given less value, but we today know that unless you will measure something correctly, how will you manage it properly? So blood pressure measurement actually, as has been written in this slide, one should take 3 measurements, take an average of the last 2. The hypertension is diagnosed primarily by measuring blood pressure in the office. And blood pressure should be measured in both the arms. We do not diagnose hypertension solely on the basis of out-of-office blood pressure. As yet, world over, there is no guideline which says that on the basis of a home blood pressure recording you can diagnose hypertension. And this is the correct method how your patient, you should take 3 readings, as I said, patient should be resting, the level of the blood pressure cuff should be the same as the apparatus, the arm should be bare, the legs should be uncrossed, patient should not have had tea or coffee. These are all very small, simple things, but they have a significant bearing because they can increase blood pressure. You can overestimate hypertension in your patients. So the method of hypertension, and this is some work that we did actually, which we published in Journal of Clinical Hypertension, in which we showed that there can be a significant difference between the upper and the lower, between the 2 arms, the right and the left arm. And unless you will measure blood pressure in both the arms, you would not know actually what is the difference. And the arm with the higher blood pressure has to be taken for subsequent readings because that's the true reflection of the person. And in almost 6% of people, you will be diagnosing hypertension, and in the others, you will not be diagnosing unless you take blood pressure in the 2 arms. And if there is a significant disparity between the 2 arms, it tells you that there is atherosclerotic peripheral vascular disease. So there are more than one benefits actually by measuring blood pressure in both the arms. Then you have the postural hypotension in elderly people, in frail individuals. You should measure their blood pressure in a lying and a standing position, because a significant fall can occur due to diabetic autonomic neuropathy or certain drugs like alpha-methyl dopa, clonidine. Some of these earlier drugs actually can also cause postural hypotension. So the measurement devices that we have today are, actually there has been a significant change. The blood pressure measuring device that we were using when we were students was a mercury sphygmomanometer. A mercury sphygmomanometer was invented about 100 years back, and all our life actually we have measured blood pressure in our clinics, in our hospitals with the mercury sphygmomanometer only. But over the years, the environmental side effects of mercury sphygmomanometer has come to... Welcome, sir.
Sorry, sir.
No problem. So over the years, the way we measure blood pressure has significantly changed actually. And now we depend on the automated oscillometric devices. The manual blood pressure is giving way to the automated oscillometric devices, and this is what the mercury sphygmomanometer, the aneroid sphygmomanometers can still be used, and they are actually used in a lot of hospitals. The hybrid devices, the LED and the LCD display devices can be used. But the blood pressure apparatus which is most popular today is the automated oscillometric, which sadly actually depends upon a company's specific algorithm, and that algorithm is not available in the public domain, and that's the fear actually people have, that are all oscillometric blood pressure apparatuses equally dependable? And that's a point actually which is a cause of debate and which is a cause of concern to people. So as I said, class 1 is electronic apparatus. Upper arm cuff is to be used for office and home. The cuffless BP devices are becoming more and more popular. They are more fashionable, and they are going to intrude into our clinical domain in the coming years. But as yet, you can see the latest European guidelines show it's a class 3 indication. So as yet, you are not advised to use the cuff. They might look more attractive, they might look more fashionable, but they are not actually validated for the time being. So the cuffless BP devices are not to be used for recording. And this is actually a very significant change that happened. The Minamata Convention actually said that mercury-free healthcare had to come by 2020. And India is a signatory actually to the Minamata Convention. And India wanted to get away with all mercury blood pressure apparatuses, mercury thermometers 3 years back. But somehow the government of India has extended this because of want of dependable other apparatuses. So you will still see some of the clinics using mercury sphygmomanometers, but I'm sure in the next 2-3 years the mercury sphygmomanometers will only be a thing of the museums, and they will not be used because of the environmental side effects of mercury. It's a collective toxin, and actually Minamata is a place in Japan where multiple people died because the mercury does not get denatured, and it would go into a pond where it was taken up by the fish. Those fish were consumed by people, and children were born with multiple musculoskeletal abnormalities. Something like this happened in Kodaikanal in down south also. And so mercury apparatuses people are scared of, people don't want mercury apparatuses, and today we have this issue as to what to do because the manual devices are dependent on the mercury. And so we developed actually with IIT Ropar, we developed this new digital apparatus, what we called as the Oscar D, a mercury-free digital oscillatory sphygmomanometer. And today actually this digital apparatus is being widely used by various places across the country. And this data actually we published. This is a second new work that we are at present very keenly and very closely doing. We are trying to develop a mercury-free sphygmomanometer which we call as merc-free. And we have published in scientific reports the whole concept, hardware, development and clinical trials we have done on this Galinstin based mercury apparatus. Now Galinstin is half as viscous as mercury. So the size of the apparatus is going to be double the size of a mercury apparatus, which will also help you to make it more easy for your eyes to see. And we are at present doing actually clinical studies on this. We have already published this actually in scientific reports. We have a website and we have filed for a patent which we have already actually done 2 years back, and hopefully this patent will come and then we will be using Galinstin as the material in place of mercury because it does not have toxic effects. This is a new type of blood pressure apparatus which is being used. It was used in the SPRINT trial. The SPRINT trial is the most popular trial which showed whether more diligent effective control of 120/80 is more effective than a blood pressure control of 140/90. The SPRINT trial actually showed that in non-diabetic individuals, if you control their blood pressures more effectively, you reduce the target organ damage on the heart, the kidneys and the peripheral vessels. So this apparatus actually does away with what is called as a white coat effect. Whenever a patient walks to in our clinic and we are recording their blood pressure, the blood pressures are a bit high because they are a bit scared of us. So this is actually recommended by the Canadian guidelines also. This is going to become more popular, although it is more expensive. This blood pressure apparatus starts recording the blood pressure when a person is sitting alone in a room. There is nobody attending after a gap of 3 minutes. So automatically the person has rested for 3 minutes. It takes 3 readings which are 1 minute apart, and it gives you an average of the second and the third reading. So in that sense it is felt that this is probably the best BP apparatus which is at present available, but it's a bit expensive. As I said, the wearable cuffless BP monitoring devices, if you will look at the last line from the guidelines, there is no data to confirm that these devices result in improved patient outcomes, and so we as yet do not advocate the use, although we are sure they will come up in the next couple of years. Now, one other conceptual thing which has happened in the management of hypertension in the last couple of years is we are giving more and more respect to the home blood pressure. Ambulatory blood pressure is expensive, it is cumbersome, it is not very convenient for the patient, but the same apparatus, since we have moved from a mercury, a manual apparatus, to an automated oscillometric device, the same device patient uses at home, because we know in the home, person is spending most of the time there, and we want a combination of the office blood pressure reading, which is generally a bit higher than the home blood pressure reading. And so if you will look here, the home blood pressure criteria for diagnosing hypertension is 135/85. This is from our Indian guidelines. Actually the same in 2019, the same values have been given by the European guidelines in 2023. If you are having an ambulatory blood pressure is a device which is actually like a halter which records the patient's heart rate. An ambulatory BP apparatus is a device which is applied on the person. The person carries with him, goes home, every 20 minutes it keeps recording, and after 24 hours you get a whole chart of the blood pressure readings, because we know it's not only the office blood pressure, but the night time blood pressure is related to target organ damage. The early morning rise, we know. Most strokes, most heart attacks, they occur in the early morning. The morning erections, it's all because of catecholamine excess, which happens from 4 to 10 a.m. So it's the morning time when our body metabolism is such, when the blood pressure rises and when most of the strokes. So the control of early morning rise of blood pressure, control of night. See, most of us will drop our blood pressure by 10 to 20 percent, whatever is our blood pressure in the daytime. There are some people who are non-dippers. We call them non-dippers because their blood pressures do not fall at night. And it's the non-dippers who have more target organ damage as compared to the dippers. So we are today looking at the whole perspective. What's the blood pressure in the office? What's the blood pressure at home? What's the blood pressure at night? What it is in the early morning? Because we want to effectively control blood pressure throughout the 24 hours. And this is what the guidelines today say, that you may not use it for diagnosis of hypertension, which still you will use the office, but you will use it to diagnose white coat hypertension. White coat hypertension means nothing but the blood pressure goes up when we are recording in our clinics. At home the blood pressure is actually normal or lesser. What is masked hypertension? It is opposite of white coat hypertension. In the clinic the blood pressure is not high, but at home, as the name suggests, it is getting masked. At home the blood pressure values are high, and this is, mind you, more dangerous than sustained hypertension also, because doctor will not treat it and the target so we want to know which of our patients have masked hypertension, which of our patients have white coat hypertension, what is the total level of control. So this is a precaution which is very important actually, that you should ask your patients to monitor blood pressure for 7 days, never to react to one blood pressure reading. It's a very common problem. Patient records the blood pressure, finds it fluctuation. One of my teachers used to say fluctuation is a sign of life. Anything that is not fluctuating is dead actually. And blood pressure, you know, varies by 30 to 35 millimeters of mercury if you record it on an ambulatory blood pressure recording. So variation, you have to tell your patients, is actually a sign of life. They will record morning, evening for 7 days, have an average of actually 14 readings, and that is how you will use the home blood pressure recording to the best method. This is some work actually which we did. It's a very huge study, the India Heart Study, which we published in the Journal of Hypertension. As you can see, 18,000 patients were taken in this study. Self blood pressure measurement was done. It was compared to the office blood pressure. And then we looked at what is the prevalence of white coat hypertension and masked hypertension. And you'll be surprised to know that almost 15% people have white coat hypertension. And about 20% people have masked hypertension. And this underlies the value of not depending only on the office blood pressure, but using the home blood pressure and then having a collective opinion. And this is one of the buzz actually, most of the latest guidelines, that we give more and more respect to the home. Just as diabetologists give a lot of value to the home blood sugar values, we have started now giving more and more value to the home blood pressure recordings for these two reasons, that white coat hypertension and masked hypertension are not very uncommon. And this is a work actually we published in the Indian Heart Journal, in which we looked at the awareness of actually home blood pressure value amongst physicians in India. And what we found was that only 30% of the people actually were using home blood pressure. And these numbers need to be encouraged by you and me. And patients, actually the industry needs to develop better blood pressure apparatuses which are available at home. And so that we are able to, and also as doctors, we need to know what are the criteria for diagnosing hypertension in the office. Only 3% of us could answer it correctly, and what are the reasons. And so these are some of the reasons why it is being used less often. We also looked at this factor at an Asian level also. And most of the Asian countries participated in this. Actually, we published in Hypertension Research last year. And we found, as you can see, most of the Asian countries fare similarly in terms of the percentage of people who are using home blood pressure. And this is, as I said, this needs to go up because there is a lack of understanding of value, there are lack of guidelines, and of course there is concern about the reliability of the home pressure. Ambulatory blood pressure apparatus, we do not advocate for routine use. It is only to be used for diagnosis of nocturnal blood pressure phenotypes. And it can be used in resistant hypertension, but otherwise it has a limited applicability because of the cost factor. And why complicate a thing which can be done very easily, which can be done by you in the clinic and also can be done in the office. So these are some of the reasons. So coming to office blood pressure for diagnosis of hypertension, home blood pressure primarily for maintenance of therapy and to know how your patient is responding, and ambulatory blood pressure for difficult cases who have nocturnal rise, who have had a complication of hypertension, and who have resistant hypertension. What is resistant hypertension? Resistant hypertension is when you have used 3 drugs for treatment of hypertension. One of that has to include a diuretic. So obviously it will include a RAS blocker, an angiotensin receptor blocker, or an ACE inhibitor. It will include a calcium channel blocker and a diuretic. And if still the blood pressure does not come below 140 by 90, that is called resistant hypertension. The whole philosophy of treatment of hypertension is opposite of epilepsy. An epileptologist wants to use higher dosage of a single drug. In hypertension, you use synergistic effects of multiple drugs which act at different levels. So you use lower dosages of multiple drugs conceptually for management of hypertension, and you combine so that your patients have less side effects and there is a synergistic effect between these drugs. This is a very important slide actually, which conceptually gives you that you have to look at the risk of an individual. We are not treating numbers. We are treating human beings. We are not treating labs. After COVID, this bad habit has come. We started treating labs to a larger extent. Look at this. You need to form a holistic opinion of your patient. Of course, values are important. So you have the value, whether it is 130, 140, 160, whatever, the risk increases. Actually, it goes towards the red. If the person has additional risk factors, the risk further increases. And as I said, more the age, more the risk factor, as you can see in the bottom of this slide. But very important is whether your patient has hypertension mediated. Those who already have effects, they are at a higher risk and you will need to be more aggressive in them. I'll just spend 1 or 2 minutes actually. This is a score system. The sex, males have obviously more coronary disease than females. As we age, as I said, more blood pressure of course. Smoking is a very important risk factor, and LDL cholesterol. So someone who has multiple of these risk factors will obviously have more coronary disease and more effects of hypertension. And this is what we wrote actually in an editorial in Journal of Human Hypertension. The Western guidelines have now bring in coronary risk prediction score. We do not have a risk prediction score of our country. But what we actually in the end said is the age, sex, lipids, smoking habit and diabetes. Someone conceptually who has a multiple of these risk factors is at a greater risk of having hypertension. Be more aggressive. Treat their blood pressure more effectively. Treat it, bring it down to actually better levels so that you can prevent the target organ damage. These are some of the newer actually risk factors which we are today looking at. They may not be as important as the 8 risk factors that I enumerated initially, but the resting heart rate. It's a very important parameter of longevity of life. People who have higher heart rates, exercise brings down the heart rate. I was reading somewhere the famous tennis star John Bogg had a heart rate of 38. So as you exercise, your heart rates come down because your cardiovascular system becomes more effective. People who are physically deconditioned, they have faster heart rate. So heart rate, low birth weight, frailty, sedentary lifestyle, uric acid is now linked, LPA levels. LPA level is what? LPA is a genetic risk factor. It's a risk factor which is peculiar to South Asians. And this is actually some data that we published many years back in Lancet actually. And we found that Indians who had migrated to England, they had higher LPA levels than the Caucasians there. 2 things they had higher LPA levels and higher insulin resistance syndrome. We are a capital of diabetes, you all know. So these are the 2 risk factors which bring in this peculiar early occurrence of coronary artery disease. So these are all risk factors. Heart rate I have just dwelled upon. And these are sleep apnea, very important, very peculiar cause of actually resistant hypertension. People who have these autosomal disorders like rheumatoid arthritis, SLE, they have greater risk of hypertension effects. People who have NAFLD, chronic infections, migraine, depression, erectile. So this is what actually the hypertension mediated organ damage. You'll do a simple ECG. If you find on ECG there is left ventricular hypertrophy. You'll do an echo. If you find the LV mass is increased. You do a urine routine and you find the albumin creatinine ratio is more than 30. You put them into CKD grades. Simple blood pressure measurement in the upper arm and the lower arm to find atherosclerotic disease and the ankle brachial index, which you should do in your clinics. Retinopathy, of course. And this is actually a later stage. When your patient already has CVA, has had a heart attack, has heart failure, has renal failure, by this time actually a lot of the battle is already lost. You want to actually pick up your patients at this stage, or rather even before this, when they do not have any of these complications. So I'll just touch for a minute or so on our Indian guidelines. These are some of the factors we have given as to what contains more salt and what contains less salt, because we as Indians, as I said, take a lot of salt. And this is a very simplistic algorithm of treatment of hypertension which we have given in the hypertension guidelines. Younger people less than 55 use A. What is A? ACE inhibitor or a ARB, angiotensin receptor blocker. Younger people have a high renin hypertension. Older people have a volume related hypertension. So in older people you will use a calcium channel blocker or a diuretic. The conventional antihypertensives were beta blockers and diuretics. But because of their metabolic side effects, the newer antihypertensive agents, the RAS blockers, the ACE inhibitors or ARBs and calcium channel blockers are. So step 1 is this. Step 2 is you will combine A with C or D. We primarily combine A with C because we know a calcium channel blocker with an ARB or an ACE inhibitor. We never combine an ACE inhibitor with an ARB. And we today know that the best combination is either an ACE inhibitor or an ARB in combination with a calcium channel blocker. Which are the common ACE inhibitors? Ramipril, captopril. Which are the common ARBs? Losartan. So these are candesartan. So these are some of the agents that you will be. Step 3 is you combine A with C with D. As I said, diuretic, if it is not the second drug to be combined, it should be the third drug in combination. And as I already said, the concept is to combine multiple drugs. And the pathway trial showed us that the best agent as a fourth add-on agent is a mineralocorticoid receptor antagonist, spironolactone. The pathway compared actually beta blockers, something that was so high up in the treatment of hypertension, today doesn't even figure amongst the 3 lines. Beta blockers are to be used in very selective indications. Young people with fast heart rate, those with migraine, those with heart failure, and those with coronary artery disease. They are the people where you will be using beta blockers. Otherwise, beta blockers as antihypertensive agents have receded in their value, whereas they have gained in their value in terms of heart failure medication. This is from the American guidelines, which shows these are the agents that you use as first line agents for treatment of. I have already dwelled upon the targets. The SPRINT trial has shown that we try to reduce blood pressures greater. There is a J-shaped curve. If you bring blood pressures to below 120/70, the risk of coronary events, cerebrovascular events increases. So you do not, the European guidelines have given the lower limit also up to which you should reduce. Young people, you try to achieve lower pressures. In a frail, thin, elderly individual where there is fear of postural hypertension, obviously you will not be that aggressive. This is what we have given the Hope Asia Network, some of the things that you need to do. As I said, the awareness, treatment and control rates you can see in scientific reports published this year itself are so dismally low in our country, and this is where we need to work at actually if we want to control. And this is an editorial in, this is actually a review article in Lancet Regional Health which actually shows that although in the last 20 years the levels of control have gone up from about 15% to 22%, but they are still very low. So that's the reason this implementation research, actually there is more emphasis, and we are now looking at greater task sharing. Rather than limiting blood pressure control to doctors, let's involve nurses, let's involve paramedics, let's use the electronic gadgetry and see extended period prescriptions. And this is some of the works people have done actually on involving staff nurses and others. This is an editorial. I'll end here with 2 important remarks which I think should leave some mark on the minds of the students. To achieve improved control of hypertension, the country should adopt and enforce hypertension screening and diagnosis programs on a massive scale. This is something what we wrote actually in an editorial in Circulation, which is a very high impact factor journal. And another quote from another editorial that we published in the European Heart Journal, where we said protocol-driven standardization of treatment regimens is important. Make it as simple as possible for people. As we just discussed, Younger people use ACE inhibitor or ARB. Elderly people use calcium channel blocker. Combine A and C. If not, then combine A, C, D. If still not, then combine a MRA. So that sort of an approach has to be developed. And India today has actually started the India Hypertension Control Initiative. And we are lucky actually in our institution to start this on a national basis as the first private sector hospital, which we have called as Hamara program, Hypertension Awareness, Management and Risk Assessment program. And we are currently actually very deeply engaged in this kind of work, where we can control blood pressure more effectively in our city. Almost 50% people we have screened in the last couple of years, because we have to actually work towards the national program for prevention, control of cancer, diabetes. This is a program which was started in 2010. Earlier we used to have National Malaria Eradication Program, Tuberculosis Control Program, because we were dealing with communicable diseases. As our population has aged, the government of India today realizes that we need to handle these non-communicable diseases because they are responsible for mortality of a larger number of people, and the goals are to reduce CVD deaths by 25% and to reduce the prevalence of hypertension by 25%. Thank you.
Thank you, sir. Only Dr. Gurpreet Singh Wonder could make even guidelines interesting. Thank you for gracing us with your presence. I apologize to all of you for the disco effects of the screen. Even the screen got intimidated by the presence of such stalwarts in the auditorium today. We shall be fixing it during the course of our inaugural ceremony. We are now starting the inaugural ceremony, and I request Dr. Akhilesh Pathak, Dean Academics, AIIMS Bathinda, to deliver the welcome address.
So our worthy director, Dr. D.K. Singh sir, Dr. Rajiv Sood sir, Vice Chancellor, Baba Farid, University of Health Sciences, Dr. Neil Garg, Chairman, MIDV Punjab, other dignitaries, and the most important, the respected delegates of MAPICON. A very warm welcome to all the stalwarts, physicians of Punjab who have come here to participate in this 4 days conference of MAPICON. And I would like to congratulate Organizing Committee for organizing this wonderful academic feast in AIIMS Bathinda. So we are always thankful to our worthy director, Dr. D.K. Singh sir, who is having exceptional vision and leadership for the AIIMS Bathinda, and always happy to host such kind of conferences and other academic activities in our institute. I am working with Dr. Sir since beginning, and I have observed that Sir always take decision in favor of the institute, and he is always worrying about to provide the maximum benefit to the people who are coming for the treatment and for the various purposes in our institute from the Punjab, Haryana, Rajasthan or nearby places. Sir planning and implementation is various aspects for the upliftment of the institute, whether it is in the area of academics, recruitment, or creating large amount of the hospital facilities are exceptional. And that is why we can proudly say that the AIIMS Bathinda is far, far ahead from our other contemporary AIIMS in all areas, especially in patient care, academic activities, and high level of the standard of medical education. The Director Sir has already started MDMS in all specialties, and from the last session he has also started the DM and MCH courses in 7 different branches. So almost all courses we have already started. And recently the sir has also established the cardiology and CTVS department. And here I would like to share some of the data which we have achieved as a milestone in last 1 and 2 months only. So our cardio CTVS department, they have already done 45 breathing heart CABG surgeries, 15 pump cases, 5 PDA closure of 2 to 5 weight children who were not able to survive. They have already done 5 PDA closure cases. Our cardiology department, they have also done within last 1 month of the establishment of our cath lab, 35 angioplasties has been done. Only yesterday there was very complicated procedure was done by the cardiology team with rota ablation therapy. They have also done 10 pacemaker surgeries, 5 device closure with ruptured sinus of Valsalva. So that was one of the complicated surgery that was done in last week, and different ASD and PDA closure they have done. So this work has been done under the guidance of Dr. Sir, who is continuously working since last many months to establish all these departments, whether recruitment of the faculty, whether recruitment of the supporting staff, whether hiring the procurement and the other things to establish these departments. And now we can see the fruits, and the people of our Malwa area, they are getting benefit from all these. So here I'd like to thank you, sir, for guiding us and leading from the front. Long back, MAPICON 23, it was planned to held in AIIMS Bathinda, and the organizing committee met with our sir, and it was allowed this time to held in our institute to foster a culture of collaboration and excellence within our state. Organizing such a huge conference, it requires planning, dedication and commitment of the organizers to make it successful. And we all can see here that Dr. Vitull Gupta and his organizing team, they have done this in an excellent way. I hope this MAPICON, it will update your knowledge about the recent advancement in the treatment of various critical diseases. I request all delegates to actively participate in the various sessions, engage in discussions, take some notes, ask questions and participate fully during the discussion, and follow up with contacts made during the event. I am sure that the MAPICON is going to be a grand success, and it will help you all in sharing their wonderful newfound knowledge and insights with colleagues and peers that can help reinforce and extend the impact of the conference on their professional growth. Thank you once again, all the stalwarts and speakers, for participating in MAPICON in AIIMS Bathinda, and I again welcome you all in our campus for some nice memories. Thank you.
Thank you, sir. I now invite Dr. Vitull Gupta, Organizing Secretary MAPICON, to deliver the MAPICON report.
So good afternoon, friends. So I am really very happy that MAPICON has been shifted to AIIMS Bathinda, because it gives us a great academic, you can say, atmosphere. AIIMS name is a brand name, and anything associated with AIIMS has to be academically great. So I must thank in the beginning Professor Dr. D.K. Singh for giving us the opportunity to organize MAPICON in AIIMS Bathinda. So this is our 10th conference, and it takes great mentorship from Dr. G.S. Wander to sustain such a long journey. And we have announced 1 year in advance our organizing 11th MAPICON also next year, and for that we will require the assistance, help from Punjab Medical Council. Dr. Ravi Bansal is here, So I will request him to impress upon Punjab Medical Council to award us the credit hours 1 year in advance, because they are routinely awarding this about 2 weeks or 3 weeks before. So I must appreciate the Punjab Medical Council for giving us the hybrid approval. This conference is being held on hybrid mode thanks to our Health Minister, Dr. Balbir Singh. He was to come today as chief guest, but as all politicians have some extra responsibilities, he was in Vidhan Sabha. Today there was session in Vidhan Sabha, so he couldn't come. He has promised to visit MAPICON tomorrow. So to start with, I am thankful to all the dignitaries, Professor Dr. Rajiv Sood, Vice Chancellor, Baba Farid University of Health Sciences, to accept our invitation to grace this occasion, Dr. P.S. Brad, Dr. Ravi Bansal as the Chief Observer for Punjab Medical Council. So I think you had a great impression coming down and we get the approval from Punjab Medical Council. So Dr. Gurpreet Wander is instrumental in each and everything what I do from the very first day of my college in 1978. So I am really very honored and proud to have a friend, mentor, my senior in my medical career. So I am not forgetting the contribution of Mr. Neil Garg, who is Chairman, Medium Scale Industries, to help us in every way since we are organizing MAPICON. And our organizing committee comprising of Dr. K.K. Goyal, Dr. Mangat Ram, Dr. Ashok Goyal, Dr. K.K. Noria, and the organizing committee members from AIIMS Bathinda, who has given us unconditional, unparalleled support in organizing this event, heading by Dr. Rajiv Gupta, Medical Superintendent, Dr. Akhilesh Pathak, Dean Academics, Dr. Rakesh Kakkar, who is heading the Community Medicine Department, and above all, Professor Dr. D.K. Singh, who was instrumental in giving us the permission to organize this in AIIMS Bathinda. So I am really indebted to my friends, you can say non-medical organizing committee in form of Mr. Anil Pola, Ashwini Malhotra, and Kunal Sharma. So with this, I encourage you to avail the early bird registration concession and register for next year. That will be a great help. Last year we had about 150 registrations in early bird, and this time, because it is being held in AIIMS Bathinda, we expect much more people will have confidence in us that we are organizing this conference in AIIMS Bathinda. So I think MAPICON is growing from one-day conference 10 years back now to 4 days conference, which is the largest conference. Even APICON, which Dr. Gurpreet has organized in Punjab for the very first time in 2014, that is 3.5-day conference, and we are organizing 4-day conference with all the help from the faculty. Dr. Ravinder Garg is here, whose almost all PGs are presenting papers. So I am very thankful to you, sir, for participation in MAPICON since the very first day. So I am thankful to our delegates as well as the faculty who has come all the way from different parts of Punjab and India to deliver lectures and make MAPICON an academic feast. Thank you very much.
Thank you. For the lighting of the lamp, I invite on stage Dr. Rajiv Sood, Vice Chancellor, Baba Farid University of Health Sciences, Faridkot, Dr. D.K. Singh, Director, All India Institute of Medical Sciences, Bathinda, Dr. Gurpreet Singh Wander, Chairman, Board of Management, Baba Farid University of Health Sciences, Dr. P.S. Barad, Member, Board of Management, Baba Farid University of Health Sciences, Dr. Ravi Bansal, and Mr. Neil Garg, Chairman, MIDP, to kindly join us on this stage. I request Dr. Akhilesh Pathak, Dean Academics, All India Institute of Medical Sciences, and Dr. Rajiv Gupta, Medical Superintendent, All India Institute of Medical Sciences, to kindly join us on the stage for the lighting of the lamp. I request Mr. Neil Garg to kindly stay back on stage and address the audience.
Respected Dr. Rajiv Sood, Vice Chancellor Baba Farid University, Dr. D.K. Singh, Director AIIMS, Dr. Wander, Chairman Management Board Baba Farid University, entire Organising Committee, सब तो पहला तो तुहानू सारिਆਂ ਨੂੰ मुबारकबाद कि ਅੱਜ 10ਵੀਂ ਜਿਹੜੀ मैपीकॉन कॉन्फ्रेंस है वो एम्स ਦੇ इस ऑडिटोरियम ਦੇ ਵਿੱਚ हो रही है। और मैं स्पैशल थैंक्स अदा करना चाहांगा डॉक्टर वितल गुप्ता का जिन्होंने मैनू यह मान बख्शिया तो इस इन्नी प्रस्टीजियस स्टेज के उत्ते तुहाडे नाल रूबरू होने का। मैं लगातार देखा कि डॉक्टर वितल गुप्ता तो उन्होंने टीम जिस तरीके नाल एफर्ट्स करते हैं, मैनू अज भी याद आ कि ऑनलाइन क्रेडिट आवर्स का कुछ चक्कर से और डॉक्टर वितल गुप्ता लगातार उसके लिए एफर्ट्स करते सी ताकि पार्टिसिपेंट्स ने जो इतने फिजिकली अटेंड नहीं हो सकता जो बाहरों भी अटेंड करते, क्योंकि इस मैपीकॉन की जी क्वालिटी है वो विश्व पद्धर की जिस तरीके के तुहाडे कोल स्पीकर्स ने, जिस तरह डॉक्टर वांडर बोल रहे थे, मैं उन्होंने कह भी रहा सी, मैं कि डॉक्टर वांडर जो तुसीं बोलते हो ना साडे वर्गे अनपढ़ बंदियां नूं भी समझ आता है कि स्टडी है की है। तो सो मेरा कहने का मतलब है कि बड़ा पार एक्सीलेंट जी कॉन्फ्रेंस हैगी है। तुहानूं सारिआं नूं एक बार बहुत बहुत मुबारक। एक गुजारिश करनी चाहांगा इस मंच तो कि तुसीं लगातार अकैडमिक इशू ते डिस्कस करदे ही हो, जो मैडिकल साइंसिस की इंप्रूवमेंट है, तुसीं अपनी रिसर्च अपना पेपर वर्क अपना जिहड़ा हैगा पोस्टर प्रेजेंट करदे हो। एक बेनती जरूर है कि अज जिहड़ा मैडिकल ट्रीटमेंट है वो बहुत कॉस्टली हो गया। आपदी रिसर्च दे विच, आपदी प्रेजेंटेशन दे विच ते ट्रीटमेंट दे विच एक कॉस्ट इफेक्टिवनैस जरूर कंसीडर की जाए ताकि भले अज जी नवी रिसर्च आ रही है कॉस्टली है पर वो शख्स भी मतलब ट्रीटमेंट का हकदार हैगा जो बहुत ज़्यादा महंगा जो ट्रीटमेंट है वो अफोर्ड नहीं कर सकता। जब इस दे उत्ते भी कुछ वर्क ऑन हो सके तो मैं समझदा सोसाइटी का बहुत बड़ा फायदा होगा। इन्हां शब्दों के नाल एक बारी फिर सबका बहुत बहुत धन्यवाद। थैंक यू।
Thank you, sir. I now request Dr. P.S. Barat, Member, Board of Management, Baba Farid University of Health Sciences, Faridkot, to kindly address the audience.
Vice Chancellor Sahab, Director AIIMS, Dr. Wander Sahab, Dr. Ravi Bansal ji, te Udvante Sajano, te respected and dear medical students. आज डॉक्टर वितुल ने बड़ा अच्छा उपराला करके इस मैपिकॉन का 10वां अध्याय चालू किया और जिहदे असीं दौरान 3-4 दिन जिहड़ा चलेगा और इस सारे लिए असीं सब तो पहला डॉक्टर वितुल की अणथक निरंतर कोशिशों के लिए उन्होंने मुबारकबाद दिंदे हैं कि उन्होंने एपीकॉन ते मैपीकॉन के मैप ते बठिंडा नूं मूरली कतार विच लिया खड़ा किया। इस दे लई ओह ते उन्हां दे सारे सहयोगी मुकम्मल वधाई के पात्र ने ते जिहड़े जिहड़े भी उन्होंने सहयोग दे रहे हैं उन्होंने भी हौसले इस गल दे नाल बुलंद होंदे ने। और मैं समझदा बतौर आई सर्जन साडा योग फिजिशियन जिन्ना दे इहदे विच नहीं हुंदा पर सारिਆਂ ਦਾ रोल हुंदा लाइफ स्टाइल डिजीज़ अज साडी सारी ह्यूमैनिटी नूं कन्फ्रंट कर रही हैं, बी इट डायबिटीज़, बी इट हाइपरटेंशन, बी इट एनी मोर ओबेसिटी, सारिया डिजीज़ जिहड़ियां कन्फ्रंट करदियां ते इदां दी कॉन्फ्रेंसिस जिवें इस सरकार की भी दिशा निर्देश है इस बड़ा लंबा जांदियां ने इस मसले नूं हल करने लई कि सोसाइटी नूं सेहतमंद किवें बनाया जाए ते इलाज लोकां दी जेब दे विच किवें लिआंदा जाए। वड्डे वड्डे हॉस्पिटल प्राइवेट हॉस्पिटल खुल रहे हैं जिहड़े कि क्यूरेटिव क्योर करते हैं, प्रिवेंटिव क्योर की समाज में बड़ी घाट है। ਉਹ ਘਾਟ ਨੂੰ ਪੂਰਾ ਕਰਨ ਲਈ ਪ੍ਰਾਇਮਰੀ ਪੱਧਰ ਤੇ ਸਰਕਾਰੀ ਇਦਾਰੇ ਉਪਰਾਲੇ ਕਰਦੇ ਨੇ ਤੇ ਜਨ ਚੇਤਨਾ ਪਬਲਿਕ ਅਵੇਅਰਨੈਸ ਬੜੇ ਵੱਡੇ ਮੁਹਾਜ਼ ਦੇ ਉੱਤੇ ਤੋਰਨ ਦੀ ਲੋੜ ਹੈ। ਔਰ ਇਸੇ ਦਿਸ਼ਾ ਦੇ ਵਿੱਚ ਮੈਂ ਸਮਝਦਾ ਮੈਪੀਕੌਨ ਦਾ ਬੜਾ ਵੱਡਾ ਯੋਗਦਾਨ ਹੈ। ਆਲ ਇੰਡੀਆ ਇੰਸਟੀਚਿਊਟ ਬੜਾ ਵੱਡਾ ਯੋਗਦਾਨ ਪਾ ਰਿਹਾ। ਬਾਬਾ ਫਰੀਦ ਯੂਨੀਵਰਸਿਟੀ ਜਿਹੜੀ ਕਿ ਸਾਰੇ ਪੰਜਾਬ ਦੇ ਹੀ ਮੈਡੀਕਲ ਅਦਾਰਿਆਂ ਦਾ ਨਿਯੰਤਰਣ ਕਰਦੀ ਤੇ ਦਿਸ਼ਾ ਨਿਰਦੇਸ਼ ਕਰਦੀ ਹੈ ਕਿ ਕਿਸ ਤਰ੍ਹਾਂ ਦੀ ਖੋਜ ਕੀਤੀ ਜਾਵੇ और उस खोज नूं लोकां लई लाहेवंद किवें बनाया जाए। ये सारे उपराले इत्थे सिर जोड़ के फैसले करन दी ते इस नतीजे ते पहुंचण दी लोड़ है। और बहुतियां लंबे गल्लां ना करदा होया मैं डॉक्टर वितुल नूं ते इस ऑर्गेनाइजेशन के सारे प्रबंधकां नूं एडा सफल आयोजन करन दे लई हार्दिक ਵਧਾਈ दिंदा। धन्यवाद।
Thank you, sir. I now request Dr. Ravi Bansal, Member Punjab Medical Council and Observer for MAPICON, to kindly address the audience.
Dr. Ravi is the most important person in this conference, so I am all out to impress him.
Respected Director Sahab, AIIMS ਦੇ ਸਾਡੇ Vice Chancellor, Dr. School, our very great personality of Punjab, Dr. Wander, very prominent eye surgeon of the Punjab and national level, Dr. Brad, and dignitaries and the students and the other people. ਅੱਜ ਸਾਨੂੰ ਬੜੀ ਖੁਸ਼ੀ ਦੀ ਗੱਲ ਹੈ ਮੈਨੂੰ ਕਿ ਅਸੀਂ ਯੂਜ਼ਲੀ ਜਦੋਂ ਜਾਂਦੇ ਹਾਂ DMC ਲੁਧਿਆਣਾ ਦੇ ਵਿੱਚ ਹੀ ਜਾਂਦੇ ਹਾਂ ਲਰਨਿੰਗ ਕਰਨ ਲਈ, ਜਿਹੜੀ ਐਕਚੁਅਲ ਲਰਨਿੰਗ ਹੁੰਦੀ ਹੈ ਜਿਹਨੂੰ ਅਸੀਂ पंजाब मेडिकल काउंसिल तो क्रेडिट आवर्स देने हैं क्योंकि जिन्नियां भी CMEs पैरीफरी ते होंदियां सी डिस्ट्रिक्ट हैडकुआटर्स ते होंदियां जिहड़ी उन्हां दी क्वालिटी ऑफ एजुकेशन है ते कैरी होम मैसेजेस ने बड़े घट होंदे ने। बट DMC तो बाद अज मैनू मैडिकल कॉलेज फरीदकोट ते उस तो बाद अज एम्स बठिंडा देखा मैं फर्स्ट टाइम देखा ऑडिटोरियम। इट्स अ वंडरफुल प्लेस। आई थिंक दिस इज द बेस्ट वेन्यू ऑफ द Southern Punjab for the learning. It's a wonderful place. Please give big applause to Dr. D.K. Singh for this great achievement. Dr. Vitull ने काफ़ी मेहनत की है। मैं पिछले 2 ਸਾਲ ਤੋਂ ਦੇਖਦੇ ਹਾਂ ਕਿ ਮੈਡੀਕਲ ਐਜੂਕੇਸ਼ਨ ਤੇ ਹੈਲਥ ਦੀ ਕੁਆਲਿਟੀ ਨੂੰ ਇੰਪਰੂਵ ਕਰਨ ਲਈ he is the only person from this area who is consistently putting his efforts. ਲਗਾਤਾਰ ਉੱਥੇ ਆਪਣੇ ਵਿਊਜ਼ ਦਿੰਦੇ ਨੇ, ਆਈਡੀਆਜ਼ ਦਿੰਦੇ ਨੇ. ਫੋਰ ਐਗਜ਼ਾਮਪਲ ਹੁਣ ਪੰਜਾਬ ਮੈਡੀਕਲ ਕਾਉਂਸਲ ਦੇ ਇਲੈਕਸ਼ਨਸ ਹੋ ਰਹੇ ਨੇ ਤਾਂ ਅਸੀਂ ਉਸ ਵੀ ਦੇਖ ਰਹੇ ਹਾਂ ਕਿ ਬਹੁਤ ਫੇਅਰ ਤਰੀਕੇ ਨਾਲ ਜਿੰਨਾ ਕੰਮ ਹੋਣਾ ਚਾਹੀਦਾ ਸੀ ਉਸ ਲਈ ਇਹਨਾਂ ਨੇ ਹੈਲਥ ਮਿਨਿਸਟਰ ਨੂੰ ਵੀ ਆਪਣੀ ਦਿੱਤੀ ਹੈ ਰਿਕੁਐਸਟ ਤੇ ਸੁਜੈਸ਼ਨਸ ਕਿ ਕਿਸ ਤਰੀਕੇ ਨਾਲ ਫੇਅਰ ਇਲੈਕਸ਼ਨਸ ਹੋਣ. ਤਾਂ ਓਵਰਆਲ ਕੁਆਲਿਟੀ ਕਿਵੇਂ ਐਜੂਕੇਸ਼ਨ ਦੀ ਠੀਕ ਹੋਵੇ. ਉਹਨੇ ਮਿਸਟਰ ਸੁਨੀਲ ਨੇ ਦੱਸਿਆ ਕਿ ਹਾਊ ਟੂ ਮੇਕ ਇਟ ਏ ਕਾਸਟ ਇਫੈਕਟਿਵ, ਕਿਸ ਤਰ੍ਹਾਂ ਅਸੀਂ ਕਰ ਸਕਦੇ ਹਾਂ. ਡਾਕਟਰ ਬਰਾੜ ਸਾਹਿਬ ਨੇ ਦੱਸਿਆ ਕਿ ਇਸ ਨੂੰ ਲਾਈਫ ਸਟਾਈਲ ਡਿਜ਼ੀਜ਼ਿਸ ਬੜੀਆਂ ਪ੍ਰੋਬਲਮਸ ਨੇ ਪੇਸ਼ੈਂਟਸ ਦੇ ਵਿੱਚ, ਪਰ ਮੈਂ ਉਸ ਦੇ ਵਿੱਚ ਇੱਕ ਚੀਜ਼ ਹੋਰ ਐਡ ਕਰਨਾ ਚਾਹਾਂਗਾ. ਆਪਣੇ ਦੋਨੋਂ ਰਿਸਪੈਕਟਡ ਪਰਸਨੈਲਿਟੀਜ਼ ਬੈਠੀਆਂ हैं DMC ਦੀਆਂ ਵੀ, ਏਮਸ ਤੇ ਬਾਬਾ ਫਰੀਦ ਯੂਨੀਵਰਸਿਟੀ ਦੀਆਂ ਵੀ, ਕਿ ਜ਼ਿਆਦਾ ਪ੍ਰੋਬਲਮ ਪੇਸ਼ੈਂਟਸ ਦੀ ਤਾਂ ਹੈਗੀ ਹੈ, but the more problem is with the doctors also. Doctors have a worst lifestyle. ਅਸੀਂ Dr. DK ਜੀ ਅਸੀਂ ਇੱਕ ਲਾਸਟ ਟਾਈਮ ਸਾਡੇ ਵੀ ਹੈਵ ਏ ਵਨ ਕਾਨਫਰੰਸ ਐਟ ਚੰਡੀਗੜ੍ਹ. ਉੱਥੇ ਅਸੀਂ ਬੱਚਿਆਂ ਨਾਲ ਆਈ ਐਮ ਏ ਬੇਸਿਕਲੀ ਪੀਡੀਆਟ੍ਰੀਸ਼ੀਅਨਸ ਐਂਡ ਕ੍ਰਿਟੀਕਲ ਕੇਅਰ, ਉੱਥੇ ਉਹਨੂੰ ਦੱਸ ਰਹੇ ਸੀ ਕਿ ਬੱਚਿਆਂ ਨੇ ਮੋਬਾਈਲ ਨਹੀਂ ਯੂਜ਼ ਕਰਨਾ ਕਿਉਂਕਿ ਸੋਸ਼ਲ ਮੀਡੀਆ ਕਰਕੇ ਤੁਹਾਡੀ ਜਿਹੜੀ ਇਮੋਸ਼ਨਲ ਹੈਲਥ ਹੈ ਬੜੀ ਸਫਰ ਕਰ ਰਹੀ ਹੈ. ਤਾਂ ਅਸੀਂ ਉੱਥੇ ਬੱਚਿਆਂ ਨੂੰ ਜੋ 40 ਬੱਚੇ ਸੀ ਕਨਵੈਂਟ ਸਕੂਲ ਦੇ ਉਹਨਾਂ ਨੂੰ ਪੁੱਛਿਆ ਤਾਂ 40 ਦੇ 40 ਬੱਚੇ ਨੇ ਦੱਸਿਆ ਕਹਿੰਦੇ ਅਸੀਂ ਤਾਂ ਛੱਡ ਦਾਂਗੇ ਮੋਬਾਈਲ ਪਰ ਸਾਡੇ ਪੇਰੈਂਟਸ ਨਹੀਂ ਛੱਡਦੇ. ਐਂਡ ਆਲ ਦਾ ਪੇਰੈਂਟਸ ਵਰ ਡਾਕਟਰਸ. ਸੋ ਡਾਕਟਰਸ ਦੀ ਜਿਹੜੀ ਲਾਈਫ ਸਟਾਈਲ ਦੀ ਪ੍ਰੋਬਲਮ ਜ਼ਿਆਦਾ ਹੈ, ਉਹਨਾਂ ਦੀ ਸੋਸ਼ਲ ਹੈਲਥ ਦੀ, ਇਮੋਸ਼ਨਲ ਹੈਲਥ, ਫਿਜ਼ੀਕਲ ਹੈਲਥ. ਸੋ ਥਰੂ ਦਿਸ ਕਾਨਫਰੰਸ ਆਈ ਵਿਲ ਰਿਕੁਐਸਟ ਡਾਕਟਰ ਵਿਤੁਲ ਕਿ ਤੁਸੀਂ 1-2 ਘੰਟੇ ਡਾਕਟਰਸ ਨੂੰ ਵੀ ਅੱਛਾ ਮੋਟੀਵੇਟ ਕਰਨ ਲਈ ਰੱਖੋ ਕਿਉਂਕਿ ਉਹਨਾਂ ਦੀ ਹੈਲਥ ਜ਼ਿਆਦਾ ਖਰਾਬ ਹੋ ਰਹੀ ਹੈ ਡੇ ਬਾਈ ਡੇ. They are more diabetic, more hypertensive, more going into congenital heart disease, lifestyle heart diseases and all that. So I again appreciate Dr. Vitull's efforts and the help contributed by AIIMS authorities, and I wish all you very success for this conference. Thank you.
Thank you, Dr. Ravi, for your kind presence and advice. Now I invite Dr. G.S. Wander. He needs no introduction and he is the one of the most prolific motivator for young generation to excel in academics as well as in ethical practices, low cost medical treatment. Dr. G.S. Wander, please.
Very respected Director of the All India Institute of Medical Sciences, Dr. D.K. Singh, Vice Chancellor of the Baba Faried University, Dr. Rajiv Sood, my colleague in the Managing Board of the Baba Faried, Dr. P.S. Brad, a very popular eyes specialist, and Dr. Ravi Bansal, who is set up a distinguished neonatal setup in this part of the state and a very popular pediatrician. Dr. Akhilesh Pathak, the Dean of this institute, and my younger brother, Rajiv Gupta, who has been stolen by this institute from us, and we are still having hiccups for that, and we have not yet stabilized Dr. D.K. Singh sir for this, what has happened to us. And popular physicians of this region, dear students, all who are present here, members of the press, it is indeed a matter of great honor and privilege for me to come for MAPICON. In fact, my rivalry with Vitull has been very old. When I entered the medical school, in the first year itself, I became the table tennis best player. And the next year he joined, no one expected that this will happen to me. And no wonder he beat me up so after that, the table tennis rivalry kept on growing. And the friendship, of course, kept on. The mutual respect that we have for each other has always. He's, as Dr. Ravi Bansal was saying, he's probably one of the cleanest and the most frank and most honest human being I have met in my life, and who does not fear voicing his thoughts. His thoughts are always very balanced and always very practical. And that's how you can see that he has been able to hold this conference in the premier institute of North India. And I must congratulate you, Vitull, and the support that you get from your wife and from Meghna. And his son is a thoracic surgeon now in German, and he used to help him in the initial MAPICON. So whatever you need to, for the students, I would say, anything that you really want to do in life, there has to be an obsession. Just the obsession with which Dr. D.K. Singh has brought this institute. When he came to this region, I met him. I had the fortune of meeting him when he just came here. And that conviction in his mind was visible to me that he will certainly take it. To build a new institute is unimaginable. In fact, to build a department, just now Dr. Pathak was talking about the procedures that the cardiology department, that's another little bit of hiccups we have. Dr. D.K. Singh, you have brought in two of the brightest boys from Hero DMC Heart Institute, Dr. Pupinder and Dr. Suraj, both were working with us. And to start cardiology procedures and cardiac surgery the way Rajiv has done, I think it needs a lot of devotion. Cardiac surgery does not happen on its own. Cardiac surgery needs people to stay. I am indeed very thankful to Neil Gargji for giving us this thought that cost, of course, cost-effective treatment is important to us, sir, and we always do make an effort whatever we do. Although the aspirations and the avenues that we have in medicine are now so much that the art of medicine is getting lost just as we are picking up the science. Thank you, Vitull, for making me a part of this great. The obsession Vitull has across the country, wherever he goes to the conferences, he puts up the posters for the MAPICON. And today MAPICON is truly a national level conference. I wish him all the best to continue this great effort that he is doing. And I also thank Dr. D.K. Singh, the Dean and the Medical Superintendent, everybody, the faculty of this institution, for having given this chance to him and his team, Dr. Noria and others. And also giving an opportunity in the bargain to the young boys and girls. They can foresee what will happen to them after 15-20 years by looking at some of us. So it's a good mix, and it's a good way of knowing what way the profession is going. So thank you once again to the institute and to the management of this conference. Thanks.
Thank you, Dr. Wander, for really kind words. And this conference or our academic pursuits is because of your motivation only. Now I request Professor Dr. D.K. Singh. So he is such a kind personality and academically aware that whenever I meet him, I learn one or two things from him. And it is a great learning that I have in his contact for last 2 years. So I request him for word of wisdom for the younger generation as well as the older generation.
Thank you, Professor Vitull Gupta. As a host, my job is first to welcome the delegate and dignitaries, Professor Rajiv Sood, Professor Wander, Sri Neil Garg ji, Professor Barar, and other senior faculty members. I remember the day when Dr. Vitull Gupta approached me and he said that I want to organize this conference in AIIMS campus because we have already handed over this auditorium by the builder. Yeah, why not? You can have it. You can organize your conference in the campus, but for that you have to join the hands of the AIIMS faculty. And I am very happy he immediately agreed and contacted some senior faculty members, and they worked together to make this conference happen. We are all working for the people. So joining hands is a good thing because it will help the people. As Sri Neil Garg requested that think for the cost effectiveness. Basically, it is the requirement of the day that we must think about how to make it cost effective. As Professor Wander has said that yes, we are all trying for it, but sometimes because of some problems of the science, we can't reduce the cost. We have to think the need of the area, need of the people of this Malwa region. And I am very happy to say that Professor Rajiv Sood, AIIMS Bathinda and other medical institutions will like to join hands together and will do something for the people of the Punjab. I am very happy that when Professor Vitull Gupta, he said, I want to organize this campus. I thought probably this is the best chance for my student, AIIMS Bathinda, because being a new institution, it is difficult to organize a big conference in the campus. They will have the first hands-on experience of how to attend the conference, to gain the knowledge from the conference. So probably this is the best chance for our student of the AIIMS Bathinda to take every aspect of the conference, whether it is education, organization and other faculties, means facilities of the conference, and we will organize, I hope that we will be able to organize the big conferences in the campus because we have got the facility of having auditoriums. With this, I again welcome you all. Probably, I hope that the organizing committee will take care of the things whatever you require, and I take the responsibility if there is any failure in your facility part, then I am sorry for it because this is a new institution, so many things may not be there, and for that I am ready to take apology from you all, and I hope that Dr. Vitull Gupta must have taken care of everything. Thank you all.
Thank you, sir. Sir, it was a great opportunity provided to us by the AIIMS under your leadership as well as the faculty. And moreover, I am thankful to you for giving us 20 volunteers of medical students, and they will learn organization as we have learned from Dr. Wander and our seniors when they recruited us as volunteers. Thank you very much, sir, for giving us the opportunity. Now I invite Dr. Rajiv Sood, Vice Chancellor, Baba Farid University of Health Sciences, the premier university controlling all the educational activities in Punjab. Dr. Rajiv Sood, please.
Good morning. Thank you, Vitull, for this nice words and introduction, and also the opportunity to be part of this conference in this region. Dr. D.K. Singh, the director of AIIMS, I know him when I visited Banaras in 2006, and also he visited RML when I was there, Dean. Dr. Wander Saab is there along with Barar from our Board of Management. It is a wonderful opportunity to be together and also Dr. Ravi Bansal from Punjab Medical Council. I bring greetings from Baba Farid University of Health Sciences, and also incidentally I am the governing council member of National Medical Council, and I feel belongingness with all of you here, and the words which has been shared, wisdom which has been shared from this dais just now. Dr. Neil Garg ji also, he has talked about cost, economy, and we are observing the safety. So with the safety and efficacy of medication which is available, economy has become very important, and this was the topic I think 2-3 days back in Jalandhar. When we talk about patient safety, patient economy, and also we talk about the safety, we talk about the advances in the medicine, and those are possible to be shared through such conferences. Now 2019 onward, we have adopted to competency-based education, and in medicine we have accepted 5 levels of competency. That is the knowledge, and knowledge how, that is what we are doing, first 2 levels here. Then there is show and show how. That is the demonstrations and all hands-on without involving the patients, or what all level we can go. And also at the last comes the final proficiency, that performance. So if we go stepwise, where the medical education, the undergraduation is already, that has implemented it. Internship, I was fortunately the part of ICMR also, the competencies for internship, and now we are in a process through National Medical Council Commission that this is to be implemented, whether it in the education or in the research, in the mandatory way to the post-graduation and super specialization also. I am impressed with the wisdom and vision of Dr. D.K. Singh, that we have to have hand-holding of each other, of our institutions, and that will go a long way in the form of exchange programs, or in the form of our MOUs which we can enter into. And also National Medical Commission has given very good solution. Dr. Wonder was mentioning that some faculty has gone, and then this is the loss of one institute and the gain of the other institute. That National Medical Commission now is working on. We have introduced now the concept of visiting faculty. It is possible to adopt the faculty from the other institution if the person has served for at least as faculty, maybe for any duration, plus 8-year post qualification experience. And if that person is there, not more than 50% of the sanctioned strength, you can have additional visiting faculty also. And then there are outreach programs. We are into the arena of telemedicine, and telemedicine has become legal now, March 2020. Earlier it was not legal, and what we are doing, the hybrid mode of the conference, this is also a big part of telemedicine, telepresence. And I'm happy Dr. Ravinder is here, and we have given the charge for the entire university to Dr. Ravinder Garg, that along with our board of management member Dr. Vishwa Mohan, he will be advising the university along with our team members that how to go forward for education, for R&D, and for telemedicine. So these are the few areas which will reduce. Today the cost will reduce because of hybrid. Those who can come here, they are here. Those who can not come here, they are also attending the conference. And this is the beauty. And this is the beauty. This practice has developed in COVID pandemic times, when we got more used to social platforms and such kind of meetings. It was totally gone to virtual, and it has not totally come back to physical now, and it is in the hybrid mode, which is more economical. Medicine is economical, patient safety is there, the trainee performance is improving, and ultimately the medical education is gaining new horizons, touching it. And when Dr. Wander was mentioning that in 2010 the new initiative programs were launched. Now we are not launching any new national health program. Now in 2010 I was in that meeting in Ministry of Health and Family Welfare. I was part of that, and when it was decided that now new initiatives for the non-communicable diseases will start, and lot of work has been done since then. So I congratulate the institution, I congratulate the organizers, I congratulate the delegates also who are part of this, and the eminent faculty from this institute, India and abroad, who are making it possible for this wonderful interaction in wonderful auditorium, being the alumni from AIIMS Delhi. I feel proud that AIIMS Bathinda is very near to our university. I extend my all cooperation and also seek the cooperation from AIIMS Bathinda for future endeavors. And again, thank you very much for this nice arrangement and wonderful scientific program. Thank you.
Thank you, sir, for your kind words. I welcome Dr. Karamveer Goyal, 1 year senior to me, my friend, the former member PMC who has visited us in lot of conferences as observer. He is Dr. Wander's classmate, and I did my house job under Dr. Karamveer. Thank you, Dr. Karamveer, for coming. I have an announcement to make that just now I had a talk with Honorable Dr. Balbir Singh, Health Minister, Punjab, that he is coming tomorrow at 10:30. So I invite you all. We will have a special session for Honorable Dr. Balbir Singh, because he is a crusader and health is bound to have some impact on common man in Punjab. So this government basically for last 8 conferences we did not invite any politician, but now for 2 conferences we are inviting, because this government is talking about health and education and doing great groundwork which will culminate or which will bear fruits in next 2-3 years. So that is why we are basically appreciating their work and telling that people are with you in your crusade to change health and education in Punjab. So he will be visiting us for this conference at 10:30 tomorrow. So I invite all the delegates to be please in time so that we can welcome him and listen to him that what he is doing for health services as well as medical education in Punjab. So with this, I invite Dr. Kesh Kakkad to please deliver vote of thanks. Dr. Kakkad, please.
On behalf of AIIMS Bathinda and on behalf of MAPICON, I take a privilege to deliver vote of thanks. I am honored to give a vote of thanks to the dignitaries, our Director, Dr. D.K. Singh sir, and Vice Chancellor of Baba Farid University, and all the senior dignitaries present here. I am thankful to all the students, participants who came all the way to attend this conference. I'm very thankful to Dr. Vitull, who has chosen AIIMS Bathinda for this MAPICON. It will be very informative and very good conference for all the participants. They will learn a lot of things from here. I'm thankful to all the volunteers, all staff who has contributed in for arranging this conference. Thank you. Thanks.
Thank you, sir, for all your help and guidance. I now request Dr. Ravinder Garg, a head of Department of Medicine, Government Medical College, Faridkot, to kindly deliver his talk on non-alcoholic fatty liver disease, the new pandemic.
Session. At the outset, I must thank the organizers for arranging such a marvelous academic show, which is an annual event, the mega event, especially Dr. Vitull Gupta. The title for discussion here is a disease which is a silent killer, a disease which has undergone tremendous change in nomenclature, change in the prevalence, change in the imaging and other diagnostic modalities, and changes in the management. Since there are so many changes, so this disease needs a lot of awareness. So we'll discuss about non-alcoholic fatty liver disease. This is turning out to be a new pandemic. It is a common persistent liver ailment now, with a global incidence of around 25%. And 25%, remember, is not a small figure. And it is increasing as a cause of end-stage liver disease and hepatocellular carcinoma. And remember, now it is emerging as one of the leading causes for liver transplantation. Presently, it's number 2 on the list. But if it continues going like this, it can take the slot number 1. In short, we can call it the hepatic component of metabolic syndrome. If we have to describe it in very brief, we'll say hepatic component of metabolic syndrome. And it is directly related to diabetes and obesity. Now, as far as our Indian population is concerned, we are much more prone. Why? Professor Wander sir said India is turning out to be the center of diabetes in the world. And Indians have a very peculiar type of dyslipidemia. It is a highly atherogenic dyslipidemia. Why? We have a particular type of LDL which is called small dense LDL, which is highly atherogenic, and this is directly related to non-alcoholic fatty liver disease. Not only that, we have a peculiar pattern of abdominal obesity. Our BMI is normal, but still we have obesity because it is more of a visceral fat. And you know, this all causes insulin resistance, and insulin resistance is the hallmark for non-alcoholic fatty liver disease. If we have to define this disease, there are three essential components in the definition. One, there has to be more than 5% hepatocytes have to be undergoing steatosis. So if more than 5% hepatocytes are into steatosis, this is one criteria. Second, the person has to have any of the metabolic risk factors. And what are these risk factors? We'll be discussing very shortly. And the last component is that there has to be an absence of disproportionate alcohol intake or any other further persistent liver disease. So if a patient fulfills all these three criteria, we can very safely suspect non-alcoholic fatty liver disease and proceed further. And let me tell you, in hepatology, this is a diagnosis of exclusion. You have to exclude other diseases before we come to the diagnosis of NAFLD. If we talk of the global incidence, I told you just now it's around 25%, and in India it ranges from 9 to 10% to 55%. So 10 to 55% of our population is having this disease. And remember, this presents around 4th to 6th decade of life, and this, if you look at NAFLD, it has two essential components. One is diabetes and second is insulin resistance. And 60 to 80% of patients of NAFLD, they have insulin resistance, and around 20 to 30% patients of NAFLD have diabetes. So that means, in short, diabetes and obesity and insulin resistance, they are the hallmark of this disease. And both in the developing and developed countries, now this disease is progressively increasing for a single reason, because we are into a global obesity epidemic. This graph just shows overall prevalence in the world. Almost it's around 25% everywhere in every country. Now these are the various comorbidities which are directly associated with NAFLD. May it be cardiovascular disease, may it be any malignancy, may it be diabetes and obesity, all these. So it's a multitude of diseases which are contributing to NAFLD. This is to show you that this is a dynamic disease, right? So it starts from simple steatosis. Steatosis means nothing but deposition of fat. The next stage is steatohepatitis. Steatohepatitis is when there is inflammation, there is ballooning degeneration. In the coming slide, I'll show you how the pathologist looks at it. And the next stage after steatohepatitis is fibrosis or cirrhosis. And it does not end there. Cirrhosis can further go into hepatocellular carcinoma. So this is a dynamic disease process, and this is how the pathologist looks at this disease. So if it is a simple steatosis, the pathologist will look at the slide like this. Unable to, otherwise I would have shown you the marker laser, but anyways. So at the top we have simple steatosis. Simple steatosis is non-alcoholic fatty liver. The next stage is hepatocyte ballooning and lobular inflammation. This is non-alcoholic steatohepatitis. And next is fibrosis. And as the fibrosis increases, this goes on to a florid cirrhosis. And so what is NASH? NASH is nothing but NAFLD plus ballooning degeneration and lobular inflammation. So if we combine the fat with this inflammation and hyaline, this ballooning degeneration or hyaline degeneration, it becomes steatohepatitis. And 5 to 20% of these patients, they would ultimately of NAFLD will go into NASH, and 10 to 20% patients of NASH would ultimately go into high-grade fibrosis, and less than 5% of these would go into a stage of cirrhosis. And out of these patients of cirrhosis, this flow chart shows us that 31% patients of cirrhosis over 8 years, they would go into a decompensated disease. And you know, decompensated cirrhosis is a very bad disease. And 7% of these patients of cirrhosis over a period of 6 to 7 years would develop hepatocellular carcinoma. This is just a slide to show you a direct head-on comparison of alcoholic liver disease vis-a-vis non-alcoholic liver disease. In addition to the other differences, one main difference which I would like to point out here is that the rate of progression, rate of progression from steatohepatitis to fibrosis or cirrhosis is much higher in alcoholics as compared to non-alcoholic fatty liver disease, right? So it is around 3 to 12% per year in alcoholic liver disease, whereas it is just 1.5 to 3.5% in non-alcoholic fatty liver disease. So this is one big difference, but otherwise this is it's not less bad than alcoholic liver disease. Now, there has been a big change, in nomenclature of the disease. Now it's no longer NAFLD. NAFLD is now metabolic dysfunction associated fatty liver disease. Now it becomes MAFLD, or you can call it metabolic dysfunction associated steatotic liver disease. So the word fatty liver and non-alcoholic has undergone a tremendous change, right? And similarly, non-alcoholic steatohepatitis now becomes metabolic dysfunction associated steatohepatitis. That NASH becomes MASH now. Why this change? Why are we changing names? It has a logic. The logic is that the initial name, NAFLD, it describes what the cause is not there. कि अल्कोहल कॉज नहीं है, लेकिन कॉज क्या है ये नहीं वो बता रहा. तो जो नया नाम है वो हमें ये भी बता रहा है कि नया कॉज क्या है. It is not that it's not only alcohol, right? The second is fatty liver is sort of a stigma. So it removes the stigma now. Now we are not labeling it fatty. And this new name, it covers the entire spectrum of all the diverse etiology this disease carries with it, right? And it not only that, it emphasizes the influence of the cardiometabolic risk factors which are directly associated with MAFLD. And I'll be showing you what are the various cardiometabolic risk factors. And it allows, this changed name allows for a straightforward explanation for the disease. Now this is the Delphi consensus statement which recently came up regarding the change of nomenclature. So this consensus has changed the name. Very recently the name has been changed. So in which patients should we suspect this disease? Very simple formula I'll give you. Any patient who is having steatosis. Steatosis कैसे पता लगता है? ये भी हम अभी discuss करेंगे. So any patient having steatosis, you have to see whether there is any cardiometabolic risk factor, yes or no. If there is no cardiometabolic risk factor, this patient we should not suspect having MASLD or NAFLD. So this goes to the right side then. Now, then we have, if there is a cardiometabolic risk factor, yes, then either your patient has a isolated solely NAFLD or FAMSLD, or maybe your patient has steatosis, your patient has a cardiometabolic risk factor and is taking significant alcohol also. So then it could be a combination of non-alcoholic and alcoholic fatty liver disease, what we call as MET-ALD, right? So basically what the crux of this flow chart is that any patient who is having fat deposition steatosis, we just have to focus whether cardiometabolic risk factor is there, yes or no. No, we will not suspect this disease. If it's there, yes, we will suspect and we will proceed further. Now, these are some of the cardiometabolic risk factors which are there. Very simple. It's like diabetes, impaired glucose tolerance, hypertension, dyslipidemia, obesity, a high BMI or a waist hip circumference, and dyslipidemia generally we mean by a high triglycerides more than 150. We'll be discussing them in detail just now. So if the patient has any of these 4 or 5 cardiometabolic risk factors and there is steatosis, we will definitely suspect this disease. Now, if we look at the fatty liver disease or steatotic liver, so now we use the word steatotic liver disease. So hepatic steatosis can have this total spectrum. it can be NAFLD or now what is called MASLD, or it could be a combination of metabolic and alcoholic, or it could be only alcoholic liver disease, or it could be cryptogenic without any cause, or it could be other etiologies. Other etiologies, you know, they are huge in number: viral, toxic, metabolic, drugs, you know. There's a good large list of drugs which cause liver injury. So this is the total spectrum of steatotic liver disease. And in addition to alcohol, non-alcoholic or the MASLD stands out. Now these are the various, if we look at the etiopathogenesis of the disease in short, right? Because whenever we read any chapter, this is for medical students, when it comes to pathogenesis, we sometimes start feeling bored. The pathogenesis phir aa gaya. So to simplify the etiopathogenesis of this disease, we have these various etiological factors. May it be comorbid illnesses, maybe diabetes, obesity, insulin resistance, hypertension, dyslipidemia, whatsoever. Some genetic factors, and genetic factors as far as NAFLD is concerned, they are single nucleotide polymorphisms. These are some of the genetic factors. And on the right side, we have the environmental factors. What is our dietary pattern, our exercise, alcohol intake, and so many other things. So a combination of these contributes to the disease NAFLD, and this is just a repetition that all these factors, how they contribute to MAFLD. Now, if we discuss the pathogenesis, we will divide the pathogenesis into two. One, what is the pathogenesis of simple steatosis? And then we will discuss what is the pathogenesis of steatohepatitis. Pehle steatosis hogi, phir hepatitis pe jayega. So what are the various pathogenic factors for steatosis? Number one is increased delivery of free fatty acids to the liver. Free fatty acids body mein itne zyada ho gaye, they are increased delivered to liver, and this causes increase in insulin resistance. Second, there is increase in the pro-inflammatory cytokines like leptin. And on the contrary, there is a decrease in the anti-inflammatory, adiponectinic anti-inflammatory cytokine hai, wo kam ho jata hai. That goes down, leptin goes up. Then our dietary fructose. We have so many diets which are rich in fructose. They cause lipogenesis through carbohydrate metabolism. And last but not the least, they are farnesoid receptors. They are involved in bile acid metabolism. And once these receptors, they are increased, they decrease the steatosis. So we should have more number of farnesoid receptor activity. Right? So these are the four pathogenic mechanisms which contribute to steatosis. Now once we come to steatohepatitis, again we have four factors. Number one, very simple. These free fatty acids which are high in liver, they are directly lipotoxic. Second, there is a pathway which is called Hag-Hog pathway, where this lipotoxicity causes portal inflammation and hepatocellular ballooning. Third is that there are some surgical procedures where there is intestinal bacterial overgrowth. This intestinal bacterial overgrowth is directly related to NASH. And last but not the least, again obesity and fructose consumption. If it is increased, there are release of endotoxins in our intestine. And these endotoxins, they further cause release of inflammatory cytokines. So it is a combination of these 4 plus 4 pathogenic mechanisms which causes steatosis, and steatosis causes steatohepatitis. So this slide shows you how there is a strong interplay and correlation between all these factors, all these comorbidities causing increased free fatty acids, which is exceeding the limit of the adipose tissue and causing increase in insulin resistance and causing this disease. And once we come to the management, which we'll be discussing shortly, in addition to managing the individual comorbidity, the best part of the management is, which is shown in the yellow arrows, that it's better if we treat the insulin resistance. If we focus on the fatty acids, I think that would be much better. And of course, we have to treat the individual comorbidities also. How to diagnose this disease? I told you, this is a disease by exclusion. So any patient having steatosis, if there is no significant alcohol consumption, although is little different for males and females, but now we have just got one universal value, that is more than 20 grams per day. Ideally it is more than 20 in females and 30 in males, but then anything more than 20 gram per day should not be there. And you have to rule out other diseases like autoimmune, viral hepatitis, metabolic factors, toxic factors. If they are all excluded and there is steatosis, we suspect NAFLD. But let's not expect too many clinical features. The patient's majority are asymptomatic, no symptom. At the most there might be some fatigue, some malaise, or maybe some pain in the right upper quadrant. And there might be some hepatomegaly. Then how are they diagnosed? Most of these patients, they are diagnosed incidentally. There is an incidental deranged LFTs. Patient कोई और काम के लिए hospital आया, आपने उसके LFTs कराए, AST/ALT are deranged. There is an incidental hepatomegaly. And there is an incidental steatosis. आपने ultrasound किसी और काम के लिए कराया, radiologist ने लिख दिया fatty liver. So these are the incidental markers of clinical diagnosis. And once we have this, we go in for some anthropometric measurements. BMI, waist to height ratio, waist to hip ratio. And you will find that if your patient is having this disease, these anthropometric measurements would be deranged. How to take the help of laboratory? AST/ALT, they are raised. They are almost 2 to 4 times the upper limit of normal. But remember, AST to ALT ratio is less than 1. And you know what is the ratio in alcoholic liver disease? It is the reverse. In alcoholic liver disease, the AST to ALT ratio is more than 1.5. Right? So here it is less than 1. Alkaline phosphatase may be slightly raised. Remember, these 3 parameters are always normal. Bilirubin, albumin and PTI-INR. They would never be deranged. Yes, serum ferritin would be raised. And if serum ferritin is raised, take it for granted that this is an indication of advanced disease. Now, this is a very important test which is mentioned at the last. This is HOMA-IR. This is homeostasis model assessment for insulin resistance. आपको सिर्फ 2 values चाहिए, insulin fasting and fasting glucose. You can calculate this by very simple formula. And if it is raised, take it for granted if you are suspecting NAFLD, your patient will be NAFLD, especially if this value is more than 2.5. And we have some clinical scoring systems, very simple to use. Out of all these scoring systems, 3 are very important. One is NAFLD fibrosis score, NFS, which has got 7 parameters. And if the value is less than 1 minus 1.455, this excludes advanced fibrosis. On the other hand, if this value is more than 0.676, it means your patient has entered the stage of fibrosis. Similarly, we have another score, FIB4. It is very frequently used by the clinicians. FIB4, it has 4 parameters. If the value is less than 1.3, this rules out advanced fibrosis, right? Similarly, we have a very commonly used score, EPRI, which just has 2 parameters, right? So once we are treating these liver diseases patients, patients of hepatitis C and other patients, we are routinely calculating FIB and EPRI to see whether this patient has fibrosis, yes or no, because the treatment modality changes. Then we have other scores like BARD, ELF score, but the commonly used scores are the top 3 ones. Now the biomarkers, very important. Now what is the importance of biomarkers in this disease? The importance is that they help us to differentiate simple steatosis from steatohepatitis. That is very important. And we have some of the biomarkers, more importantly CK18, cytokeratin 18 and procalcitonin 2. Now, what is the problem with these biomarkers? The problem is they are not easily available, they are expensive, and they lack standardization, right? They are quite costly, so every patient cannot afford it. So then, we have to depend on the Department of Radiodiagnosis then. So we asked the patient to get an ultrasonography. Now, you know, simple, cost-effective, non-invasive, easily available is ultrasound. And it carries a sensitivity of 90%. But when more than 30% hepatocytes they have undergone stenosis. Now that is a big condition. But now, recently we have some software which is coming up. It's already there. That software, if the machine is equipped with, then there is a very good quantitative assessment of fat by the ultrasonography. This is a recent software which is already in the market. The next is elastography. You must have heard. Elastography can be transient elastography or fibroscan, or it can be shear wave elastography, or this could be done by MRI machine. Then it is called MR elastography. What is the function of elastography? Is to measure the liver stiffness. ये हमें fibrosis बताती है कि liver में fibrosis कितना है, right? It's got a very good sensitivity and specificity. Next is CT scan, right? CT scan can detect the fat and the fibrosis, but you know it carries high amount of radiation, right? And of course the cost is there. MRI, very good investigation, sensitive, specific, but again expensive. MR elastography I just talked about. It's a very sensitive investigation, but again some cost is involved. The last is MR spectroscopy. Now, I'm going to focus on this. Why? Because MR spectroscopy is the most sensitive modality for detecting fibrosis in the liver. Most sensitive. The only problem is that it is definitely costly, but it has been seen, or the data says that this is very sensitive modality. Liver biopsy, gold standard. And once you do liver biopsy, you can stage the fibrosis. And you have two scoring systems, 2 or 3 scoring systems on biopsy also. Histologically भी आपके पास scoring system है. उसमें NFS था, इसमें NAS है. NAFLD activity score. So if it is more than 5, your patient has NASH. If it is less than 3, no NASH. Similarly, there's another SAF score is there, and if the value is more than 3, it indicates fibrosis. Now, there was a time, even when we were students, there was a time liver biopsy was done very frequently, because other modalities were not there. But now, since we have so many other modalities to image the liver, now liver biopsy is not a preferred choice. Why? Because it is invasive. It carries complications, right? And there is inter-observer variability. Not only that, आपने sample लेके भेज दिया, sampling variability भी है इसमें, right? So these are some of the demerits of liver biopsy. So liver biopsy is done now very selected cases, although it is the gold standard. Now, if we want to stratify this disease, right? You have a patient with fatty liver. You rule out all other causes. वही exclude आपने कर दिया. आपका diagnosis of NAFLD और MAFLD आपने सोच लिया. अब आगे क्या करोगे आप? आप उस पे 2 scores लगाओगे. अभी हमने डिस्कस करे हैं FIB4 और NFS. ये 2 scores लगा दोगे, आपका काम बहुत आसान हो गया, right? If FIB4 is less than 1.3 and NFS is less than minus 1.455, take it for granted your patient does have only simple steatosis. उसको अभी hepatitis, steatohepatitis, fibrosis नहीं है. On the other hand, extreme right, if FIB4 is more than 3.25 and NFS is more than 0.676, take it for granted your patient has advanced fibrosis. And in this case, if the patient has advanced fibrosis, we have to further investigate the patient. Maybe you have to go in for elastography, biomarkers. Whereas if the risk is not there, then you just have to observe the patient. You have to treat the comorbidities. Now, these are the INASL. INASL is our association for the study of liver diseases, Indian society. And in 2022, they have given the clinical management guidelines for the treatment of NAFLD. Now here again 2 scores are used, but one score is same. FIB इसमें भी है, लेकिन इसमें NFS की जगह EPRI आ गया. EPRI तो और भी आसान है, right? So if FIB4 is less than 1, EPRI is less than 0.45, your patient has low risk of significant fibrosis. On the other hand, if the FIB is more than 1 and EPRI is more than 0.45, this patient needs care. This patient is a candidate for further elastography. And elastography, just for your knowledge sake, elastography we just discussed, it measures the liver stiffness. Liver should not be stiff. If the liver stiffness is increasing, that means your patient is going into an advanced stage of fibrosis. So, if the liver stiffness measurement, LSM stands for liver stiffness measurement. If it is less than 8.2 kilopascals, okay. If it is 8.2 to 13.6, this is a patient who has got steatohepatitis. And if it is more than 13.6, this patient has cirrhosis, right? And this is how we follow these patients. Less than 8.2, just we'll keep a watch on the patient, treat the comorbidities, usko bolenge apna weight kam kar, lifestyle modifications le. 8.2 to 13.6, these are the patients who need attention. Why? Because abhi fibrosis nahi hua hai. These are the patients who should be targeted for treatment for pharmacotherapy, which we are going to discuss. Because if it exceeds 13.6, then the game is over. Then it is cirrhosis. Then the patient will have full features of liver cirrhosis, right? So if we have to see the guidelines for management, we'll group it into 3: lifestyle modifications, pharmacotherapy, and bariatric surgery. So we'll just spend a minute each on each one of them. So the first one is the individual. It has to be an individualized therapy. You have to advise exercise, diet program. The patient has to lose weight, and the patient has to quit smoking, alcohol, all these things. Fructose intake has to be decreased, and you have to target the diabetes, dyslipidemia, hypertension, obesity, all the comorbidities, right? Now this is lifestyle. I've tried to focus all the lifestyle measurements in one slide, right? So we start with calorie restriction, weight loss. Remember, one important point about weight loss, it should be a slow, gradual, sustained weight loss. वो ऐसा weight loss नहीं कि एकदम से खत्म down और एकदम से फिर वो ऊपर भी जाता है. That's not required for NAFLD, right? And generally 5 to 7 or 10% of the weight should be lost in 6 to 8 months. 6 months, that is ideal for NAFLD. And alcohol intake, I told you, should be cut down to less than 20 grams if at all it is there. And low fat diet and walk, yes. 45 minutes of daily walk, simple walk, maybe for 5 days a week is good enough. And even this is good enough for cardiac diseases. And it's good for all the metabolic diseases, right? Other things, you have to optimally control the sugars, optimally control the lipids, avoid alcohol, and a patient who has already developed cirrhosis, you have to use these vaccines. Vaccine for hepatitis A, for hepatitis B, for pneumococcus, because this is an immunocompromised patient now. And you have to use the important drugs so that HbA1c remains less than 6.5. Pioglitazone is used not only in diabetes, but it is used in non-diabetics also in NAFLD. We'll be coming shortly to that. Hypertension, Professor Wander talked in length just now. So target should be systolic less than 130, diastolic less than 80, and the preferred drugs are ACE inhibitors and ARBs. Dyslipidemia, yes. Statins are used except for if the patient has decompensated cirrhosis, then we try to avoid them. But otherwise, our target should be that triglycerides should be less than 150, LDL should be less than 100, right? Next is our specific pharmacotherapy. Now in this, the most important group is the insulin sensitizers. You know, insulin resistance is the main cause, so we'll focus on insulin sensitizers, and your metformin is a very good drug used in diabetes and so many other indications even when the patient is not diabetic. and this is one of the important indications. It improves the LFTs and insulin resistance, but it does not have any good effect on the histology though. And then we have pioglitazone, right? Thiazolidinediones, it is PPARA gamma agonist. You know, it is a wonderful drug which is being used to not only to control diabetes, but it has been seen that if it is used in a dose of 45 milligram per day for 6 months, or you can use it a lower dose, 30 milligram per day for 96 weeks. And there have been studies where pioglitazone has been directly compared with vitamin E, and there has been some outscore for pioglitazone. And these are some of the incretin mimetics, GLP-1. Two important drugs are there, liraglutide and semaglutide. They are weight-losing drugs. And DPP-4 inhibitors, you know, students know these are the oral hypoglycemic agents, but they are weight neutral, right? Other important product is vitamin E. It's very much in the market since long. It is an antioxidant, and when used in 800 international units per day in divided doses, it is good for steatosis and histology, right? But you have to take care. What care? You have to use in non-diabetic patients, and this carries a risk of carcinoma of the prostate and some risk of hemorrhagic stroke. So you have to be selective in choosing the patient for vitamin E, but generally it is used. A very good drug. There have been good trials with vitamin E, with seroglitazar, vitamin E with pioglitazone, and vitamin E has a good efficacy and it can be used, but you have to be very selective. And then the lipid-lowering drugs, you know, the most common are statins. And if the statins are unable to achieve the targets, you can add other drugs like ezetimibe or PCSK9 inhibitors. These are also add-on therapies. And now, you know, recently we have bempedoic acid, which is a very good lipid-lowering drug. These are some of the miscellaneous weight-losing drugs. ठीक है, ये मार्केट में चलती रहती हैं, orally stat पहले बड़ी यूज हुई, अब नहीं हो रही है. So some of the combinations, but this, yes, liraglutide is definitely going on these days. Now, these are three or four important drugs. Seroglitazar, which is a dual PPAR alpha and gamma agonist. It is 4 milligrams per day. I'll show you just 2 slides where this has been studied very nicely. Pentoxifylline is another drug which is used, and then we have obeticholic acid, which is pharmacoid X receptor agonist. I told you it helps in bile acid metabolism. Now seroglitazar, a good drug, and I know I'm going to just have. So this study, seroglitazar versus vitamin E, right? The only thing is there was some seroglitazar outscored vitamin E little bit, but still it has the effect on fibrosis is debatable as far as seroglitazar is concerned. Bariatric surgery, yes. I'll tell you simple indication for bariatric surgery in this disease. If after 6 months of lifestyle modification weight loss is not achieved, the patient should undergo bariatric surgery if the patient is BMI wise is obese, and this helps in histology and the improved liver parameters. Last is the liver transplant. I just told you it has become the second leading cause for liver transplant and liver diseases, and is still increasing. And remember, this is mainly recommended for advanced NAFLD, where the patient is going into hepatic failure, as other indications of hepatic failure are there. Now this EASLD guidelines came out in 2022, which tell us that it has to be a multidisciplinary approach for the management of NAFLD. There's a lot of work going on, NAFLD, MAFLD, many molecules are in fray, but not documented as such. And the take-home message, my friends, number one, is that NAFLD is responsible for significant liver disease in our country. Number two, steatosis is a relatively benign condition, but remember, a NASH carries a significant morbidity and mortality. Number three, prolonged oxidative stress and inflammatory cytokine damage are the key pathogenic mechanisms. Number 4, ultrasound and lab investigations, they remain the pillars for diagnosis, although we have other modalities, non-invasive, which are add-on modalities. Number 4, sustained weight loss and lifestyle modifications are the mainstay of treatment. And in addition to that, insulin sensitizers, antioxidants, cytoprotectors and hepatoprotective drugs along with bariatric surgery are the add-on therapies. Thank you so much.
Thank you, sir. Because of paucity of time, we will not be taking any questions for this session. I request the paper presenters for the poster presentation to kindly go near the early bird registration counter immediately. For the next talk, I would like to invite on stage Dr. Rakesh Kakkar, Head of the Department of Community Medicine, AIIMS Bathinda, to deliver his talk on life course approach for NCD control.
Thank you, Dr. Meghna, and I'm thankful to the organizing team for giving me this opportunity to present a paper, life course approach for prevention of non-communicable disease. So I'll make the environment a little lighter because every one of us has to play a role, be it a pediatrician, be it a gynecologist or general physician. Everyone has a role, and everyone can contribute in this approach. If we leave it to cardiologist or a general physician only, then it will be injustice to the patient. So every citizen, every physician, everyone has to be a part of this life course approach. So as we know that NCD account for now it is a major chunk of morbidity and mortality are due to non-communicable diseases, and the four most diseases which contribute more, like cardiovascular disease, are the major killers, followed by cancer, chronic respiratory disease and diabetes. So in addition to this cardiovascular disease, cancer, chronic respiratory disease and diabetes, we have other diseases like hypertension, dyslipidemia, obesity, metabolic syndrome. So the diseases are innumerable, but with every disease there is a role of lifestyle modification. So we will discuss that. You can see a lot of risk factors of non-communicable disease. Some are modifiable, some are non-modifiable. So modifiable risk factors, these are spread across right from the conception till geriatric age. So, like tobacco use, alcohol use, physical activity, weight, dietary practices, dental health care, and managing various diseases. So, air pollution and many other factors are there which can be easily managed at various stages of life. So, for these major diseases like cardiovascular disease, diabetes, cancer, and chronic respiratory diseases, these tobacco, unhealthy diet, physical inactivity, and harmful use of alcohol play a major role. While for other diseases like mental health and cardiovascular morbidities, other factors also play a role. So now, NCD affects all countries and people of all ages. So it is now considered as world's biggest killer. And if we follow the life course approach, then right from the preconception through pregnancy, then infancy, early years, childhood, adolescence, teenage years, and adulthood, and then to the geriatric age group. So everyone is involved, and these factors go on accumulating from pregnancy or from the antenatal period. So a life course approach of NCD involves maximizing people's health or well-being throughout their lifespan. So we have to have a holistic approach for prevention of this disease. Like social, we have to have a control over the social environment, environmental control, and economic and lifestyle determinants are very important for control of this non-communicable disease burden. So if we see the global burden of disease in 90s and in say 2023, so it is drastically changed, and we have a double, or in fact we have triple burden of disease now. So we'll see that the NCD burden is increasing, both morbidity and mortality are increasing. This is basically due to the exposure to unhealthy lifestyle and lack of physical exercise or adoption of sedentary lifestyle. So this epidemiological transition and increase in the life expectancy, so it is manifested after say 50s, but these factors or the risk factors increase right from the childhood age. So there is a need for stronger health system and health worker integration. So every physician, every health authority, health administration, everyone has to play a big role in making this health system stronger. So it needs more resource allocation, better preventive knowledge, and awareness of danger sign. Earlier diagnosis and treatment is required. So many non-government organizations like World Health Organization, UN agencies, they are playing a big role in controlling it in developing countries also. So nutrition play a very big role across all the life stages, and we'll discuss it in detail. In childhood, a new risk of NCD may appear due to easy access to unhealthy foods and drinks in their canteens. So now Eat Right Campus concept is there. So we can inculcate a healthy lifestyle right from the school age. So Eat Right Campus need is there, so that in childhood they get the option of choosing the right kind of food. In young people, in adolescents, adolescent people acquire the harmful habits such as smoking and drinking alcohol, which are the major contributors of NCD, and this trend continues even in adulthood. And in addition to this, many other factors adds up stress at the workplace, financial stressors, unemployment, unsatisfying career, low social engagement. So all these also contribute in adding the risk factors for non-communicable disease. Then retirement or in the geriatric period also, there are many stressors like poor nutrition, lack of physical activity, alcohol, tobacco, social isolation also plays a very big role. Financial stress directly affect the older people. So you can see that it affects all the ages. And maternal diet, lifestyle and body composition during the antenatal period plays a very important role, and which influence the children's development and body composition, and it can be diagnosed through ultrasound and genetic metabolic test. And lot of research is still needed to control these factors during this period. Now the aim is to control, to have a mechanism to uncover the developmental origin of NCD. So Dr. Barker has showed a significant role of maternal nutrition, which plays a significant role in adult disease, and he has found that adapting human fetuses to a limited supply of nutrient resulting permanent structure and metabolic changes. So malnutrition during the early period, it increases the chances of non-communicable disease in later life, and many cardiovascular complications are possible if one is having a low birth weight child, or if the malnutrition is there in early childhood. So importance of first 1000 days, the nutrition and the child development during first 1000 days of life is very important, and if we can ensure a good development during this period, then we can decrease the chances of non-communicable diseases. So undernutrition during this period increases chances of heart disease, diabetes, hypertension in later life. And moreover, unborn babies are not only negatively influenced by maternal habit, like diet during the antenatal period, what drugs mother is taking, any alcohol or tobacco consumption during pregnancy, or other environmental factors like now air pollution is also a big factor in non-communicable disease. So a low birth weight is attributable to poor long-term health and poor cognition. So NCD risk factor during the life course, that is infancy, childhood, adolescence and adulthood, contribute to prenatal maternal undernutrition and low birth weight, and this is how we increases the chances of later complication in the form of non-communicable disease. So across various life stages you can see different factors which play a role, and this is how the risk factor go on accumulating, and it usually manifests after 50s, but now we can see, because it is a multifactorial causation disease, so it manifests even earlier in present scenario. So somehow at least we can play a big role in controlling the modifiable factors. So you can see the different curves. The upper curve, if we do not intervene anywhere, and if we continue to follow the unhealthy lifestyle, or if we continue to follow all the risk factors, then the upper curve will be there. And if we follow all the if we follow the better lifestyle, then the lower one is by early intervention we can largely reduce the burden of non-communicable disease. In this graph, there is a role of physician also. suppose if mother is entering, if without planning, if mother is going to antenatal period, then there is a high risk of preconception period, and without any reducing any risk factor, there is a increased chances of risk of NCD in mother as well as in child, because of if the weight gain is more, then there are chances of hypertension or diabetes. So it will increase the risk for both mother as well as for child. So barriers at healthcare professional level are like sometimes due to heavy OPD we do not give enough time for the counseling. So due to time constraints, due to the lack of awareness and resources, sometimes due to hesitance about the intervention effectiveness, we ignore many factors. So and due to these barriers, there is a continued barrier for healthcare professional to communicate or intervene to their patients, and inadequate or no follow-up of high-risk pregnancies and babies. This is how, due to our ignorance and due to the ignorance at the patient level, the chances continue to be high. Now, coming to the last stage, that is 2021 to 2030 is declared as a decade of healthy aging by Ministry of Health and Family Welfare. So our health minister at that time, he has launched a decade of healthy aging. So the aim is to a decade of concerted action by countries across the globe to ensure the healthy life for a rapidly growing elderly population. So in this you can see that in next India's 50% population is increasing from 270 million to 410 million in next 15 years. So this increase in the geriatric age will be rapid because of increasing life expectancy and decrease in the younger population. So at present we have around 125 million 50 to 60 year population, and over 60 year population is 135 million, and by 2036 we will have 400 million of this geriatric population. So every fourth person will be 50 plus in next 15 years. So this comorbid condition predisposes the population to vaccine preventable diseases, and you see that around 18% population is increasing between the 50 to 54 years to 60 to 64 years. So almost every second person above 50 has at least one comorbid condition. And there is a need of giving the influenza vaccination to decrease the chances due to these morbidities. So incidence rate ratio of influenza related hospitalization for adult with comorbidities are increasing, and in end stage renal disease the incidence rate ratio due to influenza and due to hospitalization is very high. Similarly for COPD, CHF and asthma it is high. So for particularly these patients it is recommended to give influenza vaccine to people over 50 years of age. Incidence of invasive pneumococcal disease is also high. If a person is healthy, then there are chances of only 4.5%, while a person with a comorbidities, the chances increase to 167%. So it is recommended to give pneumococcal vaccine also to people over 50 years of age. Similarly, in this, we see the predisposition which lead to sharp rise in the incidence and severity of vaccine preventable disease, and incidence of invasive pneumococcal disease per lakh population is presented here. So, in 50s, if between 50s to 65 plus, there are 65% increase in the incidence of invasive pneumococcal disease. So as person move to the geriatric age group, the lung chances of lung disease increase. So again, it emphasizes the need for pneumococcal immunization. So nowadays, adult immunization is also important. So incidence of herpes zoster is also more over 60-year population. Influenza-related hospitalization is also increased manifold from 50s to 60s. So there is a significant hospitalization episode after 60s. So from 45 to 60 years and from 60 to 69, there are 71% increase in hospitalization. So this is the medical bodies have recommended usage of these vaccine over 50 years of age. So it is recommended that over 50 years of age, all the important medical societies like Geriatric Society of India, Association of Physicians of India, IMA, Indian Association of Occupational Health, all have recommended the use of influenza, pneumococcal vaccine, herpes zoster, Tdap, MMR in the adult population. So, what are the factors to promote the adult immunization? We can promote adult immunization by increasing the physician's awareness and knowledge, by removing the vaccine apathy, because it is instilled in our mind that vaccine is for childhood age. But now this, due to COVID, this barrier is now removed and we can realize the importance of vaccination in adulthood also. So somehow government has to provide some sponsorship or some hand holding for removing this socio-demographic barriers, and we have to modify the behavior and lifestyle factors in addition to it, improving the channels of access, that is, these adulthood immunization should be made available in many centers across India, and we are happy that we are providing adulthood immunization in our AIIMS. So you can refer patients from other areas of Punjab or nearby state to us. So overall, we have to focus in 7 focal areas. That is, we have to improve the mental health, we have to focus more on reduction of non-communicable disease, we have to give more elderly care, we have to make geriatric friendly hospitals because this population is increasing and the morbidity is also on rise. We have to give adequate nutrition, balanced kind of nutrition across all ages, not only in adult but right from the pregnancy. So we have to give more focus on a holistic health and traditional medicine also. So now the concept of One Health is also on rise, that is humans, animals and environment are studied together. So thank you.
Thank you, sir. Now I would like to call upon the stage Dr. Karamveer Goyal, who is member of PMC Ludhiana, for his talk on the topic Diet in Convalescence.
A very good afternoon to all of you. I think lunch is going on and my lecture is again also on diet. So I don't think I will be standing between you and lunch for a long time. So let's focus on what is the importance of diet in convalescence. So main focus is how we are going to see that people getting well with the nutrition in convalescence. In general, if we see in day-to-day practice, we see a lot of patients, and here is one patient, like 44-year-old gentleman complaining of lack of appetite and weakness, had presented with symptoms of acute respiratory infection, intermittent cough, fever, generalized weakness, lack of appetite, illness, and the elevated CRP and other things. We treated him with antibiotic and vitamin D, vitamin C and all. Patient recovered, and however, patient is having lack of appetite and there is some weakness. Now, that means patient is complaining of weakness, lack of energy, anorexia in this after the illness, and we should know what should we be doing in this period. And this is the period what we call as convalescence. Convalescence is gradual process to restore health after illness. Many people regard themselves healthy once discernible symptoms of illness disappear. They don't leave themselves time for convalescence. This increases their risk of relapse and renewed bouts of illness. In patients who have lost significant strength and muscle mass, considerable period of significantly increased calorie and protein delivery is required for recovery. Lack of understanding of role of oral nutritional supplementation in convalescence has led to the extremely poor long-term outcomes and quality of life. So we'll be focusing how we should be taking the patient out of illness to health during this period. The most important thing in this period is nutrition, and most of the people have malnutrition. In this, the previous two talks were of, if we say, non-communicable diseases and NFLD. They were of disease of the rich. Here we have malnutrition pertaining to both rich as well as poor. In our country, many people, hundreds and thousands of people, after a bout of illness, they don't have either money to spend on good nutrition, or they don't have the knowledge, even if they have the resources, to have a good nutrition for their recovery to normalcy after illness. So, if we see what is the relationship between malnutrition and immunity, there is, after illness, there is anorexia, there is metabolic damage, there are reductions in the vitamin concentration, iron deficiencies there, zinc and copper deficiencies there, and there is reduced intestinal absorption, and people have traditional behaviors. Somebody will say, I won't have to take tomato, I don't have to take onion, I don't have to take egg or something like that. So ultimately what results in malnutrition, and malnutrition leads to decreased immunity. There is a vicious cycle of undernutrition and infectious disease. As if we see on this slide, on one hand there is an increased energy needs, but there is a decreased appetite, there is decreased absorption, increased absorption in calorie need requirement. On the other hand, there is a decreased immunity and there is increased risk of disease. So, on one hand, patient has got infection, on the other hand, malnutrition. With malnutrition, patient has malabsorption is because of the decreased nutrient intake, decreased absorption and increased catabolism. Whereas infection causes impaired barrier protection and impaired immune function. So we have to tailor make the nutrition therapy to illness and recovery. Our primary objective is to minimize the adverse effects of illness on nutritional status, and secondary objective is to promote normal intestinal, mucosal renewal, absorptive and digestive functions. That should be our aim. During infection, there is aversion to food in the form of anorexia, nausea and vomiting, we all know. So, there should be complete balanced nutrition with protein, zinc, vitamin A, prebiotics and other nutrients for complete and faster recovery. So if we maintain good adequate nutrition, we can restore positive nitrogen balance and decrease burden on kidneys, provide relief to the symptoms as and when they are present, and correct and maintain water and electrolyte balance. What we get out of it? We will be improving muscle strength, there will be better wound healing, there will be immunity booster, there will be better recovery from inflammation, and patient will be having better energy in the body. So, if we see how does malnutrition affect the immune function, there is tissue wasting and impaired organ function, there is cardiorespiratory impairment, there is chest and bone infection, there is muscle mass loss, and ultimately increased mortality. Persistent poor nutritional status adversely affects the immune function and it may predispose to the recurrent infections. Patients who are malnourished and they have decreased immunological responses, and there is higher prevalence of immune dysfunction in the malnourished people. So, oral nutrition supplementation therapy has to be taken into account, has to be kept in mind if we are seeing the patient during the convalescent period, and we should know that if we supplement the diet with ONS, we call it oral nutrition supplement therapy, this will definitely will improve immunity. So, nutrition supplementation leads to improvement in immunity, vitamin status, prevents secondary infection, there is improvement in the anthropometric indices, there is improvement in the clinical outcomes, and there is improvement in the quality of life. So, I won't go into the detail of all the studies because of the cost of the time. So, malnourished people, they show functional limitations, reduced physical performance and physical activities, decreased body weight and decreased muscle strength. But protein-rich oral nutritional supplement containing micronutrients in malnourished patients can reverse the conditions. So these are the studies which show and prove that if we give oral nutrition supplements, then these patients, they have better outcomes. Whether patient is having sarcopenia, that is decreased muscle mass, if we give ONS, they will have improved muscle mass with supplementation therapy. So, this is a study showing 330 people malnourished. They were given ONS twice daily for 24 weeks, and there was much improvement in all the parameters which were showing muscle strength and muscle mass. Same is true about the other people. They have enhanced specific nutrition formula for strength and quality of life. And as just to repeat, we see malnutrition can alter body composition with reduced fat, accelerate muscle losses, impact overall ability to be active, increased risk of fall and fracture, diminished physical and mental function, impaired clinical outcome, high risk of hospital readmission, and it reduces quality of life. Just to repeat, oral nutrition supplement therapy increases muscle strength and overall activity and overall stamina of any person who is in the convalescence period. Again, if we come to wound healing, nutritional status influences all phases of wound healing. We know in wound healing we have the phases of wound healing in the form of hemostasis, inflammation, proliferative changes and remodeling phase. all phagocytes, monocytes, lymphocytes, leukocytes, macrophages, they all require protein for their formation and immune response. If we in detail see effect of nutrition deficiency on wound healing, there is nutrition deficiency, immune response is insufficient, leads to delayed wound healing, decreased wound tensile strength, and ultimately increased susceptibility to infection in the wound. Malnourished patients can develop pressure ulcers, infections, delayed wound healing that results in chronic non-healing ulcers. So there is a big role of nutrient supplements for wound healing in the convalescence period. In patients of COPD, if we see what is the effect of malnourishment, there is impaired pulmonary status, there is higher resting energy expenditure, there is increased fatigue, there is dyspnea and early satiety. So a greater calorie requirement is there in all the COPD patients, and we should do ONS, that is oral nutritional supplement therapy, in patients of COPD. There is, in such patients, there is improvement in the anthropometric measurements, pulmonary functions, respiratory and peripheral muscle strength, there is increased endurance, there is increased functional exercise capacity, and there is improved quality of life. Any patient with chest infection, again there are data which show that the patients with ONS, they have better well-being, better measurements, better biochemical status, better functional capacity, better and faster recovery from all the illnesses if we are giving oral nutrition therapy. We see tuberculosis day and night. In tuberculosis and malnutrition, there is a complex relationship. The infection may cause undernutrition through increased metabolic demand and decreased intake. And nutritional deficiencies worsen the disease and delay recovery by important immune functions being depressed. So this slide shows, this very important slide, which shows vicious cycle of undernutrition and tuberculosis. On one hand, there is tuberculosis, which causes impaired cell-mediated immunity, and on the other hand, patient has anorexia as well as inflammation, leading to undernutrition overall, and both the two things have a complex relationship, leading to the delayed recovery if there is undernutrition. Oral nutrition supplementary therapy in tuberculosis helps to improve outcome in tuberculosis patients. How it improves BMI and total lean muscle mass, improved weight gain and improved muscle strength, enhanced clearances of clearing the mycobacteria. There is shorter time to sputum conversion from positive to negative. There is reduced infectiousness of the patient. There is reduced mortality, and there is improved quality of life. Just again, studies showing that additional nutrition supplements combined with education on nutrition contribute to rapid and sustained recovery in all such patients. So again, coming back to the first slide, if we see that 44-year-old gentleman recovered from acute illness after appropriate therapy and micronutrient support, however, there was lack of appetite and weakness. With oral nutrition supplement therapy, appetite returned to normal. There was improvement in the muscle strength. There was body weight had increased. There was increased body immunity, and quality of life had got improved. Nutritional support should continue not only during acute illness but also in the recovery phase. That is the carry-home message. So, if we look at for 1 meter, what should be the oral nutrition supplement and how it improves the thing? It will improve the food intake, it will improve the appetite, it will improve body weight, it will improve your immunity, it will give better muscle strength, it will improve your function capability and ultimately quality of life. So while choosing a oral nutritional supplement, we have to see that what are the attributes of an ideal oral nutritional supplement. It should be clinically proven. It should be meeting the dietary guidelines for Indians recommended for healthy diet. It should have a high quality protein. It should include fiber and prebiotic. There should be a desirable electrolyte content, and it should have a blend of micronutrients and vitamins. So these are the attributes of an ideal oral nutritional supplement. So friends, before I conclude my talk, I just want to again re-emphasize on the thing that we are in our day-to-day practice, whether we are seeing patients in our OPD or in wards or even at home. Once patients have come out of the hospital, out of their OPD and all, they have recovered from the major illness, but they are not fit enough to go to their work, to restore to their daily day-to-day activities, and their quality of life it is not good. We have to concentrate on the patient's immunity status, nutritional status, and overall energy and you can say strength level. So this is the last slide. Nutritional support can boost energy and strength as well as immunity. Food for healing is an old concept which has been utilized in modern therapy with new packing. Nutrition plays an important role in recovery from infection. Wound healing can be accelerated through appropriate nutrition. Nutritional support can prevent health-related complications in aging population. So, hope you all, after my small talk, will realize the importance of the convalescence period after patients have come out of ICU or suffering of any cancer or something. They are doing chemotherapy, they are having tuberculosis. In general, apart from the major prescription of the doctor, we should be having very important thing in our mind, whether they are having good nutrition, oral nutrition supplements are being taken or not, their energy and muscle mass and overall activity is restored in proper time. Thank you for patiently. Thank you.
Thank you, sir. Now I would like to call upon the stage Dr. Saurav Goyal, who is a nephrologist at Delhi Heart Institute and Multi-Speciality Hospital, Bathinda, for his talk on the topic diabetic nephropathy and update.
Good afternoon, everyone. I am Dr. Saurav Goyal. I am a nephrologist practicing at the Delhi Heart Institute and Multi-Speciality Hospital. And today's topic given to me is diabetic nephropathy. I will be discussing the brief updates about the diabetic nephropathy. I will be discussing the topics in the heading of introduction, screening and diagnosis of diabetic nephropathy, and management and recent advances of diabetic nephropathy. We know that diabetes is a widespread disease, and almost 6% of the world's population is diabetic, and almost 420 million people are living with the type 1 or type 2 diabetic. And out of these diabetic patients, 40% are expected to develop chronic kidney disease. And diabetes is the leading cause of patients leading to chronic kidney disease or end-stage renal disease. And almost 40% of the patients of diabetes, they land up in CKD. And diabetic kidney disease is greatly amplified by the risk of cardiovascular complication and death. And in spite of controlling the factors like hyperglycemia and hypertension, the mortality in the diabetic kidney disease remains quite high. And the irony of the disease is like no current test is available which can predict the development of diabetic kidney disease. Only we can consider the risk factors like age of patient, weight of patient, family history, and duration of diabetes and race, which can give us a hint at whether patient will be having diabetic nephropathy in the future or not. This is a disease with great economical and human suffering, and till recently drugs like only RAS inhibition are available for diabetic nephropathy, but now a lot of drugs are coming up for the treatment of this condition, deadly condition, diabetic nephropathy. And screening of the disease, awareness, and implementation of the new therapy is the need of hour. And first of all, to diagnose the patient of diabetic nephropathy, we have to anticipate the diabetic patient developing the diabetic nephropathy, and we have to screen the patient. So, how frequently should we screen the patients for diabetic nephropathy? A type 1 diabetic should be screened every 5 years for the development of proteinuria, and a type 2 diabetic patient should be screened at the time of presentation itself, that whether he has developed this diabetic nephropathy or not. And how can we screen? We can screen using the measurement of creatinine and ultimately calculating the GFR, and we can measure the albuminuria, which can be done by the spot urine sample, or we can calculate the 24-hour urine protein. American Diabetes Association also recommends the screening of proteinuria and creatinine, and they recommend it once yearly. But if patient is having moderate proteinuria and impaired GFR, then it should be done twice yearly. And this is a slide which is important, which is showing the categorization of albuminuria in patients. Earlier it was called as microalbuminuria and macroalbuminuria, but the now new terminology define it as normal to mildly increased, moderate increased, or severely increased. Normal to mildly increased is less than 30 milligrams, and moderately increased is 30 to 300 milligrams, and severely increased is more than 300 milligrams. So, how we diagnose? Typically, it is a clinical diagnosis. Routinely, we don't do biopsy to diagnose the diabetic kidney disease. But diagnosis, when alternative diagnosis is being thought of, then we go ahead with the biopsy in certain cases. And when we should biopsy a patient of a diabetic patient, when are we suspecting that he is having a diagnosis other than diabetic nephropathy? If severely elevated proteinuria is present at the time of presentation of type 1 diabetic, then we should suspect that this is non-diabetic renal disease. If there are presence of RBCs cast, dysmorphic RBCs, WBC cast, then also we should have a clue. And presence of another systemic diseases like polycystic kidney disease, renal stones, or SLE should also give a clue that patient might be suffering from a non-diabetic renal disease. And if there is sudden increase in albuminuria or a GFR fall of more than 6 ml per year, then also we should think of another diagnosis than diabetic kidney disease. This is a natural history of diabetic kidney disease. It goes through 5 stages of stage 1 to stage 5, and different timelines are given. And management of the diabetic kidney disease, it is brought, first we implement the lifestyle modifications in patient in the form of diet, exercise, smoking, cessation, and weight control. And then we move with the first line of drugs, which includes glycemic control. We use metformin, SGLT2 inhibitors is the add-on therapy. And then we implement the important class of drug, which is the backbone of diabetic nephropathy, that is RAS inhibition. And also we use statins. Statins can be high dose or it can be low dose statins. And then we add on the add-on therapies like GLP-1 receptor agonists and antiplatelet therapies and non-steroidal mineral receptor antagonists. And then there is lipid management and blood pressure control. This is a diagram which is showing the comprehensive care of a patient of diabetic kidney disease. First of all, lifestyle modification should be implemented, and then the first line drugs, which includes the metformin, should be added. Metformin can be added if GFR is more than 60, and dose needs to be modified if the GFR falls to 45. And then SGLT2 inhibitors can be added. It is added if GFR is more than 30 and it is continued. And then if further glycemic control is required, we add GLP-1 receptor agonist. And if further glycemic status is not met, we can consider the sulfonylureas or insulins. And in the blood pressure control, the first line of drug is RAS inhibition in the form of ACE or ARBs. And if blood pressure is not controlled, then we consider of adding the calcium channel blockers, which are mainly dihydropyridine. And diuretics can also be thought of. And also we can add on the upcoming drugs of non-steroidal mineralocorticoid receptor antagonists, and if proteinuria is there, and other conservative managements like antiplatelet agents and statins should also be added. What should be the target of hemoglobin A1C in a kidney failure patient? It should be monitored every twice yearly, but it can be done up to 4 times per year if glycemic status are not met and other new drugs are being added. And regarding the level of HbA1c, patients with earlier stages of CKD should be given a strict target of HbA1c of less than 6.5 because they have minor complications, they have fewer comorbidities, and they have hypoglycemia awareness. Whereas the patients in the advanced stage of CKD, they have many comorbidities, shorter life expectancy, and hypoglycemia awareness is lost. So they are given a relaxed target of almost 8. This is again a slide which is showing the selection of glucose-lowering drugs, physical activity. Metformin is started when the GFR is more than 60, and it can be continued safely up to GFR of 30. When the GFR falls below 45, a dose needs to be halved. And SGLT2 inhibitors is the first add-on therapy with metformin, followed by the drugs. This is again a slide which is showing the metformin usage in the patient of renal failure. And so I will be broadly dividing the drivers of disease progression and treatments into these headings in the form of RAS inhibition, SGLT2 inhibitors, GLP-1 receptor agonists, non-steroidal mineralocorticoid receptor antagonists, a doubtful role of uricosuric drugs and protein restriction, and also the correction of acidosis. These are the main drivers of a diabetic kidney disease progression, which include hemodynamic factors, inflammatory factors, and metabolic factors. They all cumulative leads to the tubular interstitial damage, glomerulosclerosis, mesangial expansion, and glomerular hypertrophy, which ultimately leads to the CKD progression. So these are the basically 3 drivers, which is inflammation, hemodynamic dysregulation, and hyperglycemia. And there are a variety of drugs which almost acts at these pathways only. First of all, we will be seeing the role of RAS blockage, which can be either through ACE inhibitors or it can be through the angiotensin receptor blockers. It basically acts at the hemodynamic regulation and also at the inflammatory part. What does KDIGO guidelines of 2022 says about the addition of the RAS inhibition? They say that the patient with diabetes, hypertension, and albuminuria, RAS inhibition should be added, and a patient with the diabetes, with the albuminuria, with normal BP, we may consider the RAS inhibition. But if a patient is having a diabetic and he is not having proteinuria and he is not having hypertension, then it is not recommended to add the ACE inhibitors to prevent the diabetic nephropathy in the future. How to manage the RAS inhibition in the clinical practice? We have to start the ACE inhibitors or the ARBs, and we have to monitor the serum creatinine and the potassium within 2 to 4 weeks of addition. And if patient remains normocolemic and there is no rise in the creatinine, then we can safely continue or accelerate the dose of RAS inhibition. And if patient develops hyperkalemia, then we have to see for the other causes like other drugs and addition of diuretics and soda bicarbonate or GA-cation exchanges to maintain the potassium. And if there is a more than 30% increase in the creatinine, we have to look for the other factors which leads to the AKI. And if no factor is found, then we have to put the blame on the ACE inhibitors or the ARBs, and we have to reduce or discontinue the ACE inhibitors, and only to be restarted again after a waiting period. Then coming, I won't be going to studies of RAS inhibition because this has been the traditional molecules. Everybody is aware of the studies. And we are coming to the next molecule of SGLT2 inhibitors. They are the latest oral hypoglycemic agents which have found a great role in the heart failure, in the atherosclerotic disease, and in the management of diabetic nephropathy. And it acts at all the drivers of progression of disease, may it be inflammation or it be hemodynamic dysregulation or hyperglycemia. This class of drug is acting at every possible mechanism of progression of diabetic nephropathy. This is a slide which is showing the normal tubular feedback, and in the diabetes, we can see in the diabetes there is the increased glucose and sodium reabsorption, which gets absorbed at the proximal convoluted tubule, and ultimately leading to the decrease in the sodium at the juxtaglomerular apparatus, and ultimately leading to the activation of the RAS inhibitors. And while the addition of the SGLT2 inhibitors, we can see that this efferent arterial vasoconstriction is relieved, and it leads to the benefit effects of the SGLT2 inhibitors. So by this mechanism, the beneficial effects are the control of RAS, the decrease in oxidative stress, decrease in the plasma glucose, decrease in the body weight, decrease in the blood pressure, decrease in uric acid, and also decrease in the hyperfiltration, and also promoting the glucosuria and natriuresis. So these are the basically the landmark trials which have established the efficacy of SGLT2 inhibitors in the diabetic nephropathy. Earlier SGLT2 inhibitors, they were started with the cardiovascular outcome trials, but these 4 landmark trials, they have established the safety of SGLT2 inhibitors in the diabetic nephropathy. These trials are CREDENCE trial, CANVAS, DAPA-CKD, EMPA-REG outcome trials. This is a CREDENCE trial. In this, the population which was selected had a GFR of up to 60, and ultimately it was found that there was lower relative risks of primary outcome, which was doubling of serum creatinine, end-stage renal disease or death due to any renal failure causes, was decreased by 30%, and incidence of ESRD was decreased by 32%, and renal specific outcomes, which were doubling of serum creatinine, death from renal causes, was reduced by 34%. DAPA-CKD trial, the results were pretty same to the CREDENCE trial, and the difference was the population which was selected in this group had a GFR of as low as 25. CREDENCE trial had a population of a GFR of 60, and DAPA-CKD had a population with a GFR of as low as 25. And then EMPA-REG outcome trial also, the results are pretty same, showing the benefits of the SGLT2 inhibitors, and the GFR here was 30. So these trials in the CKD, when meta-analysis was done, it was showing that the risk of dialysis, transplantation, end-stage kidney disease, acute kidney injury, they almost have a relative reduction of almost 30%. So, and going a step ahead, these SGLT2 inhibitors, they were also tried in the patients who were non-diabetic, and the GFR was even brought down to the as low as 20. So the researchers found that these beneficial effects also extended to the GFR of less than 20, and also in the non-diabetic patients with the renal disease. And now the further trials are going on, which are trying of SGLT2 inhibitors in the transplant patients and the type 1 diabetic patients also. So this is the practical guidelines to initiate the SGLT2 inhibitors. It should be started with the patients of type 2 diabetes with CKD with a GFR of more than 20 and proteinuria of a moderate proteinuria category. And once initiated, and if your patient is having a progressive CKD, its GFR is falling, it is not recommended to discontinue it, and unless patient is not tolerating or renal replacement therapy is required. So this is the slide which is again showing the initiation of SGLT2 inhibitors and the maintenance of it. And what is the AKI risk with SGLT2 inhibitors? AKI, when we start the patient on SGLT2 inhibitors, we can expect a certain dip in the GFR. So that should not be indicated to stop the SGLT2 inhibitors. Rather, we should wait and let the GFR recover, and then we have to continue with it. And obviously, risk for AKI like hypovolemia, chronic renal insufficiency, heart failure, or nephrotoxic drugs should be looked after. And sick day protocol, like we normally follow with ACE and the ARVs, like a patient with sick, excessive alcohol or dehydration, we tell the patient to avoid taking the dose on the sick days. And regarding the pre-operative care, if a patient is being planned for a daycare procedure, we skip the dose on that day. And if patient is planned for admission and surgery, then we skip normally for 2 days and 1 day after. Coming to next class of drug, which is a GLP-1 receptor agonist. This is a preferred add-on therapy. This is basically the injectable incretins mimetics, and it acts on the pathology of inflammation and hyperglycemia mechanism. And there are some direct and indirect effects of GLP-1 agonists in the progression of diabetic nephropathy. The direct effects, it includes the hemodynamic effects, anti-inflammatory effects, reduced oxidative stress, inhibition of the RAS, and increased natriuresis. And indirect effects are obviously the improved glycemic control, reduction in the blood pressure, and the weight loss. These are the trials in which this GLP-1 receptor agonists have been tried, the molecules, namely liraglutide, semaglutide, exenatide, albiglutide, dulaglutide, they have gone through various trials, and GFR of as low as 30 to 25 were chosen. And in all the trials we have seen that they have shown a promising towards the cardiovascular outcomes, and also if you look at the kidney outcomes, that is the amelioration of proteinuria or the loss of GFR, all the molecules have shown a positive response, and with no major side effects, no major side effects, but minor side effects like GI intolerance or skin infections. This is a slide which is showing a basic dose of the common GLP-1 receptor agonists used in our practice. Coming to the next class of molecule is non-steroidal mineralocorticoid receptor antagonists. Everybody knows that in the patient of diabetic nephropathy, RAS inhibition has been the cornerstone of the treatment, and mineralocorticoid receptor antagonists have been used from long back. But there is a disadvantage and risk of hyperkalemia when the steroidal mineralocorticoid receptor antagonists and ARBs or ACE are used together. So, a new molecules of non-steroidal mineralocorticoid receptor antagonists have been developed, which is finerenone. This exerts the beneficial effects of MRAs without leading to patient excessive risk of hyperkalemia. We can see that whenever there is a RAS activation, there is always a mineralocorticoid receptor overactivity, and this overactivity is pathological, leading to the inflammation and fibrosis in the kidney. And this MRA antagonist, finerenone, take care of this, and it helps the CKD and type 2 diabetic patients to slow down the progression of CKD. What are the beneficial effects of this MRAs? It decreases the tubular injury, decreases the fibrosis, decreases the glomerulosclerosis, podocyte injury, vascular injury, and mesangial expansion. So these are all the possible mechanisms of diabetic nephropathy, and we can see that mineralocorticoid receptor antagonist is playing a huge role in this management. And what are the trials favoring the implementation of this non-steroidal MRAs? There have been two trials. One is the Fidelio DKD trial, which is basically a kidney outcome trial with the secondary outcomes related to heart, and Figaro DKD trial, which was basically a cardiology trial with the secondary outcomes of the kidney. In Fidelio DKD trials, it showed the significantly reduced the risk of primary composite kidney outcomes by 18%, and cardiovascular outcomes was reduced by almost 14%. And similar results were seen in the Figaro diabetic kidney disease trial. This is a slide which is showing the population of patients which was selected with a GFR of 30 to 90 and with severely increased proteinuria. And we can see that finerenone significantly reduced the risk of GFR loss in a patient by 23%. And finerenone, it is the first non-steroidal mineralocorticoid receptor antagonist to be approved for the adults with type 2 diabetes associated CKD. And it fills a significant void of treatment. And this is a slide which is showing the dosing and monitoring of finerenone. It should be started when the potassium is less than 5, and if GFR is less than 60, the starting dose should be 10 mg once a day. And if GFR falls below 60, so if GFR is more than 60, then dose can be increased to 20. At the same time, we have to monitor for the potassium. If potassium is rising below above 5.5, then it should be stopped temporarily. This is the same slide which is showing the dosing of eGFR. If the GFR is more than 60, 20 mg. If GFR is between 25 to 60, 10 mg once a day. And below 25 GFR, we discourage the use of finerenone. Uric acid lowering beneficial. This is very controversial part, like a uric acid lowering. And traditional teaching goes that this is a endogenous nephrotoxin, it should be managed. But the research don't approve these things. The trial, like a CKD fixed trial, in which the CKD population was given allopurinol, but we can see that there was uric acid lowering by allopurinol has no effects on the CKD progression. Until and unless patient has a gout, it should be treated, but the trials don't support the use of this uricosuric drugs, halting the CKD progression. Similar results were seen in the PEARL study also, in which it was seen that the allopurinol does not have any meaningful effect in the type 1 diabetes with mild to moderate diabetic kidney disease until and unless patient doesn't have a gout. And regarding febuxostat also, it is not a different scenario. in the febuxostat, a further study was done in which stage 3 CKD were enrolled and asymptomatic hyperuricemia was treated. But compared to placebo, febuxostat did not mitigate the decline in the kidney function among patients with stage 3 CKD. So it is not recommended to treat the asymptomatic hyperuricemia in the patients of CKD. Role of protein restriction. This is a conventional teaching which is going on that kidney disease patient should be low on protein. But on the name of proteins, we are just dividing patient of the fat and carbohydrate diet. And it slows the progression of kidney disease. It is not very much research backed up. The Cochrane systemic reviews, it states that the compared with the very low protein diet, which is 0.3 to 0.4 gram per kg per day, to the low protein diet of 0.5 to 6 gram per kg per day, to a normal diet of 0.8 kg per kilogram per day, little or no effect was seen on the death of the end-stage renal disease. So, very low protein diet or low protein diet is not favoring the research. What does guidelines have to say about the nutrition? It says that the patients with the stage 3 to stage 5, not on dialysis, a protein diet of 0.6 to 0.8 gram per kg per day should be given to patient to maintain the nutrition status and optimal glycemic control. And coming to management of acidosis, we normally added soda bicarbonate in the patients of CKD whose GFR is less than 25. And research and Cochrane review has also shown that this addition of alkali therapy and reduction of the acid in the patient, it helps in preserving the GFR and slows down the disease progression. So what are the takeaway messages? First is comprehensive care. A patient who is having diabetic nephropathy should exercise, take appropriate nutrition. He should not smoke. Risk factor management should be done and pharmacotherapy should be given. Nutrition, he should take a diet high in vegetables, fruits, leguminous plants, and saturated fat should be avoided. And he should avoid processed meats, refined carbohydrates. Sodium should be less than 2 grams per day. And protein restriction to a 0.8 kilogram per kg per day is sufficient. Glycemic control regarding the A1C target. With the patients of earlier CKD, glycemic target is quite stringent of a HbA1c less than 6.5. And with the advanced CKD, the glycemic status are relaxed to be kept HbA1c of around 8. And regarding the SGLT2 inhibitors, they should be added to the metformin when the patient is having diabetic nephropathy. And they should be added when the GFR is more than 30 or more than 20, and they should be continued even if GFR is falling on the addition of SGLT2 inhibitors. And they have a beneficial role in the CKD progression, heart failure, and is a first-line therapy. And regarding metformin, we have discussed like more than GFR of 60, it should be added in full dose. With a GFR of 45, it should be half, and below 30, the metformin should be stopped. And GLP-1 receptor agonists, we have seen the trials and we have seen the molecules and their beneficial effects. And regarding the RAS blockade, everybody knows about the beneficial effects of RAS inhibitors and also the non-steroidal mineralocorticoid receptors. So it is a time to spread the word that the new therapy for the diabetic kidney disease has arrived, and we should implement it with the full heart. Thanks.
Thank you, sir. I would now like to request Dr. Sunita Goyal from Cloud9 Hospital, Ludhiana, to kindly deliver her talk on PCOD overview.
A very good afternoon to all present. Thank you, Dr. Vitull and the team to invite me here to give a talk on this PCOS. So it might sound odd, what is the obstetrician doing in a meeting of physician? But it's not a disease which is restricted. Excuse me, how to change this? So it's not a disease which is restricted. The patients are not only coming to the obstetrician. Patient with the PCOS are going to multiple specialists. Slides how to change. So a patient with a PCOS can reach anybody. First person she probably reaches is a general practitioner. She can go to a gynecologist, she can go to a dermatologist, she can go to a nutritionist, she can go to a psychiatrist. So there are so many people she can approach. So everybody must have a basic knowledge of PCOS. So September month is PCOS Awareness Month. That's for awareness of the doctors as well as public about PCOS and its effect and its optimal management and outcomes. So what is PCOS? PCOS is a heterogeneous, complex, genetic trait. We still don't know what is the etiology. It's probably multiple etiology, and it is an important cause of ovulatory and menstrual irregularity, infertility, clinically evident hyperandrogenism, and metabolic dysfunction in women. So if you talk about the, it's a most common reproductive age group endocrinal disorder. So 10 to 13% of the women, they suffer from PCOS, and I feel presently in urban area it's much more. I don't think we have any day in OPD when we don't see at least 3 to 4 PCOS patients. So it's becoming an epidemic. If you see infertility women, about 20% of the women who suffer infertility, they have basically PCOD. But the most important issue is that 70% of the affected women who have PCOS, they are not diagnosed. And 45% of the females who don't have PCOS, they get treatment for PCOS. So it's very important to make a proper diagnosis of PCOS. So it happens very often, a girl or a young woman walks into our OPD and we ask her, what is your complaint? And she says, I'm suffering from PCOS. So you have to, she cannot make the diagnosis. That's a wrong diagnosis which has been made, because maybe only the ultrasound has polycystic ovaries and she thinks, or somebody has told her that she is suffering from PCOS. PCOS is not merely polycystic ovaries. Okay, so there are 3 core components for the diagnosis of PCOS. There is hyperandrogenism, which can be clinical or biochemical. There is chronic oligo-ovulation or anovulation, and there is polycystic ovarian morphology on ultrasound. And there are very strict criteria for diagnosis of polycystic ovarian morphology on ultrasound. So there are different bodies, for everything there are different bodies, then they give their own criteria. But the one which needs to be remembered and easy is that out of this, Rotterdam has given this criteria, that out of these 3, when 2 are present, then we can label a patient as suffering from PCOS. Okay, so these are the different bodies, I won't go into detail. So, but whenever you are making a diagnosis of PCOS, you must rule out other 2 main important causes which are very common: thyroid dysfunction, you all know, and hyperprolactinemia. So they can also mimic polycystic ovarian syndrome, so they must be excluded. The rare ones are non-classical adrenal hyperplasia, adrenal or ovarian tumors, Cushing syndrome or acromegaly. These are very, very rare. But the 2 investigations which can rule out is TSH and prolactin, that they are in the normal range. Then you say that yes, this patient is suffering from PCOS. Recently, there is, recommendations are published in August 23 only from International Evidence-Based Guidelines for Assessment and Management of PCOS. They have added AMH as one of the criteria. There were a lot of studies done on AMH, but it was not added as one of the criteria. So what is AMH? AMH is a hormone which is secreted by small follicles in the ovary, preantral follicles, and because there are multiple follicles in patients with PCOS, the levels of AMH are high. So this can be used as one of the criteria for diagnosis of PCOS. So how do you diagnose a patient is having oligo or anovulation? So it depends at what age the girl has presented to you. If the patient girl is brought within 1 year of menarche, that she is having irregular cycles, prolonged cycles, that you should not make a diagnosis of PCOS, because that's the time hypothalamic pituitary axis is immature, So prolonged cycles is a possibility. So that's not because of the PCOS. Don't do any ultrasound, no further investigation. Tell the parents wait for a year and after that see what are the menstrual pattern like. In the next 2 years, diagnose PCOS if she is having irregular menstrual cycle, that is less than 21 or more than 45 days, or she has a period of amenorrhea which is lasting more than 90 days, and there is clinically or biochemically hyperandrogenism. After that, till 19 years of age, you diagnose PCOS if the cycle length is even more than 35 days. So then PCOS should be diagnosed. Ultrasound should never be done till 8 years after adolescence, because normally also polycystic ovarian morphology may be there. So if a girl achieved menarche at 12 years, till 20 years, ultrasound should not be done to make a diagnosis. So how do you say somebody is suffering from clinical hyperandrogenism? She has acne, alopecia and hirsutism. So these three features. Acne and hirsutism, very severe acne in adolescence. That is, we know some amount of acne is common in young adolescent girls, but if it is a very severe acne which is not responding to the usual therapy, then one should suspect that she is suffering from hyperandrogenism. Hirsutism, for hirsutism there is a scoring that is modified Farrin and Galway score, and if that score is more than 4 to 6, that means that the girl is suffering from hirsutism. Sonography is very, very important. We get lots of reports. The sonologist does the ultrasound and just writes polycystic ovarian morphology. But what are the criteria? So criteria depends on how many follicles you can see per ovary. And that is possible only with a TVS, when you can see all the aspects of the ovary. So follicle number per ovary more than 20. Or if you are doing a transabdominal scan, like in a sexually inactive girl, then you can do a transabdominal scan, then number of follicles more than 10 per ovary, and which are 2 to 8 millimeter in diameter, and look at the ovarian volume. So ovarian volume more than 10 ml, either in one ovary or both the ovaries, makes the diagnosis of polycystic ovarian morphology. So this has to be combined with other feature to make a diagnosis of PCOS. So polycystic ovarian appearance can also be found in certain other conditions like congenital adrenal hyperplasia, Cushing syndrome, or exogenous use of certain medications. So if you want to see the polycystic ovarian morphology on ultrasound, patient should not be on OCPs. She should be off OCPs for 3 months, otherwise you may not find the typical morphology. So how do you diagnose PCOS? So if clinically patient has irregular cycles and hyperandrogenism, you don't need further investigation. Diagnosis is made after you have excluded other causes. But if there is no clinical hyperandrogenism, then you can test for biochemical hyperandrogenism by doing investigations. And if either only is present, if only clinical hyperandrogenism or irregular menstrual cycles, then you can go for ultrasound. So what are the investigations? Basically, actually investigations are not really required to make a diagnosis, but to exclude the other causes. Like I already said, you test the thyroid, you test the prolactin, you test for hyperandrogenism biochemical by doing a testosterone level. 17-hydroxyprogesterone and DHEAS are done to rule out other secondary causes. And all these patients should have a baseline lipid profile, and one should test for insulin resistance by doing a fasting glucose test and the oral glucose tolerance test. So I already said in a young girl, make the diagnosis with caution. That may be a normal immature hypothalamic axis, and similarly in perimenopausal women. So generally PCOS starts in the reproductive age, it doesn't start in the perimenopausal age. So the previous history is important when you diagnose PCOS in perimenopausal women. So most of the women who have PCOS, they are obese. 70 to 80%, their BMI is generally more. But recently it has been found that certain thin women also have PCOS. So they are known as lean PCOS. Generally the diagnosis is delayed in them, but they have the same basic pathology as in the obese PCOS. So if we see across the lifespan, when the girl is in the adolescent age, it is more of a reproductive problem. But when the woman reaches menopause, it becomes more of a metabolic problem. So why we are so much bothered about PCOS? What are the risk factors? What is the implication of PCOS? PCOS affects, it causes lot of problems at every stage of life. So we know, already said that it causes irregular menstrual period, infertility. If the woman conceives, PCOS woman conceives, she has high risk of preeclampsia, gestational diabetes, premature birth, increased incidence of cesarean section. PCOS affects the metabolic function. It causes obesity, type 2 diabetes. It is associated with dyslipidemia, hypertension, sleep apnea, and like in the morning Dr. Ravinder Garg talked, it is the fatty liver, NAFLD. So it is the liver component of metabolic dysfunction. It is associated with endometrial cancer. Now even with ovarian cancer, it is suspected that it may be associated with increased incidence of ovarian cancer. It affects the mental health. The children, the young girls tend to be depressed, they are anxious, they have eating disorder, they have reduced quality of life, they have negative body image because of hirsutism, acne, obesity, acanthosis. So they have negative self-body image, and because of that they go into depression. It is also associated with cardiovascular disease, so myocardial infarction, strokes. So that is why a proper management of PCOS is very, very important. So there are different types of PCOS. Why they are important is that the ones which have both the features, hyperandrogenism as well as ovulatory dysfunction, they are worse off. They have more of insulin resistance, cardiovascular risk, and the glucose intolerance. Those who have only hyperandrogenism or oligoovulation associated with polycystic ovarian morphology, they are better off. So you see your patient falls into which phenotype, and accordingly you prognosticate the patient. So etiology is not clear, genetic, familial histories are there, and some epigenetic modification have also been implicated. So basically in the, when you see the pathophysiology, there is a hormone imbalance. LH is increased much more as compared to FSH. There is hyperandrogenism and there is insulin resistance. So leading to the various risk factors of various diseases. So this is again about the pathogenesis only, how it affects the whole body system, not only the reproductive system. So what are the goals of treatment of PCOS? So goals depends at what age patient has come. Is she an adolescent girl who requires a regular cycle? Does she require the treatment of hyperandrogenism features? Does she require pregnancy, ovulation induction? Does she require contraception? Or the metabolic abnormalities have to be taken care. So you have to see your patient, what is required for your particular patient. But the basic of PCOS management is lifestyle changes. So that is the core. I won't go into detail because I think every lecture is stressing on lifestyle modification. And I think in our OPD, I was just telling my resident yesterday that probably out of 20 patients, if I see, the 15 patients I am stressing on lifestyle modification. Whether it is pregnant women or it is PCOS women or women who come to us with gynae diseases and have associated diabetes and hypertension. So it is duty of every doctor to sensitize the patient how important it is to make lifestyle changes. Even 5% weight loss in PCOS that regularizes their cycle, decreases their weight, and the patients are happy. So it's a very common history. Patient tells she joined gyms for 3 months, her periods became regular, now she has stopped, now the periods have again become irregular. So lifestyle is the core, management is the core of PCOS treatment. So if the patient is not improving with your lifestyle modification, exercise, diet, she's not losing weight, you can even consider anti-obesity drugs like recently liraglutide and semaglutide. They have been advocated for reducing weight. Even bariatric surgery can be carried out in very morbidly obese women, even at a lower cutoff as compared to the one with the morbid associated condition for PCOS. But one thing you have to tell these patients that once they have a bariatric surgery, they can conceive very fast. So 1 year they must use effective contraception after the surgery and should not conceive. Irregular cycles, so it depends on which age group the girl is. If she is less than 40, her BMI is less than 30, you can put her on oral pills, especially the ones which contains hyproteron. Or if she doesn't want the regular medicine, she can take progesterone withdrawal every 2 months. She must menstruate at least 6 to 8 times in a year. If it is more than 40, avoid COCs and give progesterone. A married woman who is anxious to conceive, you induce ovulation, and if she is concerned with amenorrhea only, then same way you can give her OCPs or progesterone withdrawal treatment. Ovulation induction, again weight loss is the first intervention. If that's not working, you can go for ovulation induction. I will not go much into details of this. So many drugs are there, and IVF and laparoscopic ovarian drilling, these are the many options. Hirsutism. That's the main concern of these young girls. They develop hirsutism. So they have to be concerned that whatever hair has come, that will not go with the treatment. We can only prevent new hair from developing. The hair which have come already, they have to be removed by various methods, lasers, epilation, waxing. So different methods have to be used. If a hirsute girl is planning to conceive, you cannot give her any drugs. Because whatever the drugs we give for hirsutism, patient they will cause teratogenesis, and patient should not conceive while on treatment. So first find out what is her plan about pregnancy, and then only give for treatment for hirsutism. So you can give COCs, combined oral contraceptive pill with cyproteron. If that's not working, there are various anti-androgenic drugs like spironolactone, chlorodione, and finasteride rarely used. Contraception, again COCs are the best. They can use progesterone only pill or LNG IUS, which will prevent against endometrial hyperplasia and endometrial cancer also. Metformin has a great role in PCOS, because we have seen that one of the basic things in PCOS is insulin resistance. So indication of metformin are any adult whose BMI is more than 30, even adolescents, whose history is like suggestive of PCOS, for them also metformin can be given. Metformin is also used along with ovulation induction agent if ovulation induction agents alone have failed. So it leads to better ovulation and patient can conceive. It's a category B drug, so absolutely safe even when patient conceives when she is taking the drugs. Other recent drug is myoinositol and inositol. That is also a insulin sensitizer, sensitizer only, decreases the insulin resistance and improves the ovulation function. For preventing the endometrial hyperplasia and malignancy, because it's a hyperestrogenic condition, you have to give regular progesterone every 2 months withdrawal, or LNG IUS can be given. And these women, even at a very young age, if they have abnormal uterine bleeding, they should be investigated, and endometrial sampling should be done to rule out endometrial cancer. So there are cases, even less than 40 years they may develop cancer if the disease is not taken care of. So carry on messages are, I'm just summing up, it's a hyperandrogenic state, especially of ovarian origin. So exercise portion, then you are diagnosing in adolescent and elderly, and make a proper diagnosis on 2 of the 3 criteria: COC or progesterone withdrawal bleeding to regularize the cycle, and for prevention of endometrial cancer. Mechanical methods to get rid of established hair. COC with cyproteron helps in decreasing the regrowth of the hair. Induction of ovulation for infertility. Weight loss through lifestyle changes and exercise helps reducing the metabolic syndrome and improving the ovulation. Prove the insulin resistance by GGT, especially in obese, before you start metformin, and you should regularly screen them for diabetes and for cardiovascular risk factor. Thank you for a very patient hearing.
Thank you, ma'am. The next talk is on the topic Approach to a Patient of ABPA. The talk will be delivered by Dr. Ramnivas, DM Pulmonology, AIIMS Bathinda.
Good afternoon, everyone. First of all, I want to thank the organizing team for giving me this opportunity. So, I will be discussing about ABPA, that is allergic bronchopulmonary aspergillosis. So, I will start with some introduction to Aspergillus species and its virulence factor, various spectrum of pulmonary aspergillosis, epidemiology of ABPA, pathogenesis, clinical feature, various diagnostic criteria, and the treatment approach. Aspergillus is a ubiquitous saprophytic mold, and it has more than 200 species, and most common is Aspergillus fumigatus. It has very high sporulating capacity. Aspergillus conidia, the diameter of conidia is very small, that is 2 to 3 micrometer, and that they can easily penetrate the bronchiole and alveoli. The hyphae are acutely angled, and they can be stained with KOH, PAS or Bomori, methenamine, silver staining. These are the various virulence factors. So we have cell wall components like beta-glucan, serum galactomannan, and chitin. In cell wall, there are various proteolytic enzymes like proteases, elastase, and phospholipase. The fungus also has ability to form the biofilm. Melanin enhance the resistance to get phagocytosis, and thermotolerance enable the aspergillus to grow at the body temperature. Now, once the Aspergillus fumigatus conidia adhere to the respiratory epithelium, then it germinates into the hyphae, and hyphae will ultimately evoke the host response. The host response may be immediate response or early phase response or late phase response, and ultimately this immune response will recruit various inflammatory cells like mast cells, eosinophils, and monocytes, and they will lead to tissue injury, that is cytokine mediated, and airway inflammation, mucus plugging, bronchiectasis, and at later stage pulmonary fibrosis. This is the spectrum of various Aspergillus pulmonary disease, and the spectrum of Aspergillus disease depends upon the immunity of the host and the underlying lung condition. So if patient is immunocompetent and underlying lung is also normal, in that condition a patient usually do not develop the invasive aspergillosis, and there may be some hypersensitivity reaction. So patient may develop fungal sensitization, ABPA, or some hypersensitivity syndrome. If a patient is immunocompetent and the lung has some structural lung disease or some chronic inflammatory lung disease, patient may develop aspergilloma or chronic pulmonary aspergillosis or some semi-invasive form of aspergillus. If patient has severe immune deficiency, in that condition patient may develop invasive form of pulmonary aspergillosis. Now coming to epidemiology, first case report of ABPA was published in 1952 in UK by Hinson et al. If we talk about prevalence, the true prevalence is unknown because there is no community-based study, but there are hospital-based study, and it is found that around 1 to 2% of patients of asthma have ABPA. If we talk about ABPA prevalence at referral center, then the prevalence is 13% in asthma patient at referral center, and it is 2 to 9% in cystic fibrosis patient. So if we consider the 2% of ABPA prevalence worldwide, the global burden of ABPA is around 5 million. And in India it is 1.4 million, considering the fact that in India there is high prevalence of ABPA in asthma patients as compared to the Western counterpart. Now, almost 30% of patients of ABPA may be misdiagnosed as tuberculosis or other chronic inflammatory disease, and there may be delay in diagnosis also. This is the study that was published in 2020 by Agarwal et al. And they have shown the range of aspergillus sensitivity around 5.5 to 35% and prevalence of ABPA in asthma patient with a range of 2.5 to 22%. So as high as 22% of patients may have ABPA in asthma. Now coming to clinical feature, as most of the patients of ABPA have underlying asthma, so patient may present as uncontrolled asthma. Patient may have symptoms like breathlessness, cough, wheezing, hemoptysis if there is central bronchiectasis, expectoration of brownish black mucus plugs can also be seen. On examination, patient may have signs of airflow obstruction, clapping, signs of pulmonary hypertension, poor pulmonary bronchi and coarse crackles. These are the various diagnostic modalities. So we have various serological tests like skin prick test, IgE specific to aspergillus, total IgE, serum precipitin or IgG specific to aspergillus, eosinophilia, etc. And in imaging, the gold standard is HRCT chest. If we talk about the most sensitive test, most sensitive screening tool, then IgE specific to aspergillus is the most sensitive test, and this is the study published from PGI. They have shown the diagnostic performance of various tests, and they have shown that if we take a cutoff value of more than 0.35 of IgE specific to aspergillus, the sensitivity is almost 100%. Now, serum total IgE is the one of the important essential criteria to diagnose ABPA, and usually we take cutoff value of more than 1000. That was suggested by the latest ISAM group. If you take the lower cutoff, that is suggested by Patterson et al., the specificity of diagnosing ABPA will decrease. So we usually take the cutoff value more than 1000. And another important feature of serum total IgE is that it is used for monitoring the response. Coming to the serum precipitin or specific IgG against aspergillus. So serum precipitin is the surrogate marker for specific IgG, and the sensitivity is very low. It is 27% as compared to IgG specific. So if we take the cutoff value of 27 milligram per liter of specific IgG, then sensitivity is 89% and specificity is 100%. So it is a very good Riolin test. Now coming to various HRCT finding. So most common finding is central bronchiectasis. Another finding may be the mucoid plugging with bronchoceal, consolidation or fleeting infiltrates, central lobular nodule between bud appearance, bronchial wall thickening, area of atelectasis, etc. Now coming to uncommon finding. So high attenuated mucus, that is HAM. HAM is the most specific finding of HRCT. There may be some other uncommon feature like pleural involvement or some randomly scattered nodular opacities. This is the axial cut of CT scan of one of our patients, and you can clearly see that there is a bilateral central bronchiectasis. This is another patient with bilateral bronchiectasis. In this CT in the mediastinal window, you can see that there is high attenuated mucus inside the bronchiole. And here you can see the pleuroparenchymal fibrosis along with bilateral bronchiectasis. So these are the various imaging features. Now coming to other testing, so sputum examination is not very important for ABPA. Though we can do sputum examination if we have some other differential like tuberculosis or other invasive form of fungal infection. PFT is done to know the overall lung function. Galactomannan is very important test for invasive aspergillus, but it is not a good investigation for ABPA. This is the evolution of various diagnostic approach. As I earlier mentioned, that the first case report was published in 1952. First diagnostic criteria was proposed by Rosenberg in 1977. In 1999, these criteria was updated by Greenberger, and in 2013, ISAM group proposed the new criteria, and that these criteria were also updated in 2016. These are the Rosenberg criteria. There are major criteria and minor criteria. So to diagnose ABPA, 6 out of 8 major criteria must be present. So these are asthma, transient pulmonary infiltrate, immediate cutaneous reactivity, elevated total serum IgE, precipitating antibody against aspergillus, peripheral blood eosinophilia, elevated IgE and IgG specific to aspergillus, and central bronchiectasis. These are the minimal essential criteria given by Greenberger, and these are the latest criteria. So on the right side you can see the updated 2016 latest criteria given by the ISAM group, and it has 3 domains. One is predisposing condition, another is essential criteria, and last is additional criteria. So in predisposing condition, there may be bronchial asthma, cystic fibrosis, COPD or post-TB fibrocavitary disease. So out of these predisposing condition, some of these should be present. Next is essential criteria. So in essential criteria, there are 2 immunological tests that must be present. So serum IgE specific to aspergillus more than 0.35, and increase in serum total IgE more than 1000. So these 2 tests should be present, and the additional criteria have 3 points: serum IgG specific to aspergillus more than 27, thoracic imaging consistent with ABPA, and peripheral blood eosinophilia more than 500. Now this is radiological classification, and the latest classification is given by ISAM group. So they have classified into 4 groups: ABPA-S, ABPA-B, ABPA-HAM, and ABPA-CPF. So if there is no radiological abnormality, so in that case we classify as ABPA-S, that is serological ABPA. If there is bronchiectasis, then we classify as ABPA-B. If along with bronchiectasis there is high attenuated mucus, then it is classified as ABPA-HAM. And if there is chronic pleuropulmonary fibrosis along with bronchiectasis, then it is classified as ABPA chronic, ABPA-CPF. Now, once we diagnose the ABPA patient, we have to stage for further management. So this is the latest staging given by ISAM group, and they have staged into 6 groups. Step 0 is if patient is asymptomatic. So asymptomatic stage is stage 0. If patient have uncontrolled asthma or acute symptoms, then this is stage 1 or stage of acute symptoms that can be further divided into stage 1A and stage 1B on the basis of mucoid impaction. If patient have clinical or radiological response along with decrease in more than 25% of IG, total IgE, then it is classified as stage of response. If there is clinical or radiological worsening after starting of treatment and there is increase in more than 50% of IgE, then it is classified as stage of exacerbation. If there is sustained clinical or radiological improvement for more than 6 months, then it is staged as stage of remission, stage 4. And if patient has treatment dependent ABPA or have more than 2 relapse within 6 months of stopping treatment, then it is treatment dependent asthma, treatment dependent ABPA. And if there is patient have certain complication like core pulmonary chronic type 2 respiratory failure or extensive bronchiectasis, so these patient is classified under advanced ABPA. Now coming to treatment. So goal of treatment is to control asthma, to control the acute stage of ABPA, to control and treatment of exacerbation, to mitigate the progression of bronchiectasis. These are the various drug targets. The most important drug is oral glucocorticoid. We can also give some antifungal treatment like itraconazole, voriconazole or posaconazole, and we have biological also that can be given if steroid patient is symptomatic even on steroid and antifungal therapy. So in corticosteroid we have 2 regimens, regimen 1 and regimen 2. Regimen 1 is milder dose and with lower duration, while regimen 2 is given at higher dose. So in regimen 1 we give prednisolone 0.5 mg per kg per day for 1 to 2 weeks, then on alternate day for 6 to 8 weeks, and then we can taper 5 to 10 mg every 2 weeks and discontinue. And we should do the repeat chest X-ray and serum IgE after 6 to 8 weeks of therapy. This is regimen 2. So in regimen 2 we give prednisolone 0.75 mg per kg per day for 6 weeks, then 0.5 mg per kg for next 6 weeks, and then we can taper down 5 mg per 6 weeks and discontinue after 6 to 12 months. And we should also do serum IgE level every 6 to 8 weeks to see the clinical response. Now this is the study that published in ERZ 2016, and they have compared the 2 regimens, and they have shown that the exacerbation after 1 year and that glucocorticoid dependence was almost similar. There was no statistically significant difference, but there was a higher side effect profile if we use the regimen 2. So they concluded that medium dose oral glucocorticoid are as effective and safer than high dose treatment of high dose steroid. Now coming to antifungal therapy. So antifungal therapy are reserved for patients who are not willing to take steroid, or there is recurrent ABPA, or patient is steroid dependent as ABPA. Common agents are itraconazole, voriconazole and posaconazole. Itraconazole is the cheaper option, and voriconazole and posaconazole is the safer option. We give itraconazole with a dose of 200 mg twice a day for 16 weeks, then we can decrease the dose to 200 mg once a day for 16 weeks. Indication we have already discussed, and we should also monitor for various adverse effects and clinical response. And if patient does not have significant clinical response, then we should also do the serum level of serum drug level of itraconazole. This is another study that compared the itraconazole versus prednisolone. This was published in CHEST 2018, and they have reported that the composite response was 100% with prednisolone as compared to 88% in itraconazole. And this is another study in which prednisolone was compared with combination therapy, that is prednisolone with itraconazole. And the primary outcome and secondary outcome was almost similar, but the side effect profile was higher in the combination group. So the current standard of treatment is oral glucocorticoid therapy as compared to antifungal therapy. And now coming to other treatment modalities, so we have nebulized amphotericin B, inhaled corticosteroid, and various newer modalities. So nebulized amphotericin B can be given as a maintenance therapy, but the good quality studies are not there. Although the time to first exacerbation, there are few small RCTs, and they have shown that the time to first exacerbation or number of exacerbation are lower as compared to if we use placebo. Inhaled corticosteroid, as most of the ABPA patients have underlying asthma, so we have role of inhaled corticosteroid, but in ABPA there is no role of ICS. And newer modalities like omalizumab, mepolizumab, and benralizumab can be given if patient is symptomatic, even on steroid with antifungal therapy. I am just running through these slides. So now coming to adjunct therapy. So we can use nebulized hypertonic saline and mucolytics if for better bronchial toileting. If patient have collapse of the lung with mucus plugging, bronchoscopy can be used. Pneumococcal and influenza vaccination are also very important, because the reason behind most of the exacerbation is because of some bacterial infection or some viral infection. Environmental control to decrease the ongoing exposure to aspergillus is also very important. And last resort is the lung transplantation in the last stage of ABPA. These are the various complications of ABPA. So patient may have recurrent asthma, exacerbation, bronchiectasis, pulmonary fibrosis, respiratory failure, PAH, poor pulmonary due to prolonged or chronic hypoxia. Patient may have acute invasive pulmonary aspergillosis, aspergilloma, chronic pulmonary aspergillosis, and recurrent infection. So the take-home message is ABPA primarily affect patient with asthma or cystic fibrosis. Up to 22% of asthma patients could have ABPA. ABPA patient initially present as uncontrolled asthma despite optimal treatment. Pathogenesis is mainly due to type 1 and type 3 hypersensitivity reactions. And IgE specific to aspergillus is the key screening tool. And ISAM criteria are the current standard for diagnosis and staging. And first line treatment is oral glucocorticoid, and antifungal agent are reserved for if there is recurrent ABPA exacerbation or steroid dependent ABPA. Thank you so much.
Thank you, sir. Now I would like to call upon the stage Dr. Arvind Sharma, who is a consultant gynecologist and endoscopic surgeon in Bathinda, for his talk on the topic cervical cancer, utility of vaccinations.
Well, so first I'll give a small, short introduction, the practical or clinically oriented facts about cancer of the cervix, and thereafter a short presentation on the vaccination. So till now, you see amongst women, the commonest cancer till the turn of the century, everywhere it was cervical cancer, cancer of the cervix. Most of the women, means the cancer unique to women, important ones are breast cancer, cervical cancer and ovarian cancer. And all three may be lethal if not managed well or if not detected early. These will be, they kill so many women, statistics you can look up, but so this is how you can see the lesion on the cervix. It is very easy to detect when the growth has started. It's already a tumor with bleeding or irregular appearance on the cervix. A simple speculum examination, which everyone knows who has passed out his MBBS, a simple speculum examination will detect a cervical growth, exophytic growth. So, just to say that it is still important, the cervical cancer, though in more privileged societies, the breast cancer has now become more common than cancer of the cervix. It's number 2 now. But in the poor population, we have a lot of poor people, more poor people in our country compared to rich people or privileged people. So in them, still cervical cancer is commonest. Sorry. Gross clinical appearance, on the left side we are showing normal cervix, as you must have all seen during speculum examination, which is the basic part of clinical examination. You don't have to be a gynecologist to do speculum examination. You just, in any OPD with a SIM speculum or even Cusco speculum, you can examine the cervix. So cervical cancer looks something like this. When it has developed fully, the frank cancer is on the other side of the slide, and it's usually an exophytic growth, cauliflower type growth we कह देते हैं, एक ही बात है. So exophytic growth, irregular margins, the appearance is almost confirmatory, and still you have to do a biopsy to confirm and treat. But we are, so this is how it kills the patient. Initial stages are asymptomatic. Stage 1, which is confined to cervix. There are preclinical lesions also, well-defined preclinical lesions, which take several years to become cancer. But once the invasive cancer develops, then within a matter of months, it starts spreading. And it spreads loco-regional spread, which means to the contiguous tissues and to the regional nodes, which are pelvic nodes, and then thereafter onto para-aortic nodes later on. Then less common is distant metastasis, which is lungs, liver, etc. That is less common. This cancer of the cervix kills the patient by obstructive uropathy. The malignant infiltration of the pelvic part of ureter is, we can do stenting and palliative procedures, but finally it is incurable. Once the disease has spread into all over the pelvis, it will obstruct the ureters permanently. So then, and most of the patients, that's something very good, that the old ladies who have it, they die a sweet death due to uremia and incurable uremia. But then that's not what we are concentrating upon. We are concentrating upon the prevention and screening aspects of it. Now, cervical cancer is one cancer which has very well defined stages of initiation of cancer, thereafter pre-cancerous stage, and thereafter invasive cancer. And it takes several years. बहुत टाइम होता है कि उसको पहचान लिया जाए पहले. So, a short thing about the oncogenesis. You know that there are several viruses which are oncogenetic, like hepatitis B and human papilloma virus, which I am going to talk about. Epstein-Barr virus also, that's known for a long time. But then this was just about 30 years ago that HPV's association with cancer of the cervix was found out. So it's more recent development than hepatitis B, or which we knew already. But the process which happens is like this, that at puberty, when in every girl who attains puberty, uterus starts enlarging, and cervix also starts getting everted into the vagina because of influence of the sex hormones, estrogen mainly and progesterone, and thereafter it's a part of the sexual maturation. The exposed part of the endocervical canal, that is the cervical canal, has columnar and cuboidal epithelium, and once it gets exposed to vaginal environment, which is acidic, it undergoes squamous metaplasia. Vagina में epithelium ही रह सकती है, squamous epithelium. Columnar या cuboidal नहीं होती because of the environment. So the epithelium has to change to become squamous. And squamous epithelium, squamous metaplasia which occurs, it occurs in orderly manner, which is called typical squamous metaplasia. But if it goes haywire, which means due to some factors, if in the teenage there are some factors which act upon it, then the squamous metaplasia, which should be typical, becomes atypical. That is the beginning of the trouble. पर अभी कुछ नहीं हुआ, patient is asymptomatic, no one knows. And thereafter, as I said, it develops into, first of all, atypia, atypical squamous metaplasia. Few years it takes to develop into intraepithelial neoplasm, which are called CIN, cervical intraepithelial neoplasia, and thereafter CIN is also called dysplasia. And thereafter dysplasia progresses from mild to moderate to severe, and then finally it may go to invasive cancer, which is the real cancer of the cervix. So, what a wonderful thing that there is so much time which nature has given us, or the natural history of the cervical cancer gives you. You can detect it at, if someone who's predisposed, you can detect it at 25 years of age, 30 years, 35. Invasive cancer usually will present after 45 or 40, but it's variable. So this concept is most important to understand, that normal cervix is first there, and mainly at puberty when hormonal changes occur and metaplasia starts. And if sexual activity happens at that time, during sexual activity, if it is, especially if it is regular, teenage sex will make this squamous metaplasia atypical. So that is HPV infected cervix. But most of the times, if the immunity is good, HPV is not a very virulent infection. It will get resolved. Body की immunity उसको खत्म कर सकती है. That is why not everyone gets. Everyone gets squamous metaplasia. Some get atypical. If HPV also comes, which means human papillomavirus, certain strains. HPV virus has more than 100 strains, and only about 8 strains are oncogenic. बाकी सारे benign हैं. HPV infection is almost universal in sexually active women or even men. Penile warts हो जाते हैं, कईयों को नहीं भी होते. And so it is associated with sexual intercourse. The so-called wart virus is so common that if you have normal sexual intercourse, the wart virus, either from skin or from environment, it will go in. So the early stages of HPV infection, a majority regress. Then third, precancer. Precancer also. The milder forms of precancer also can regress because HPV, again, the immunity of the body, it can kind of deactivate the virus. But then advanced stages of precancer, once it goes to advanced stages and it has not been detected by screening, then it definitely will progress to invasive cervical cancer, which is the real cancer of the cervix. And risk factors, we know, as mentioned on the slide, viral factors are there, that is oncogenic types of HPV. And its viral load, how much HPV has been transferred onto cervix. Then there are host factors, genetic factors, and all these are linked to lifestyle factors also, that you know, because lifestyle influences your immunity. So cancer immunity is important. Immunity सिर्फ infections की नहीं होती है. Cancer तो cancer भी prevent करती है immunity. So these are well-known risk factors, but the main important risk factors for development of dysplasia, which means pre-cancerous stage of cancer and thereafter ultimately cancer, is early age at first coitus, which means teenage sexual activity. Adolescence में, जैसे मैंने बताया कि वो the cervical epithelium is unstable, it's undergoing squamous metaplasia, and introduction of HPV virus and incorporation of its genome into the host genome, into the host cells, will result in carcinogenesis. So these two things, early marriage and HPV, are the main things. Others are secondary factors, which means multiple sexual partners, poor hygiene, things which lower your immunity like smoking, multiple pregnancies, etc. That's human papillomavirus. It doesn't have a shell or coating, but capsid is there. Capsid protein is there on the surface. So on the left side, we've shown that HPV 16 and 18 are the main types which can cause cancer. HPV 16 and 18 are oncogenic. The other types, as I said, it's more than 100. So other types just cause simple warts, condylomata acuminata. Anogenital warts हो सकते हैं, even skin पे भी warts हो जाते हैं. Those are other strains. Pathogenesis, as I've already mentioned, this is just a histological picture that typical squamous metaplasia on cervix happens in every girl who attains puberty, becomes mature. But presence of HPV infection, which is mainly due to sexual intercourse, may not, but may make it atypical metaplasia, beginning of atypia. Then atypia progresses to dysplasia, dysplasia progresses to cancer. We've already discussed. So all this, in every cancer, this will depend upon an interplay of host immunity and certain offending factors. Now we come to screening, which is very important. Screening means, because you know that so many cancers, they start de novo without any well-defined pre-cancerous stage, pre-invasive stage. Carcinoma in situ सभी cancers का नहीं होता है. Even carcinoma in situ से पहले dysplastic stage भी नहीं होती है in most of the cancers. And it's only cervix presents such a model which is unique that 5 साल एटीपिया रहेगा, 10 साल अर्ली डिस्प्लेजिया जिसको CIN बोलते हैं, CIN1 बोलते हैं, उसके बाद 10 साल CIN2 and 3 सीवियर डिस्प्लेजिया रहेगा और उसके बाद कैंसर बनेगा. इतना टाइम है, but that time is lost because of lack of screening. So cytological screening, you know that it is just by the turn of the 19th to 20th century, 123 साल पहले, Papinicolo was a cytologist interested in gynecology. He devised this cellular study of cervix. At that time, sexual revolution was occurring in Europe, and due to promiscuity, cancer of the cervix was very, very common in Europe. Radiotherapy was started, radical surgery was started there, and so this man was the founder, and then pap smear जो हम करते हैं वो that detects his hypothesis became a theory, and then it became a fact and practice. So this is cytological screening, which is important. The other screening things, I'll come about it later, when cytology is not available in poor parts of the country or less privileged parts of the country like ours. So VIA and VILI, Via Villi are the other methods. So these screening by cytology can be done by any doctor. The gynecologist is not required. And simple speculum examination, and this spatula is available as you can see in the picture. The smear is made from this and sent to the lab. Now we must again understand that real screening for any disease which is epidemiologically important should be population-based screening, not hospital-based screening. I have seen in certain corporate hospitals in other cities like Apollo Fortis saying that cancer screening is done here as a part of their PR or advertisement campaign. Hospital में cancer screening तो उनकी होगी जो वो किसी और problem के लिए आते हैं. So that is called limited opportunistic screening. Conventional cytology was just scraping with a wooden spatula, but now for the 20 years, for the past 20, since the beginning of this century, we have a better method which is called liquid-based cytology or LBC. So that has a broom-like cytobrush. You can see the one with the long stalk, and then a liquid fixative is provided along with that. That's the ready-made kit available for this. You can see the difference. जो पैप स्मीयर हम बनाते हैं उसमें अगर हम स्मीयर करते हैं स्लाइड तो नॉन यूनिफॉर्म होती है वो, स्पेशली क्योंकि हम गायनेकोलॉजिस्ट है, इतने पैथोलॉजिस्ट भी नहीं है, तो वो uneven slide आप देख सकते हो on the other part. Whereas this thin prep, because liquid based cytology, the entire material gets dissolved in the liquid, which is ethanol basically, and then it is proper lab people do it themselves. Such a beautiful uniform slide. So this is a much better method, even though that means at least 20% improvement in sensitivity, specificity, etc. So pathologist के लिए भी आसान है, जो conventional pap smear जो टेढ़ा मेढ़ा या uneven बन जाता है, वो that looks something like this to the pathologist, difficult for him to interpret. Whereas thin pap test, which is same as LBC, gives more clear, uniformly stained and better interpretable slide. ये सामने है. तो this is just a comparison के जो conventional pap smear है screening का wooden spatula से लेते हैं, वो दूसरा हमें cytobrush और broom मिलता है, which has very fine plastic bristles and these are rotated onto the cervix. And the same thing which I've already said, that the slides are better. This is how liquid-based cytology sample is collected. The central bristles are longer to reach at least the middle of the endocervical canal, and the peripheral bristles take it from the ectocervix and the squamocolumnar junction, which is also called transformation zone. जो मैंने बताया कि जब मेटाप्लेजिया होता है तो एक छोटा सा जोन बन जाता है कि where squamous epithelium has replaced columnar epithelium, और वही जगह है जहाँ पे फ्यूचर में कैंसर स्टार्ट होना है. तो this is how screening is done. Now there is also another test for screening used now without cytology, that is just HPV DNA in cervical secretions. Cervical secretion pipette से ले लो, dropper से ले लो, कैसे मर्जी ले लो, और send it for HPV DNA. This is also acceptable as a screening method, but not available. See, that is PCR test, expensive, and it's not available as a part of public health program. So हमें cytology पे ही depend करना है. But now talking of these hi-fi things, as I said, the majority of our population is poor, underprivileged. तो वहाँ पे cytology भी afford नहीं कर सकते, और national program कोई नहीं है जो मुफ्त cytology करता है. लोगों की करनी चाहिए पर नहीं करते. So for health workers who are available in the field, there are two simple methods for screening without cytology. And those are called via and villi. Via and villi are these methods. Simply any nurse can be taught or health worker can be taught to do a speculum examination and put a diluted acetic acid. In the first picture you can see that any area with dysplasia will stain white. It's called aceto-white area. If they find such area, they have to send the patient to institution, the referral center, referral hospital nearby, so that a colposcopy, biopsy, etc., further investigation of this can be done. The other test is, after this, first they do with acetic acid, then Lugol's iodine diluted again 5% is poured onto the cervix, and normal cervical epithelium stains mahogany brown. Mahogany means dark brown. आप देख सकते हो डार्क ब्राउन है. जो the yellow patches, if they are seen, yellowish patches, those are suspicious. वो diagnose नहीं होता है उससे कुछ, पर suspicious है and need further investigation. So this is a very simple screening method. गांव में जहाँ भी है health workers should be taught, but अभी तक नहीं है. ये भी नहीं. Some states have started. State governments have started this screening because of the prodding by gynecologists. This simple method to be done by health workers is really useful. जहाँ पे cytology, जहाँ पे तो मतलब पढ़े लिखे लोग भी नहीं करवाते cytology, तो अगर कर दी जाए किसी की as a public service तो बहुत अच्छा है. Now, in short, prevention. First of all, most effective thing for prevention is HPV vaccination. It doesn't give 100% prevention. It's about 70 to 80% protection it gives against cervical cancer. Then, obviously, as we have already discussed that sexual practices and lifestyle habits. Sexual practices, again, avoiding sexual intercourse during teenage is one way to avoid cervical cancer or dysplasias. Lifestyle habits, they definitely affect your immunity. So, as I said, majority of HPV infections can regress if the girl or the young lady is careful. Secondary prevention, you know, is screening, early detection. Early detection को secondary prevention बोलते हैं. तो and then if something is found, the further workup is required. See, cytology पे अगर कुछ भी आ जाए, severe dysplasia, which means CIN grade 3, in cervix, a biopsy is mandatory. It's not the same as FNAC cytology from the breast lump. Cytology from breast lump, if malignant cells are seen, you can proceed with treatment, mastectomy or whatever. It doesn't require histopathological confirmation, because if pathologist says that malignant cell dekhe maine in cytology, then that's final. But in cervix it's not final because of comparison of data. And so a guided biopsy by colposcopy or acetic acid application etc. is required to decide upon the appropriate treatment of cervical lesions. Tertiary prevention यही होता है कि जो disease जिसको हो गई है उसका सही treatment हो जाए. And the two things which we have for treatment of cervical cancer are radical surgery, so-called radical hysterectomy with node dissection, and chemoradiation, which is given concurrently in cancer of the cervix. So recommendation, screening कब और कितनी करवानी चाहिए? See, on the left side I have mentioned the American recommendations, and on the right side I have mentioned Indian recommendations. The American criteria cannot apply here. We have such a vast population, and health coverage cannot be, slowly शायद हो जाए कुछ साल में, but it's really difficult to achieve. And our gynecological association, it's called FIGO, Federation International, and FOXY in India are prodding the government to start public health programs like this. Anyway, the international screening recommendations are that you start screening for cervical cancer. That means cervical cytology, whether by pap smear or preferably by LBC, within 1 year after the start of sexual activity. So, usually marriage, but see, in promiscuous societies, premarital sex is really common. So, हमें उससे कुछ नहीं लेना है, married, unmarried या कुछ जिसकी sexual activity है, that girl must start having cervical smear within 1 year of starting the sexual activity. And up to the age of 29 years, it's every 3 years that a cervical cytology is sufficient. Even once in 5 years also may suffice. After the age of 30 to 65, the same thing can be continued कि cytology हर 3 साल बाद करवाओ. अगर if co-testing is available, which means cytology with HPV DNA detection, then every 5 years is sufficient. ये 3 to 5 years लंबा समय है. It's just because the dysplasia takes several years and you have time. कितनी wonderful बात है, कितने majority of other cancers don't have such a thing. Now, in countries like ours, low resource settings, poor people, underprivileged people, and then adding on to refugees, Rohingya refugees, and illegal migrants coming and living in shanties and camps. So, वो भी तो अपने ही बंदे बन जाते हैं जो यहाँ रहते हैं. तो screening तो उनकी भी होनी चाहिए. So, our recommendation is कि लाइफ में एक बार at the age of 30 years and at the age of 50 years अगर हर एक लेडी का cervical smear हो जाए That's a great thing to be achieved. That is sufficient. It will prevent 75% of the cancers. हर 3 साल 5 साल बाद छोड़ो, लाइफ में 2 बार, at 30 years of age, at 50 years of age, a cervical smear, that's sufficient. उससे भी बेटर है अगर हर 10 साल बाद अगर हो जाए, पर वो गवर्नमेंट देगी नहीं तो यूनिवर्सल एप्लीकेशन होगा नहीं. And other thing is HPV vaccination though available doesn't provide 100% protection. जिसने HPV वैक्सीनेशन लगवा ली है वो ये ना सोचे कि मुझे अब स्क्रीनिंग की ज़रूरत नहीं है, I will not get cancer. The screening recommendations are same because its efficacy in preventing the cancer is 70 to 80%. 20-30% काफ़ी है जो छूट जाते हैं. So if you have had HPV immunization, the screening must be done. वही कम से कम 2 बार लाइफ में स्क्रीनिंग होनी चाहिए. Other thing which a few gynecologists and other doctors may make a mistake, that when a visible lesion, exophytic growth, is found on the cervix, तब cytology नहीं की जाती है. Cytology की जाती है normal cervix में. When cervix appears almost normal or small erosion, यानी कोई visible growth नहीं है. That is the principle in gynecology, that a visible lesion on cervix needs biopsy. उसकी cytology का कोई फायदा नहीं है. Will not give you the correct diagnosis. Will add to confusion. So if you find a cancer-like growth on cervix, cytology का रोल नहीं है. Cytology screening का रोल है जहाँ cervix normal है या mildly inflamed है. Then HPV vaccination. Now concluding, we talked about it. It's not the panacea, but it's very helpful. 70 to 80% efficacy. So routine vaccination. There is some controversy and variation of opinion about it. Some will say start it at 9 years. Some will say start it at 15 years. Actually, teenage में पहला teenage में हो जानी चाहिए. The crux of the matter is that every girl should be immunized during her teenage. Teenage क्या? 13 to 19, जिसके पीछे teen आता है. But I have written 12 to 18 years. 12 to 18 years में immunization हो जानी चाहिए. That's routine vaccination or the standard approach. Then there is a catch-up vaccination which can be done later, which means 90 to 25 years. Marriage mostly हो जाती है इस एज में और वो म्यूटाजेनेसिस प्रोसेस अर्ली स्टेज में होता है, ऑन्कोजेनेसिस. तो अगर HPV इम्यूनिटी बढ़ा दी जाए तो फिर वो रिग्रेस हो जाएगा. So wonderful thing. Up to 25 years of age. The pharmaceutical companies have got approval for vaccination after 25. That means 26 to 50 years of age also. That is, I believe and I have concluded that is because of their commercial interest. वो बेचनी है उन्होंने तो वो तो कहेंगे सारे लगवाओ. तो very little benefit, about 25 to 30% if you take it after the 25 years of age. Small benefit is there. So 25-30% वाली वैक्सीन तो फिर use, and it's expensive too. It's not, HPV vaccine is not a part of our national immunization program because of its expense. And it's obviously, so it has to be bought either by NGOs to give to a limited group of women, girls, or अपने आप खरीद के ले आओ बाजार से और लगवाओ. तो so for vaccination to be effective, it must be completed before starting of sexual activity.
Soon, as we are running short of time and we have already exceeded the time limit for the session.
Sorry, quickly.
Yeah, please conclude.
It doesn't matter. So it is not of much use if it is delayed further. The schedule basically, if up to 15 years of age you are taking it, there are 2 doses which are which provide enough immunity, which is at 0 and 6 months, and thereafter, after 15 years of age, 3 doses like Hep B vaccine, hepatitis B, or these two are similar, 0, 2 and 6 months, or 0. And lastly, these are the commercially available. 3 companies are marketing this. 2 are multinationals. Gardasil is from GSK, Cervarix is from another multinational company. The Indian company is Serum Institute of India, which is marketing Cervavac. Thoda bahut price mein fark hai. So these 3 vaccines are commercially available, and about the price of one dose ranges from about 1800 to 2800. Well, that's all. So this is just a concluding remark with thanking you all. Tenu aj hazur to fateh aayi, khabran udiyan vich jahan de ji, Shah Muhammada Vairi nu jaan hazir, सदा रखिए विच ध्यान दे जी. जिनको पंजाबी नहीं आती उनके लिए ये है कि ये बहुत कमज़ोर दुश्मन है आपका, जिसको आप बहुत इजीली कंट्रोल कर सकते हो अगर ध्यान में रखो तो. नमस्कार, थैंक यू.
Thank you. I now request Dr. Naveen Bhardwaj to kindly present his talk on healthy childhood development tips for parents. He is Associate Professor, Department of Pediatrics at AIIMS Bathinda.
Thank you. So, at outset, I am thankful to the organizer of MAPICON for giving me opportunity to speak over here. So, I shall be discussing topic healthy childhood development, which is in pediatric language nurturing care for early childhood development, NCECD. I will be changing these terms interchangeably, so please do not get confused. So, before I proceed further, my topic is largely guided by IAP Nurture guidelines, which are in line with World Health Organization, UNICEF, and World Bank Group on nurturing care for early childhood development. So, what are the scopes? I am going to explain what is nurturing care and early childhood development, what are the domains of early childhood development, what is good health, what is adequate nutrition, what is responsive caregiving, early learning opportunities, and safety and security. How many parents are there who are having young kids at home? Hardly. Okay. So the first edition of the Shark Tank, there was this gentleman.
वो स्किल्स आपके साथ जिंदगी भर रहता है. जो आदमी स्पोर्ट्स में अच्छा होता है, वो आप देखिए हर साल स्कूल के टीम में वही बच्चा स्पोर्ट्स में क्यों सिलेक्ट हो रहा है? बिकॉज नोइंगली या अननोइंगली ये सब स्किल्स जो फंडामेंटल
राइट टाइम our brain is going to achieve the great potential, because most of the development of the brain is going to happen in the early years of life, that is in first 3 years of life. So, but is it that simple? No. So there is a global estimate that almost 43% of the population of the world, that is almost 250 million of children, they will not be able to achieve their adequate development potential. Reason? Because we are not providing safe environment for early childhood development. So where is the problem? There are some risk factors and there are some protective factors. If we see in developed countries, these risk factors are significantly higher than the protective factors. So they can be in the form of environmental, demographic, biological or social factors. So, and the problem here, it is very big again in the developing country. If we take estimate of India, we expect that almost 70 million children in India, they will not be able to reach their adequate development potential. So, it is not only the right stimulus or right exercising of the brain. So, it is more wider than this. If we take UNICEF and WHO guidelines, it clearly says that it should encompass at least 5 points. So, what is it? It is good health, adequate nutrition, responsive caregiving, security and safety, and opportunity for early learning. So all these encompasses early childhood development, nurturing care. So these two words are coming time and again. First is nurturing care and second is early childhood development. So nurturing care is a state of providing safe environment which is adequate for the development of the child. So it is basically responsibility of family and state. Then early childhood development is a holistic concept where we are dealing with the health, nutrition, education, social protection, etc. And it is again subject of family. That means there should be family-centered care and also state-centered care. So I will be going through all these 5 components one by one shortly. So firstly, I will be covering health. So there are many factors which are highly overlooked in pediatric population. In India, we are facing the triple burden of malnutrition. On one hand, our more than 1/3 of population is facing undernutrition. A significant of population is going into overnutrition and obesity, and there is hidden hunger for micronutrient deficiency. So the burden of stunting in India is almost 38.4%. This clearly shows how is the status of chronic malnutrition in our country. Along with this, other issues of disability for which there is no standard policy still in our country. Almost 1.7 million children are born every year with some or more birth defects, and we are not doing much for most of them. So if we see healthcare at a glance, so the services, they should range from promotive, preventive, curative, rehabilitative and palliative. So the first 3, promotive, preventive and curative, they should be provided universally. It is not possible for many families to get promotive, preventive and curative services for their families, but state should have responsibility to provide all these services universally. While rehabilitative and palliative service, they are mainly targeted. So what is majorly included in the preventive or promotive service in pediatric population? First of all is breastfeeding support. We hardly hear anybody that we are having breastfeeding counselor. If we see breastfeeding rate in our country, it is still somewhere around 60%. If we support only breastfeeding, we will be able to reduce under 5 mortality by 13%. If we are providing complementary feeding at 6 months of age to all children, we will be able to reduce under 5 mortality by 6%. If we are providing even safe water and sanitation and hygiene to the children, we will be reducing under 5 mortality by almost 3%. Just safe water and hygiene. Preventive immunization, we are relatively doing good. Growth monitoring, it is not being done universally, but it should be done. So same is the status of development monitoring. Every 1 out of 10 children in our country is having some or other neurodevelopment disorder. I am not exaggerating the figures. These are the studies which are done recently, and this is real-time data. Secondly, prevalence of autism spectrum disorder is almost 1%. Among males, it is almost 1 in 50, and female, it is also somewhere around 1 in 120. So it is again very big problem which we are going to face in the near future. I have always seen that in pediatric population, we are moving more toward the behavioral pediatrics because behavioral issue, they are on the rise. So how do we evaluate growth and development most simply? What can be done? When a mother is registered in antenatal clinic, she is provided with the MCV card. So this is known as Mother and Child Protection Card. If we read this card carefully, this is available in all the local languages in our country. It is having very useful information. There are growth chart over this, but they are not regularly plotted. And also there are development milestone or development screening on these cards also. If we see this photograph, there is development age for 4 to 6 months of age. So it clearly describes what has to be done, when we should be cautious that these are the warning signs, and what parental tips can be given. They are given on the MCP card, and it is available free of the cost at every antenatal center where mother is being born. Secondly, as I already told, that autism cases are on the rise system, and it is purely parent completed provider completed questionnaire, where we have to answer only 20 questions, and we can simply classify whether the kid is at the risk of autism or is suffering from autism. Why we are trying to identify them early? Because if we do early intervention, results are very good. And if we are delayed in intervention by more than 3 years, results are not that good. Now coming to the second important component of ECD, that is nutrition. Again, same is the problem. We are having very low breastfeeding rate, we are having very low complementary feeding rate, access to food is also not universally seen. So how do we identify that what has to be given to a child? Till 6 months, it should be exclusive breastfeeding. And after that, we try to divide our food into 7 groups. So these are the 7 groups which are there on the screen. So out of these groups, there can be people who are vegetarian and there can be people who are non-vegetarian. So at least more than 4 groups should be consumed within 24 hours every day. And they should be in adequate quantity. So that is known as balanced food. And we should be aware of that micronutrient deficiency will not be apparently presenting clinically, but we are having iron deficiency of almost 40% in our country. Every second child is anemic. So, and anemia has significant effect on ultimate development outcome. So now, this is the biggest problem nowadays we are facing. Mother is breastfeeding the child and she is seeing the screen. Child is feeding but looking at the screen. So this is not responsive feeding. So we have to, even if a neonate is born, he gives you cues to the feed. We should be understanding, a mother should be understanding the love, patience and play. It may take 1 hour to feed a 6-month-old child or 7-month-old child. They should be introduced with variety of food. The classical example of first 6 months is that they like colors very much. So if you give them colored food, they will be very eager to eat them. So the feeding experience should not be like this. It should be enjoyable to both parent and also the child. While feeding, eye-to-eye contact is must for adequate brain development. And there should be no forceful feeding. So this is something known as responsive feeding. Now choosing the right complementary food. Now our baby is 6 months old, so we should be aware that at this point of time, complementary feeding should be introduced. There are a lot many diseases which are there in the society because complementary feeding is not started in the time. The most common in this region is this vitamin B12 deficiency or infantile tremor syndrome. So usually we start with semi-solid food and we gradually shift to solid food. Shifting to solid food comes somewhere around 9 to 10 months of age. At this time, taste bud also start appearing in the maximum quantity. So amount of food, quantity of food and duration of how frequently it should be given, these all are the important things when we are choosing the right nutrition for our babies. Now coming to the third part, which is responsive care. The first was the responsive feeding and this is responsive caregiving. So when a child is giving some cues, basically responsive care giving is observation, recognition and appropriate response of child by the parents or primary caregiver that what he wants exactly. And there are people or mothers most of the time who correctly interpret what their children want and need. And if we are identifying these cues adequately, we are identifying those movements adequately. If we see when a neonate who is born, so he tries to convey a message. There is usually lip smacking multiple times. He tries to put his hands into the mouth. So God has designed a neonate in a way that he can give you some cues, he can show some movement, but we are not ready to understand them. So if we are understanding them well, it is known to increase social engagement, cognitive stimulation and emotional regulation. So now coming to another concept of positive parenting. So positive parenting is one that support healthy development and adjustment. Now, there is recent data from India, and it shows that fathers are involved in positive parenting in less than 10% of the cases. So, what is basically positive parenting? It is having 5 pillars. So, basically, we want that brain of our child should grow. There should be newer things a child should be learning. There should be safe, secure and loving environment for a child. But on top of that, there should be some discipline. So wall should grow high. It is like a house. The wall should grow high with positive relationship between a child. There should be significant autonomy given to that child. But there should be a roof of discipline. What should be there in a discipline? The positive disciplining model runs that children are not good or bad, only their behaviors are good or bad. So how we teach them? We create a safe environment. We establish a routine. We give child feeling of autonomy. Say if a child want to wear, say, red dress, so we can give them an option that these are the 3 red dress, you can wear one of them. But they should be socially acceptable. At that time, we should cut the demand of child also. We should not shout. They should never be bribed that you are going to get a screen time, you are going to get some specific pastry or chocolate if you complete your homework. So this is not good disciplining. So very frequently we receive complaint in OPD that our child does not listen to us. He is totally in his mind and he is having highly unacceptable behavior. So you should not behave like the child. Be calm, state what is unacceptable and why. Give some time out. The rule of time out is, it is usually given after 1 year of age. The room should be very safe. For 1 year of age, 1 minute of this time out is recommended, and till the age of 5 years it goes up to 5 minutes. So they should be explained what can be the consequences if you are doing this thing. What is systematic ignoring? So sometimes child may be doing some unwanted things. You can ignore them for a while and let them understand things themselves. But it should not be abusive. They should not be beaten because it is not going to manage the unacceptable behavior. So it will further come then that will be breaching the boundaries of social security to the children if we are beating them like this for unacceptable behaviors. Now coming to the opportunity of early learning. So can anybody tell me when should books be introduced to the child? Okay. So learning is promoted through play, communication and social interaction. And Article 31 of UNESCO clearly says that it is their fundamental right. Leisure is fundamental right of children and it should be provided to them. And every family-centered care and every family should provide leisure to their children, whatever may be the limit. So now for specific age, there are some specific behavior and play should be organized in that way only. So they like few things at that particular time. So when I am hungry, I would like to eat the food. Similarly, when child is demanding something, it is better to give him that thing only. So say in initial first 6 months, they like bright objects very well. They use their bodies for play. They like faces of mother. They like various faces coming in front of them. Similarly, they can be stimulated in the same way. They can be massaged in different position. They can be, parents can make funny faces in front of kids. There can be dangling objects in front of them which are hanging. Bright objects can be given to the children and there should be a limit to this. They have very short attention span. So if a child is not able to focus beyond 10 minutes, it does not mean that we should force him to keep on giving him the stimulus. So they have very short span. And these playing and toys, they changes over time with the development milestone and behavior of children also. So if I take example of 24 to 36 months, they develop habit of painting. They start scribbling things well. So they like swing, they like to explore the things. So they should be given this opportunity during this period. So they should not be unduly restricted performing these duties. So cultivating reading, it should be started somewhere around 6 months of age. Why? Because it enhances cognitive and language skill, it improves child and parent bonding, it increases concentration, and it is useful when they go to school also. So what should be the type of books they should be given. So if they are 4 to 6 months, clothes with pictures should be given to them. 6 to 12 months, thick booklets with 1 page, 1 or 2 images per page should be given to them. And by the age of 3 years, they should be introduced to stories and they should be allowed to ask the question and we should answer the question appropriately. Now coming to the last part of it, it is safety and security. So these are very two important terms. Safety is a state which one is protected from hazards caused by natural forces, while security is one in which one is protected from hazards that result deliberate human actions. Who is responsible? Anybody can be responsible. Parents, 5 people sitting on one bike, parents are responsible. Other family members, social abuse is very, very common. Sexual abuse among the children is very common. Community, yes, community can be responsible and even government can be responsible for breach in the safety and security of children. So if you see problem statement of our country, neglect is seen in 16% of cases, physical abuse 23%, parents scolding and hitting the children, it comes under physical abuse. Emotional abuse is very common. If you read the definition of emotional abuse as per UNICEF, you will be surprised. And sexual abuse is seen in 18% of the girl and 8% of the boys. So, National Crime Record says that 5.9% victim of child sexual abuse are under the age of 16 years. So, this is the definition of emotional or psychological abuse. If parents are not giving, especially doctors, adequate time to the children to play with them, it also comes under emotional abuse to the children. So, we should be careful at our home how this safety can be promoted at home. They can be prevented from injuries in the kitchen, prevent electronic accident, prevention of poisoning, prevention of burns, scars and hyperthermia, fire prevention. All these are small things, but they should be addressed before a child is there in the family. So, we recently see children where the bucket is full in the bathroom and they just get a dip in the bathroom, 1.5 to 2-year-old child, and they are hypoxic throughout the life and bedridden for the rest of the life. So, toy safety. In the market, a lot of Chinese toy with button batteries comes. And if a child has taken button battery, his life is highly miserable. If a pediatric surgeon is sitting over there, they can well understand the issues after that. So, now in the last, teaching children good touch and bad touch. This is very important. So, we should tell our children as per various sites that what is the good touch and what is bad touch. So, if somebody is giving you bad touch, just shout loudly, start crying and call for help. So these are the 3 messages which should be given to them very clearly. So to sum up, so there are few messages from UNICEF. बच्चों को सही पोषण दें, स्पर्श के महत्व को जानें, बच्चों के स्वास्थ्य और विकास का ध्यान रखें, बच्चों को आसपास की चीजें दिखाएं, बच्चे से बातें करें. And these things were very common before digital era, before the era of mobile. And these were the things which used to happen in the villages. But nowadays, they are not that common to see that these things are happening frequently. बच्चे से बात करें और उसकी बातें सुनें, बच्चे की एक दिनचर्या बनाएं, बच्चे के साथ खेलें और मस्ती करें, बच्चे को शौचालय का उपयोग करना सिखाएं. It should be taught after 18 to 24 months. Good touch and bad touch should also be taught after 18 to 24 months. बच्चे के लिए सीमाएं बनाएं, this is disciplining. बच्चों को डिजिटल गैजेट से दूर रखें. So in first year of life, there should not be any screen exposure. After that, less than 1 hour of screen. Guidelines say 2 hours, but it is not an evidence-based fact. But it is better to give screen for less than 1 hour if at all required. So I have covered these 5 topics of responsive caregiving. This is possible with the support of stakeholders and people from the society and families. Thank you.
Thank you, sir.
Any questions? Okay, thank you.
Thank you, sir, for gracing us with your presence. The next talk is on utility of bronchopulmonary lavage, and it will be delivered by Dr. Rajiv Chawla. Consultant Microbiologist and Director, New Life Medicity, Bathinda.
Good afternoon all. My topic is today for the utility of bronchoalveolar lavage, that is BAL. So basically bronchoalveolar lavage is a procedure that extracts cell and the fluids from the bronchioles and the lung of the alveoli for the disease diagnosis. It is performed by the bronchoscope. A fiber optic wire and sterile saline is pumped in the air in the fluid and withdrawn for the analysis. BAL can help in the diagnosis of various diseases such as pulmonary infections, pulmonary malignancies, acute respiratory failures, diffuse infiltrative lung disease, occupational lung disease, pediatric lung disease, post-transplant monitoring, and pediatric lung disease. So all these conditions can be checked by the BAL fluid. In clinical pneumonia patients, treatment failure may be linked to the inappropriate antibiotic choices, superimposed infection and drug-resistant pathogens. Acquisition, the BAL technique is highly convenient for the pediatric patients and the immunocompromised patient, making it an excellent option for the proper diagnosis. The further BAL fluid contains various microorganisms, including Pseudomonas, Klebsiella, Staphylococcus aureus, Acinetobacter, Streptococcus, then E. coli, Enterobacters, Haemophilus, Morzella, Citrobacter and Nocardia. So, in the last 2 years back, I have discovered 26 cases of nocardia in 1 year. That is a nocardia. That is in a modified Jaden stain we use for this nocardia. Then drug resistance among the clinical and non-clinical isolates has been reported within the some bacterial pathogens being resistant to the common used antibiotics. BAL is an innovative technique that has brought a significant breakthrough in the pulmonary disease diagnosis, making it a faster, easier, more sensitive method for detecting the pulmonary disease. This is the workflow, how we, after the this BAL come in the lab, then how we will, this is workflows. First is the sample collections, then there is an inclusion and exclusion criteria sample process. There is a macroscopic examination and microscopic examinations. In a microscopic examination, we do gram staining, AFB staining and modified AFB staining. Then sample processing, other way we do cultures, blood agar, McConkey agar, then gram staining, identification of bacterial stains, then antibiotic sensitivity profiling. Then next is the material and method, how we use this material and method for this technique. Then a practice laboratory-based cross-sectional study was carried out at the microbiological lab of New Life Medicity and Delhi Heart Institute, Bathinda. The study was conducted over a period of 1 year in the 2001 to 2002. Then total number of 149 BAL fluid samples were collected from the bronchoscopy. The patients suffering from pulmonary infection, the BAL procedure was carried out by the trained medical staff of the hospital, even the doctors. Patients of all groups were included in these studies. This culture showing monomicrobial growth were included in the study. Sample with improper sealing and labeling were excluded for the study. Then data and specimen collections. Patient informed consent was obtained before sample collection and their information was kept confidential. A pre-structured questionnaire was used to gather information of like the age, sex, Then bronchoscopy details. Ball fluid was transported to the microbial lab, labeled and processed to avoid the contamination and desiccations. Then next is the sample processing. How we process the sample. Sample were processed in the microbial lab using procedure like I have already shown you. That is divided into two parts, direct microscopic, then cultures prepared from gram staining, Zn staining and modified Zn staining. Now, sometimes we also do for the KOS staining also. Then macroscopic and microscopic examination, the blood fluid was examined for the appearance, color, consistency, presence of debris and even smear of the most purulent part of the specimen was prepared and cleaned, grease-free slides and subjected to gram staining and acid-fast staining. The specimen was also observed for any kind of pulses. So this is direct microscopy. Then cultures of the specimen, the aerobic cultures of the specimen performed under the aseptic conditions. As soon as the specimen reached to the laboratory, the sample was inoculated on the MA, that is McConkey agar and blood agars. The plates were aerobically incubated at 37 degrees at 24 hours. If no growth was observed, then the sample was reported as a growth negative or no growth. In case of bacterial growth, a single isolated colony was taken and subcultured in the nutrient agar. Suppose there is one colony, that we do it as subculturing for another 48 hours. And nutrient agar and incubated at 37, same procedure. Then isolation and identification of bacteria. Bacterial isolate identification using standard microbial techniques, including colony morphology, physiological tests, staining reactions, and biochemical tests were performed. Then next is the gram staining was performed on the isolated cultures, and appropriate biochemical test was performed to characterize the organisms. The study tested bacterial susceptibility to the antimicrobial agents using Kirby-Bohr method, disk diffusion method. It is involved in a fresh broth culture of isolate in Muller-Hilton agar, that is MHA, and various antibiotic discs using one of the only company that is making this antibiotic susceptibility. Then we take the John inhibition was measured and result was interpreted as sensitive, intermediate, resistant. MRSA also was identified using cefotaxime, disc and MDR resistant organisms, but differently an ability to resist multiple class of antimicrobial agents. Then screening of ESBL by a phenotypical test. We also screen whether it is ESBL or anything else. They were conducted using ceftazimide, cefotaxime on the Muller, that is the MHA agar. So production was noted, ESBL production was noted by this method. Probably ESBL producer has zone of inhibition of less than 20 nanometer mm, and ceftazimide is 27 mm for the cefotaxime. The confirmatory test was conducted by suspected ESBL producing microorganism using antibiotic combination of ceftazimide and clavulanic acid. So for the screening, we use only, that is screening, for the screening we use ceftazimide and cefotaxime. For confirmation, we are using the combination antibiotic discs, that is ceftazimide with clavulanic acids. Then data analysis was performed using SPS statistical software. A chi-square test was used to determine the association between pulmonary infection with various attributes such as patient age, gender and presence of TB, that is tuberculosis. The p-value is less than 0.05 was assumed to be statistically significantly for the analysis. Then among the 149 samples tested for the microbial infections, 142, that is 95.3 samples were showed at least one bacterial growth. Of those 142 growth positive sample, 127, that is 89.4% show the monomicrobial and 15 accounted for the polymicrobial growth. There is two type of growth is there on the plates. The study was found a strong association between gender and bacterial growth in 142 growth positive samples. Male had a highest growth rate, that is 64.8, while the female had lowest 35.2. Then age group 60 to 70 year had a highest growth rate, that is 30.9, while the 10 to 20 year has lowest growth. But no association was found between ethnic group and bacterial growth. This is the growth, that is a chart association of bacterial growth with the various attributes. That is, male is, as I also described, 98%. One has no growth of total 93 samples. Female has 50%. 6 out of 6 have no growth. Then age group, I have already told you, 0 to 10 is a 4, that is 66%, and no growth is 33%. Moreover, in the age group of 20 to 30, there is 8, that is 88%, and 11% is no growth. That is no colony obtained over the, no bacteria obtained on this cultures. Then 50 to 60 age group has a 92% of growth, and there is a 7.14 growth, that is no growth over there on this. 60 to 70 is 97% is growth, and 2.2% is no growth. There is no bacteria obtained on these culture plates. And 70 to 80, 96% there is a growth of the bacteria, and 3.8 have no growth of the bacteria. Then TB infection, that is 36, that is 100%. This growth of the bacteria, and 106, that is 93% has, if the TB is not there, that is 93%, they have a growth of the bacteria. Then 7% with no TB infection is 6.1%. Then distribution of isolated bacteria. A total of 157 bacterial growth was observed. Of the 124 were gram-negative, and 33 were gram-positive GPC are there. Among the gram-negative isolates, Pseudomonas aeruginosa was the frequently isolated bacterium, that is 64. Klebsiella was the second most frequently isolated bacteria. Then E. coli, Citrobacter accounted for 61% and 4%, 3.2 respectively. Among the 33 GPC, there Staphylococcus aureus accounted for the 57% and Streptococcus pneumoniae accounted for the 42% respectively. That is shown in the figure also. This is the figure, we have chart basically for the Pseudomonas aeruginosa, Klebsiella, E. coli, Citrobacter, Staphylococcus aureus, then Streptococcus pneumoniae. Then AST patterns. The panel of 15 antibiotic discs were tested for all the isolates, whether it is GPC or it is gram-positive or gram-negative bacteria. Ampicillin and carbapenems were the drugs that are effectively against all the isolates. Ampicillin was 100% effective against the aeruginosa and gram-positive cocci, while the 92% effective against the Enterobacteriaceae family. Whereas the carbapenems were 100% effective against all the isolates. The least effective drug is gentamicin in the Pseudomonas, which was also completely ineffective against Enterobacteriaceae family and only 12.2% effective against GPC, that is gram-positive cocci. Amoxiclav, a combination of amoxicillin and clavulanic acid, was effective against GPC, 87% of isolates of Pseudomonas aeruginosa, but only 54.2 effective against Enterobacteriaceae isolates. This is the table where we are showing how this sensitive, then intermediate sensitive, then resistant, then Enterobacteriaceae. If you go with the ampicillin, 92% or 92.8% was the sensitive rate. intermediate was 7.2%. Then amoxiclavinate is 87.5%. For the Pseudomonas enterobacteriaceae was 54.2%. Then cefoxtin, that is for 92% in Pseudomonas and 27% in enterobacteriaceae. And for the gram-positive cocci, this is 63% and intermediate 36.4%. Whereas the imipenem, carbapenems, that is 100% in Pseudomonas, 100% in, that is enterobacteriaceae, 100% in gram-positive cocci. So they are most effective, that is sensitive to these. Then cefepime is, in case of Pseudomonas, is 23.4% in case of Pseudomonas and 16.7% in enterobacteriaceae and 39.4% in GPCs. Then next is the distribution of MDR and MRSA isolates. Out of total of 157 isolates, 125 isolates were MDR, 125 isolates were MDR, whereas the remaining 32 isolates are non-MDRs. Among the 19, there is Staphylococcus aureus isolate are 10 were MRSA. Pseudomonas aeruginosa dominated the MDR count, accounting for 48% of the total isolates. Following it was the Klebsiella pneumoniae. Then, being the MDR, the least MDR isolated, that is the Citrobacter cocceri. Among the gram-positive cocci, Staphylococcus aureus accounted for 7.2 isolate and pneumoniae for 4%. This is the chart showing this Pseudomonas aeruginosa, that is the 49%, Klebsiella pneumoniae, that is a 23%, then E. coli 16%, Citrobacter, that is the only 1%, Staphylococcus, that is 7%, and Streptococcus pneumoniae, that is 4%. Then frequency of ESBL producing enterobacteriaceae. Among 60 enterobacteriaceae isolate, 31 isolates showed ESBL screening test positive. In the study we also do the screening test as well as confirmatory test for the ESBL. So we are using the conventional cultures. Note that is the automatic. On performing the confirmatory test, 11 isolates of Klebsiella pneumoniae and 8 of the E. coli and 2 of the Citrobacter were found to be ESBL producer as shown in the table. So these are the table. Significant got in 36, screening positive, test positive is 70%, confirmatory positive is 11, E. coli is, that is screening test positive is 12, then confirmatory test is 8, then Citrobacter 2 screening test positive and 2 is the confirmatory test positive, and in case total is a 60, 31 screening positive and 21 is a confirmatory positive. Then the major outcome and conclusion of this study. The study highlights the significance of BAL in the diagnosis of respiratory disease. A high prevalence of bacterial growth were observed in the BAL fluid sample, indicating the importance of this technique for detecting the pulmonary infections. Pseudomonas aeruginosa was the most common pathogen, followed by Klebsiella, Staphylococcus aureus. The emergence of MDR and ESBL producing bacterial in the BAL fluid samples that it cause a serious concern as it limits the effectiveness of the commonly used antibiotics for the treatments. So as far as my recommendations after this study, based upon the findings, several recommendations can be made to address the challenges posed by the antibiotic resistant and enhanced diagnosis. That is the antibiotic stewardship. Implement and promote the appropriate antibiotic use, ensuring that antibiotics are prescribed judicially and prevent the development of resistance. Then infection control practices. It is very effective. Strengthening infection control measure to minimize the transmission of resistant pathogens in a healthcare settings. Continuous monitoring. Regular monitoring of antibiotic resistant patterns in the hospital to identify the emerge trend and adapt treatment protocols accordingly. Education and awareness. Conduct education program to raise awareness program, healthcare professional and public about the risk of antibiotic misuse and the importance of BAL as a diagnostic tool. Research and development, improve diagnostic. Continue to explore the new innovative diagnostic method so it can be rapidly identification of pathogens and resistant profiles. By implementing these recommendations, healthcare facility can be proactive step and to address the challenge of the antibiotic resistant, enhance the diagnosis and treatment of the respiratory disease. This is my paper where we have a study that is that is isolate 26 cases of nocardia in a period of 1.5 years at the Lehigh Institutes. Thank you.
Thank you, sir, for the talk. Our next talk will be delivered
Can we have the slides, please? Okay. Yeah. So, as I am presenting my talk, I do not have any conflict of interest or I have nothing to disclose about what I am going to discuss in this lecture. And as we all understand, depression is a common mental disorder. Its prevalence is very, very high, and if you look at any estimates, the lifetime prevalence of depression is about 1 in every 5 person will develop depression, and at any given time the point prevalence of depression is about 5%. So that means it's a very common disorder which requires attention, and it is seen across all age groups, starting from children, adolescent, adult, elderly, and very, very elderly. And it is one of the most common disorder which is also seen in people with various medical illnesses, and is associated with high level of disability, and it is among one of the most common cause of morbidity and disability across the globe at present. It is also associated with high rates of suicide, which is a burning problem in today's world, and unfortunately what we know is it is often under-recognized, untreated, and if at all it is treated, it is inappropriately treated. As we try to understand depression, it's a heterogeneous condition which has lot of symptoms which could be characterized as emotional symptoms, neurocognitive symptoms, and the physical symptoms. Basically, we need to understand it's not that it doesn't depression doesn't manifest same in every person. And as the ICD-11 tries to define them, we define symptoms of depression now in 3 basic clusters as the affective cluster, the cognitive behavioral cluster, and the neurocognitive cluster. The affective cluster basically includes the depressed mood in the anhedonia, and the cognitive behavioral cluster will include the poor attention, concentration, and very depressive cognition, and the neurovegetative includes the disturbance in the biofunction and the psychomotor retardation and reduced energy or the fatigue. And when we look at the whole spectrum of depression, again we will understand that it varies across the severity, or we can understand depression ranging from major depression to mild depression, dysthymia or unipolar, bipolar, depending on the presence of hypomania, mania, depending on the treatment response as treatment-resistant depression, difficult to treat depression, and various specifiers as defined by DSM-5 as psychotic depression, melancholic depression, depression with atypical features, and so on. So basically what I just want to emphasize to everybody that depression is a heterogeneous condition. Then we try to look at the comorbidity patterns of patients with depression,
So about 1/3 of the people will have comorbid substance use or any other psychiatric disorder, which can include something like phobias, generalized anxiety disorders, PTSD, OCD, and so on. And in terms of its prevalence in various the physical health conditions, the prevalence of depression again varies from, let's say, from 10% to about 70-80%, depending on how you are assessing depression and what is the cutoff which you are taking to label somebody as having depression. And in terms of etiology, again, we need to understand that there are different hypotheses which can include the biological, the psychological, the social, or the somatic risk factors or the etiologies for understanding depression. So, and when we look at all this, we try to understand that depression is a heterogeneous condition. So when we try to answer this question, are all patients of depression the same? The simplest answer is no. So this is one thing which we need to understand as physicians, as clinicians, which we all try to treat depression or understand depression, and we try to tell people that it's a simple depression, nothing big deal, but it's not like that. Depression has a lot of different implications as we try to understand the clinical picture. So then, are all the patients with a particular type of depression the same? Again, the answer is no. Basic reason is that because most of the antidepressants are metabolized through liver, the CYP450 system, and that's where, depending on the metabolizer, we can have something like ultra rapid metabolizers or the normal metabolizers or intermediate metabolizers or the poor metabolizers. So this will again determine the serum antidepressant levels when you are using antidepressant, and this will determine the treatment response. So although if we take a subgroup of patients of depression who are similar in their clinical characteristics and other aspects, still the response to treatment may be different. So what we need to understand that one size is not going to fit for all, means you cannot select or predict using a particular depression for a particular type of depression or a particular type of patient. So this is where we need to be very clear. So if you just again try to answer the second question, are all patients with a particular type of depression the same? The answer is again no. So then how does clinician manage patients with depression? So as I say that clinicians often have a dilemma, which antidepressant to choose, which one to give to a particular patient. And ultimately there is a so-called, as we try to understand what are the factors which determine the selection of antidepressants. So it is a SAD access to drugs, that are the factors like severity of depression, adverse effect of the medication, the dosing schedule, the OD or the BD schedule, the age of the patient, the comorbidity patterns, the cost of treatment, the effectiveness of antidepressant in particular comorbid conditions, the symptom profile, safety in the higher doses because the patient can be suicidal, drug interaction because if the patient has depression in the background of a medical comorbidity, treatment resistance, and how much they understand with respect to using antidepressant and what they don't understand, and the gender will influence the selection of the antidepressant. Then let's try to understand what the so-called unmet needs of current antidepressant. Unfortunately, whatever antidepressant we have in the market at this present, like they have a lag period of action about 2 to 3 weeks, maybe 4 weeks, which again people don't understand and just try to, without understanding that, either give patient polypharmacy or give higher doses. That is actually detrimental for the patient. Then there are a lot of sexual side effects of antidepressant which are bothersome for most of the people and often are the step limiting factors in patients to continue their medication in long run, and that leads to poor medication adherence. And sudden stoppage of certain antidepressants can lead to withdrawal symptoms, and often many patients continue to have residual depressive symptoms. That means although they may respond to an antidepressant, but they may not achieve full remission or total recovery from the depression. So what will determine how do we go about antidepressants? So it is basically the efficacy, the withdrawal or the discontinuation, and the tolerability. So let's see what data we have to compare various antidepressants. So this is one of the biggest so-called meta-analysis and network meta-analysis in understanding various antidepressants across the globe, and this meta-analysis has data of more than 1 lakh people, and out of which about 26,000 were on placebo and more than 75,000 were on antidepressant, and it included data of most of the published and unpublished studies across the globe. That's the biggest data bank which we have at this moment for understanding the various antidepressants, and let's see how does it different antidepressant compared to. So when we look at a comparison of various antidepressants compared to placebo, in terms of efficacy, you will see that the antidepressant like amitriptyline, mirtazapine, duloxetine, venlafaxine do much better than other antidepressants, with escitalopram, sertraline somewhere in the middle range. And when the efficacy is understood as response, present or absent, and when we look at as a continuous course of on the various depression scale, again the amitriptyline, duloxetine, mirtazapine and venlafaxine comes at a much higher level, and escitalopram is at the somewhere in the middle level. So that is where we need to understand in terms of efficacy, the more dirtier the drug, or the drug which is acting on more than one receptor, performs better than drugs acting on the single receptor. However, we need to talk about the acceptability, that is the tolerability, and whether this patient are going to take this medication or dropout rates. You will see that the best tolerable drug is agomelatine, fluoxetine, escitalopram, and the good drug like clomipramine goes down the ladder, totally down. And in terms of dropout due to the side effects, again agomelatine is at the top of the list, followed by vortioxetine, milnacipran, desvenlafaxine, and other drugs which come closer are something like escitalopram, fluoxetine, citalopram and sertraline. But again, the drugs like clomipramine, amitriptyline, trazodone, all the classical tricyclics or tetracyclic antidepressants are very, very poorly tolerated by the patient. So that is where we need to understand, although these may be efficacious, but these are not tolerated by the patient. In terms of again remission rates, again you see that remission rates are again very high with drugs like amitriptyline, duloxetine, nefazodone, venlafaxine, with escitalopram somewhere close to them, but not at the top of the list. So what does this evidence suggest to us? Because all this evidence is in terms of comparison of drugs to the placebo, but that does not guide us to which one to choose, because by comparison with placebo, maybe it will not give us the best answer. So let's look at the comparison of various antidepressants head to head. And here if you see the response rate is highest with vortioxetine, bupropion and escitalopram. These are at the top level, and in the continuous variable as in terms of efficacy outcome, again vortioxetine, amitriptyline, escitalopram figure among the top three. Escitalopram is one of the most commonly prescribed antidepressant across the globe at this moment, so that's where we need to understand. In terms of response rate, head to head, it performs much better than various other antidepressants. And dropout rates are again very low with drugs like vortioxetine, agomelatine and escitalopram and sertraline in terms of either due to any particular reason or side effects. So that means these drugs are also well tolerated. And in terms of remission rates, again bupropion, vortioxetine, escitalopram and duloxetine top the list. So if you take all these factors into account and try to compare various antidepressants, you will see that at the top you will see drugs like vortioxetine, escitalopram and bupropion when we look at the combination of efficacy and tolerability. So these are three drugs which perform much better than others, and when we talk about the cost issue, maybe escitalopram performs much better than any of these antidepressants. So besides the efficacy in these short-term trials, let us also try to understand the other tolerability factors which influence selection of antidepressants, and this includes medication adherence, other short-term and long-term outcomes, and morbidity and mortality data. So basically the safety and tolerability data becomes very, very important, and again this is where we need to understand the various adverse effects which are possibly not often brought up so openly by various drug trials, but can have influence on the outcome or the tolerance of the patient or the medication adherence in long run. And what we see here, that the SSRIs and various other drugs have a lot of sexual side effects in the form of somnolence, insomnia and nausea, which can be very difficult in the beginning. And if you look at drugs here, only mirtazapine would perform slightly better, or mirtazapine and bupropion have side effects, sexual side effects which are much lower compared to others. So this may be the preferred drugs, but other side effects may be there, like with mirtazapine you see a lot of weight gain, it leads to highest weight gain may be lowest with something like bupropion and nefazodone. And there are other rare side effects like GI bleeding, seizures, atypical, so-called atopic reactions, or their liver dysfunction and so on, or seizures and so on. So all these risk factors, all these side effects become important in patients who have physical comorbidities, and there the selection of antidepressant is again guided by these rare side effects rather than only efficacy or the short-term tolerability, because we do not want the so-called underlying physical illness to worsen. So these factors again become very, very important. So from antidepressant perspective, if we try to answer the third question, are all antidepressants the same? The answer is no. So what we need to understand that if all antidepressants are also not the same, that we have answered all the three questions, that all all patients with depression are not same, and if we look at all patients with a particular type of depression, they are not the same, and all antidepressants are not the same. So this is where we need to learn the so-called puzzle how to use antidepressant. So what we need to understand, that are we looking for an antidepressant for a patient, or are we looking for a patient for a particular antidepressant? That's the question which we should be asking ourselves before we start thinking about prescribing an antidepressant for any particular patient whom we are considering to use antidepressant. So what are the factors which determine the use selection of antidepressant? It is the overall efficacy, the symptom specificity should be kept in mind, the comorbidity specificity should be kept in mind, and the adverse effects should be kept in mind. So something like a patient with atypical depression, MAO inhibitors will be better than TCAs. For severe depression, drugs like venlafaxine, SSRIs, venlafaxine may be better than SSRI. And for cognitive symptoms, now we have some data emerging for the presence of cognitive symptoms, that cognitive symptoms respond better to the vorticity. And in terms of the psychiatric comorbidity, most of the data is actually available for SSRIs, and SSRIs are also effective in other conditions like anorexia nervosa, bulimia, and other conditions like OCD, panic disorder, PTSD, and the social anxiety disorders. So we need to understand that if you are looking for a patient, remember the comorbidity profile, that is the psychiatric comorbidity profile that can determine the selection of antidepressants. Similarly, the physical comorbidity, again, a lot of data is there for SSRIs, but for the cardiac patient, we have some data for mirtazapine, and for asthma patient, there is some data for moclobamide, and in the stroke patient, again, data has emerged for mirtazapine, milnacipran, and other drugs in the recent times. So the important facts to remember are these serious side effects when we are selecting the drugs, and in patients who are having the liver damage, safest drug could be something like citalopram, escitalopram, and drugs which should be avoided are something like nefazodone, duloxetine, venlafaxine, and agomelatine. Similarly, for skin condition, various drugs have particular different kind of skin reactions that needs to be kept in mind, and weight gain is very high with drugs like mirtazapine, paroxetine, tricyclic antidepressant, and the drugs which are considered to be more weight neutral are something like vilazodone and vortioxetine. And in terms of cardiac side effects, again, because the cardiology is totally a very broad subject, that's why we understand the different side effects of antidepressant from a cardiological perspective. Different kind of side effects have been noted. So the most troublesome is the orthostatic hypotension, which is commonly seen with the TCAs, and in rare cases with the SSRIs. And with drugs like SNRI, venlafaxine, and duloxetine, there is always a chance of hypertension, so that needs to be kept in mind. And of course, the QTc prolongation with drugs like citalopram, fluoxetine, and sertraline needs to be considered. And urinary retention and urinary incontinence also becomes an issue when you're selecting an antidepressant for elderly. The other important metabolic problem, which is again commonly seen in elderly, those who are on various medications, is the hyponatremia, which is often neglected. Physicians will often end up using antidepressant in elderly in a higher dose, and this patient present to emergency with seizures, which is secondary to hyponatremia, and then the patient goes on to develop the pontine myelinosis. So these are often neglected. So that needs to be kept in mind. Similarly, SSRIs in long run can lead to osteoporosis. That needs to be kept in mind. Again, GI bleeding, again for gastroenterologist, again it's very, very important to understand when anybody comes with a GI bleeding, and it's always important to collect the history of use of antidepressants. And some of the antidepressants can also lead to the extrapyramidal side effects, and that needs to be kept in mind when these are used in the hand of the neurologist. Then the issue of sexual dysfunction is again important, and that needs to be kept in mind when you're selecting an antidepressant for young males and young females. And in terms of pregnancy, among the SSRIs, paroxetine needs to be avoided in first trimester of pregnancy because of the high risk of the congenital malformations. And in close to the delivery, antidepressants are known to be increase the risk of postpartum hemorrhage, and they can lead to withdrawal symptoms in the neonates. So these factors again becomes important in the gynecological practice. So how do we solve or how do you manage depression in patients with various conditions when we understand depression as a heterogeneous condition. So we need to take the patient-specific and the drug-specific factors into account while choosing antidepressant. The patient-specific factors could be the patient preference, the cost issue, the past history of response to the medications or the other medication which the patient is receiving, or the patient's age, is it a young patient or the old patient, and the comorbid conditions needs to be kept in mind. And of course the gender issues, and in the drugs, the cost, side effects, efficacy needs to be kept in mind. And of course the patients who prefer to take tablets, syrup or capsules needs to be considered. And of course, because many patients of depression are suicidal, so risk of overdose should be kept in mind while selecting antidepressant. And so in a highly suicidal patient, it is always recommended that the drug should be handed over or should be handled by the family rather than the patient. So that needs to be kept in mind. So how do psychiatrists select antidepressant? That's where we need to look at. This is a study from US where the psychiatrists selected various antidepressants. The most commonly used antidepressants were escitalopram, bupropion, and sertraline, venlafaxine, and mirtazapine. And when we look at the reasons for selection of various antidepressants, we need to understand that antidepressant selection was influenced by the presence of specific symptom or the symptom profile, wish to avoid certain side effects or presence of the comorbid medical condition or the response to a particular medication, or patient had a good response to a previous medication in the past, and the dosing pattern and the drugs samples which are available to the doctor. So these are the factors which ultimately determine the selection of the drugs rather than just talking about the efficacy. So the other factors in terms of symptom profile, if you look at the symptoms which determine the selection of drugs, were anxiety, insomnia, fatigue, and so on. So these are the factors which needs to be looked at, and we should go for selection of antidepressants. So just to conclude, all patients of depression are not same, and all patients with a particular type of depression are again not same, and all antidepressants are not same. So prescription of antidepressant should be personalized, and that should be done by taking all the factors into account rather than just considering all depression as homogeneous and prescribing antidepressant blindly. Thank you.
It was an extremely informative talk. Thank you, sir, for your august presence at MAPICON 2023. Thank you for coming all the way. I now request Dr. Ashish Koda, President, Malwa Urology Association, currently working at Delhi Heart Institute, Moga, to present his lecture on the topic Dietary Management of Nephrolithiasis, Myths and Facts.
Good evening, everybody. It's been an honor to be present among physicians and their willingness to listen to a urologist. So the topic I have been given and what I want to comment upon is what is nephrolithiasis and how do we prevent the recurrence? Why do we need to prevent recurrence? That is the main issue. Why do we are wanting to prevent recurrence? The first point is most of the patients who undergo any sort of stone surgery is likely to have recurrent stone within a period of 10 years. So what are the factors that are determining the recurrence of the stone? When we know those factors, we can of course prevent them. So as we all know, almost 15% of all the patients who report in our OPD will have some stone disease or maybe related problems related to stone disease. And where the region we are living in is a part of a large stone belt extending from, you could say, Jammu Kashmir, Punjab, Rajasthan, Gujarat, this is all north and northwest of India is a stone belt. So why do patient comes to me? Patient comes and tell me, okay, doctor, you have done the surgery for me, fine, you have done a good job, that's very nice, thank you so much. But the first concern of a Punjabi patient or any Indian patient would be, आगे क्या करना है डॉक्टर साहब, इसको रोकना कैसे है, दोबारा ना हो, आप कैसे इंश्योर करते हो? Do you guarantee me? They can even use the word guarantee. So anyway, I have to prepare for that. And the similar thing will help you also dealing with your daily practice with stone patients who come with stone recurrence. So why do you want to have why do you want to prevent recurrence? Because we know that some sort of proper education by the patient, taking care of his diet, his lifestyle, it may help in reduce their chances of forming stones. Although still the chances never become zero. So diet modification is important and it has to be strict also. So, but before that, I would just like to point out certain things which may come across to medical students and practicing physicians in their common OPD practice. The patient or your relatives, somebody may come with ultrasound, कि डॉक्टर साहब मेरे को opinion दो, I have been detected with a 5 mm stone, 4 mm stone. Number one, I would like to clearly point out from a urologist point of view, it is very, sometimes even 2 or 3 mm stone. It is very unusual and unlikely that a stone of 2 to 5 mm will cause any cause of pain unless it ends up in the ureter. Kidney is a large area. Any stone which is 2 to 5 mm will not cause any sort of pain to the patient. You must look for other causes of the pain. Secondly, ultrasound is an ultra-sensitive device which can sometimes over-predict stones. I have many times seen the same stone which was visible on ultrasound is not present on CT scan. CT scan, plain KUB, is the diagnostic investigation of choice in case you have any doubt about the existence of stone. So don't be pressurized to treat patient on curative treatment. Don't ask him, I will give you some medication, this stone will wash off. I have seen many thousands of patients who have been given medication unnecessarily. Why I say so? Because they have been taking this medication just in hope the stone that is lying in the kidney will wash off. Sometimes it is just Rendel's plaque, sometimes it is just whitish area, sometimes it is medulla which is hyperechogenic on the ultrasound. So it has to be confirmed with a CT scan, but that is a costly investigation in our scenario. So let's stick to our basic instincts and our clinical acumen. Otherwise, you can give dietary advice that is, of course, can be given at any stage, even a patient with stone who has got his stone removed or who has a 4 to 5 mm stone. Besides that, some physicians, some practitioners may indulge in something called flush therapy. I want to stress it is obsolete now. Nobody does this. It is to be condemned basically, because in case, even if the stone is lying in the ureter, you may end up putting more pressure on the opposite kidney, which is the normal kidney, and then helping the patient. You may end up damaging the patient. I have come across in my practice patients who had, you could say, ureterolymphatic leak, basic severe pain and infection because of the flush therapy. This is almost a weekly scenario for us. So what are the myths that we encounter in our daily practice? What are the facts from a urologist's point of view? The diet can help in curing a stone, or even if patient has got a stone already in situ, the diet can remove it. No, there is no role in the cure of the diet. Hard water, doctor, mere pind da pani te bada hard hai. It can lead to increased stone formation. No. Can I drink RO water? The answer is no. Stick to your normal water, whether it's a tube well water or a underground water or a pipe water. It will not harm you any further. And I will stop taking calcium because I have heard taking a lot of milk, taking a lot of paneer, etc. will cause me stones. I will avoid taking calcium. But on the contrary, taking calcium is going to help the patient. This is again a myth. Can I take, youngsters are, and probably the Punjabis are more happy to have beer and alcohol that may help them flush out the stones. But again, the answer is no, it's just a myth. Beer can cause some diuresis, which may help in having more urine, but not in removing the stone. So again, as I told, the main stress in our case in dietary advice should be on taking a lot of vegetables, fresh fruits, also increase. So these are the things that can help the patient to have prevention of recurrence. So it is the fresh fruits and vegetables and a high fiber diet which is going to help the patient. Coming to the basic etiology, why the stones form. The basic phenomena of forming the stone is hypercalciuria, or some metabolic causes like hyperuricosuriia and hyperoxaluria and cystinuria. And in rare cases, especially in pediatric patient, renal tubular acidosis. These are the causes which cause stone. So whenever we talk about stone, patient is insistent, doctor manage करना है कि मैं जाके उसकी जांच करा लेना है, वो किस चीज़ का बना है, मैं उसका biochemical analysis करा लेना है. Then I will prevent that thing in the food and I will be relieved of the problem for the future. The answer is strict no. You will be surprised. In my 15 years of practice as urologist, I have never ever ordered a biochemical analysis of the stone. Patient may have done it on his own, but not me. I have not prescribed it. I will rather go for after removal of the stone, after patient has a normal lifestyle, I would rather go for a 24-hour urinary citrate, 24-hour urinary citrate, uric acid, these investigations. Not a simple test like biochemical, which is not going to help the patient in future. So Basic things that can help that can cause stone are dehydrations, food rich in oxalate, animal protein, especially red animal protein, salt, don't increase the sodium intake, phosphates, obesity. These are the common things which can lead to recurrence of stone. So ask your patient to avoid these things. And the things which can help are water intake, calcium, take some calcium, take some magnesium, potassium, citrate, and high dietary fiber, especially insoluble fiber. Water is going to be the easiest and the most practical thing to do. Ensure the patient takes so much of water that he urinates around 2 liters of urine per day. I mean, the frequency of taking water and interval of taking water is also important. It should not happen that the patient takes 1 liter of water in the morning and in the daytime he dehydrates himself or he causes renal dehydration leading to more stone formation. It has to be intervalled. The intake of water has to be intervalled so that the basic phenomena of stone formation of aggregation and precipitation doesn't happen in the tubules of the kidney. So what are the next thing that we are talking about is oxalate. Oxalate usually combines with calcium to form calcium oxalate. Calcium oxalate stones are the commonest among the kidney stones. So avoid oxalate. So what are the things that contain high oxalate? It is almonds, amaranth, palak, beets, cashew nuts, kaju, okra or bhindi, gooseberries and grapefruit. These are all things which have high oxalate content. They have to be avoided in their diet. Besides that, there are other products like peanuts, strawberries, tea and wheat bran that can also have high oxalate content. And the other myth that is regarding dietary calcium, calcium is believed to neutralize the absorption of oxalate and further leading to non-formation of stones. So have adequate calcium in diet. Calcium supplement, because especially in postmenopausal female we have come across patients who are taking high supplemental calcium in form of tablet or everything. They can take them with meals so that they can reduce the absorption of calcium along with oxalate. But alone taking calcium is not harmful. Supplemental calcium has to be taken along with the meals. Regarding proteins, avoid high protein diet. Why? When we studied, we know that if the protein intake is reduced from around 90 grams to 50 grams, we can have a 50% reduction in stone formation. So most protein-rich fruits, things are usually, those are animal protein origin. These can further break down in the body to form purine, which can further lead to cystine stone formation or uric acid stone formation. So risk of kidney stone formation is greater with animal rather than the vegetarian protein. So you have to avoid red protein, red meat, especially mutton, etc. You can have small amount of, you can advise your patient to have small amount of chicken at least weekly once or at the max weekly once. So besides that, animal protein also has a high sulfur content which can lead to increase in sulfur containing amino acids and form the rare form of stones called cystine stones. The most important advice that I give to my patients after they come in follow-up for the stone surgery is low sodium. I have observed if you just reduce the sodium in the diet to less than 3 to 4 grams per day, it can lead to wonders for the patient, because most of the diets which the youngsters are consuming these days have high sodium, high oxalate content. They go around, especially in Punjab, they go around to all the ladies and the sellers who are selling on the streets, and they all have the sauces are high in oxalate, high in salt. Reduce the sodium intake less than 3. It is very rare that you will have recurrence of the stones. Aim for less than 3 grams per day. So enjoy your food without added salts. No extra namak on the salad. No, you could say no pickles. Enjoy with vinegar, etc. And check your food labels. If somebody's processed food is supposed to contain more of salt. The next thing that I want to point out is potassium. If you take adequate amount of potassium, it is going to help you and reduce the recurrence of stone in your patients by up to 50%. So use potassium in form of fruits and vegetables. What about the soft and carbonated drinks? They are supposed to contain high oxalate. Moreover, the other carbonated drinks like caffeinated drinks, they are dehydrating. So every cup of caffeinated beverage that you drink, do drink another glass of filtered water with them. Sugary drinks also lead to calcium and magnesium misabsorption and leading to one's increased risk of stone formation. Your body must be able to buffer the acidity of salt drinks with calcium. So in further leading to hypercalciuria, which is affecting the kidneys, leading to more and more stone formation. Carbonated beverages consumption has been linked to diabetes also, hypertension, which are indirect causes of stone formation. And they are of course leading to chronic kidney disease also. The things that can prevent you is citrate. Citrate acts as inhibitor. Stone formation is not as simple as precipitation and aggregation. It is a mixture of 2 or 3 phenomena. Of course, precipitation, aggregation is the basic phenomena, but over and above, there are certain stone promoters and stone inhibitors. So citrate is found to be a good stone inhibitor. You have to take good amount of citrate. It may be in form of lemon juice. तभी लोगों को ये concept होता है कि let's drink more of khara, as we say in common language, so that we can have our stone out. But it is more towards prevention rather than towards cure of an already existing stone. Orange and carrot juices are high in citrates. They can be promoted. Fiber. The most important thing that I advise my patients is low salt and high fiber diet. Where does the fiber come from? From the whole grains. Whole grains usually have insoluble fiber. Insoluble fibers helps to reduce the calcium in the urine, prevent hypercalciuria. So it combines with the calcium in the intestine, binds it, and the calcium is created with the feces instead through the kidneys. So the main purpose is to prevent hypercalciuria, intrarenal hypercalciuria. Sugar, as we discussed earlier, stones are associated with high levels of sugar intake, so eat less of sugar. And there is also evidence that consuming sugar, if they reduce the sugar intake by 1/3, the stone prevention is possible. Alcohol, this is a topic of interest to everybody here. So alcohol, you can have some amount of alcohol, not directly linked to the stone formation, but of course alcohol drinking alone over long sessions can lead to intrarenal dehydration because people take it over long periods without accompanying liquids and water, etc. So this leads to intrarenal dehydration and hypercalciuria indirectly and further leading to stone formation. So cases of men who are regularly drinking alcohol beverages like beer, they have upped their risk of suffering from gout. That is another factor leading to stone formation. And so prevention of excessive intake of alcohol is essential. Vitamin B6 is a very important drug in prevention of stones. I always promote my patients to have enough B6. So every patient asks, Doctor Sahab, कोई ऐसी दवाई डाल दो कि stone हो ही ना दोबारा. So thiazides can help. In my usual prescription after stone surgery, around after 1 month of stone surgery, it does include hydrochlorothiazide, which comes by the name of Aquazide 12.5 mg twice daily. In addition, nowadays we have found that certain probiotics, especially Oxalobacter, if present in adequate quantity in the intestine, can lead to less absorption of oxalate. So the tablet by the name of Oxalobacter perfringens can be used on daily basis for next 3 to 4 months after stone surgery. Besides that, of course, as I told you, high fiber diet is going to be the main thing that is going to help, along with low sodium intake. But of course, physician can consider use of supplemental potassium, potassium citrate, potassium magnesium. These all come in syrup forms to our this thing. But as I told you, my usual advice to a patient who has already undergone stone surgery is, number one, nobody guarantees a recurrence of stone not happening. Number second, you are the one who is responsible for preventing your stone. Don't blame it on the endoscopic surgery. Don't blame it on the open surgery. It is just related to what you take, where you live, how is your lifestyle. Take low salt diet, low animal protein. Do not go for junk foods. Take physical exercise, make essential. Yoga helps a lot. Take frequent liquids, interval them. Take alkalizers initially for 3 to 4 months at least. And also you can advise them Oxalobacter formigens for other probiotics for a period of 4 to 5 months. And it has to be a personalized diet for the patient. I always ask patient, आपका lifestyle क्या है? आप क्या काम करते हो? आप कहाँ रहते हो? What is the food habits? How many meals do you take in a day? This all can help you give a personalized, instead of giving them a printed chart which is always readily served with us through companies. So provide them a personalized diet chart. It takes 5 to 7 minutes, but slowly and slowly you will have it sure. So only thing, my advice to my physician friends here, very few of them are present at the moment, is don't advise patients with small, insignificant stones, don't give them unnecessary treatment. Always try to advise the patient that these small stones are not expected to cause any pain. You must look for other causes. And besides that, if you come across any bigger stones, of course your urologist friend is just a street away. Thank you so much.
Thank you, sir. For the last talk of the day, I would like to invite Dr. Rohit Bansal from Delhi Heart Institute and Multi-Speciality Hospital, Bathinda, for his talk on the topic electrolyte imbalance in ICU.
Good evening, friends. To all, I, Dr. Rohit Bansal, in charge of critical care medicine in Delhi Heart Institute. First, I would like to congratulate Dr. Vitull Gupta for organizing such a beautiful conference in our city, and thanks the organizing team for giving me the platform to discuss today's topic, electrolyte imbalance in ICU. Though it is a vast topic, but I will try to cover it in the allotted time. We will cover the following electrolytes: sodium, potassium, magnesium, calcium, both hypo and hyper in these cases. First of all, the total body volume is around 42 liters, out of which 33% is extracellular, of which 7% is in plasma, 26% is interstitial fluid, and only 1% is lymph, and 67% is intercellular fluid. So there are two compartments, the extracellular fluid and intercellular fluid. Intercellular fluid is basically high in potassium, low in sodium, low in chloride, and high in organic anions. The extracellular fluid is low in potassium, high in sodium, high in chloride. The sodium-potassium balance is maintained by sodium-potassium pump. Just remember this formula, it will help in our future slides. The serum osmolality. Number of osmoles in the serum is called serum osmolality. The range is 275 to 295 milliosmoles per liter. Then how to calculate it? It's 2 times the value of serum plus glucose, value of glucose divided by 18 plus BUN divided by 2.8. Now coming to disorders of potassium balance. Potassium, both hypo and hyper, can be life-threatening. So we'll discussing potassium first. Normal plasma potassium concentration is 3.5 to 5 milligrams per liter. First of all, hypokalemia. Hypokalemia is plasma potassium less than 3.5 milligrams per liter. The causes of hypokalemia: redistribution into cells, increased loss or decreased intake. First, we will take redistribution to cells. It's metabolic alkalosis, or if you are taking some hormones like insulin, beta-2 agonist, alpha antagonist. The anabolic state like vitamin B12 deficiency, folic acid deficiency, or patients in ICU in total parenteral nutrition. The others are hypokalemic periodic paralysis, hypothermia, barium toxicity. The increased loss. The increased loss can occur from renal or GI. The renal causes are primary, all sorts of syndromes: the primary hyperaldosteronism, secondary hyperaldosteronism, congenital renal hypoplasia, Cushing syndrome, Barrett syndrome, Liddle syndrome, renal tubular acidosis, diabetic ketoacidosis, then using some diuretics, aminoglycosides, penicillins, and GI losses. The second is decreased intake, either because of starvation or clay ingestion in children. The clinical features of hypokalemia. Manifestations vary between patients. Usually the patients are asymptomatic. They become symptomatic only when the value is less than 3 milliequivalents per liter. The main signs now. Clinical features are neuromuscular, which includes fatigue, myalgia, muscular weakness, progressive weakness and hypoventilation as severity increases, rhabdomyolysis and paralytic ileus. Then other clinical features are cardiovascular, which include abnormal ECG, arrhythmias, orthostatic hypotension, decreased cardiac contractility, potential arrhythmogenic effect of digoxin, and myocardial fibrosis. The ECG changes includes appearance of U wave in hypokalemia, flattening and inversion of T wave, ST segment depression, prolonged QT interval, prominent U waves, prolonged PR interval, widening of QRS complex, and ventricular arrhythmias. These are the ECG showing prominent U waves, biphasic T waves, and depressed ST segment. Now, how to diagnose hypokalemia? First, the history, and second is the measure the urinary potassium excretion. If it is less than 50 millimoles per day or it is more than 50 millimoles per day. If it is less than 50 millimoles per day, then you assess the acid-base status. If it is metabolic acidosis ABG, then the cause is the GI losses. And if it is metabolic alkalosis, the cause is diuretic, either vomiting or potassium loss in sweat. And if the urinary concentration loss is more than 15 milliculents per day, then assess the potassium excretion. Then you have to calculate the transtubular potassium gradient. If it is more than 4, then assess the acid-base status. The metabolic acidosis shows DK, prominal renal tubular acidosis, or distal renal tubular acidosis. If ABG shows metabolic alkalosis, and a person is having hypertension, then if it is yes, then it should be mineralocortical excess or Liddle syndrome. If there is no hypertension, then it will be vomiting, Bartter syndrome, diuretic use, or hypomagnesemia. And if the transtubular potassium gradient is less than 2, then the cause could be salt washing nephropathy, osmotic diuresis, or plain diuretic. Then how to treat hypokalemia? The therapeutic goal should be correct potassium deficit to minimize the ongoing losses to prevent the life-threatening complications. Principle to take care is safer to correct potassium by oral route. A decremental of 1 millimoles per liter in plasma potassium may represent a total body potassium deficit of 200 to 400 milliculents. Dextrose containing solution should be avoided. If the value is 3.5 to 4 milliculents per liter, then increase the intake of potassium containing fruits like bananas and coconut water. If it is 3 to 3.5 milliculents per liter, then the treatment should be given only in high risk patients. And if it is less than 3 milliculents per liter, they need a definitive treatment. Oral potassium is much safer. Potassium chloride preparations are available. Potassium bicarbonate and citrate should be avoided. Mild to moderate hyperkalemia. KCl with 60 to 80 milligrams per day should be given in 3 to 4 divided doses. Severe to asymptomatic 40 milligrams every 6 hourly under ECG monitoring. Each 15 ml solution contains 20 milligrams of potassium. IV potassium is given only in severe symptomatic hypokalemia, continuous ECG monitoring and frequent potassium estimation. Never give KCl directly. Rapid IV correction can lead to dangerous hyperkalemia. Use isotonic saline. Do not mix with dextrose containing fluids. 15% of KCl solution in 10 ml of ampule is available. This 10 ml of ampule contains 20 milligrams of potassium. Then how to give? As cardiac rhythm returns to normal, KCl drip is tapered and oral potassium is initiated. The IV potassium should not exceed 8 milligrams per liter by peripheral vein, and if you have a central line, then faster placements, maximum up to 20 milligrams per hour can be given. Then some anesthetic complications of hypokalemia. Chronic hypokalemia are most susceptible to arrhythmias. ECG monitoring is must in these cases. Glucose-free solution should be given. Potentiates the effects of neuromuscular blocking agents. Avoid alkalosis in such patients. Hyperventilation should be avoided. Now coming to hyperkalemia. Hyperkalemia is the most dangerous in ICU setup. Plasma concentration more than 5 milliculents per liter is called hyperkalemia. The causes are either decreased renal excretion of potassium, which includes renal failure, primary hypoaldosteronism, secondary hypoaldosteronism, drugs like spironolactone, NSAIDs, ACE inhibitors, trimethoprim. Then there is extracellular movement of potassium, which includes acidosis, hyperkalemic periodic paralysis, succinylcholine, rhabdomyolysis, cell lysis following chemotherapy, and D-chalice overdose. There could be enhanced colloidal reabsorption in case of Gordon syndrome or increased potassium intake by patients or pseudohyperkalemia. Clinical features are mostly skeletal and cardiovascular. Skeletal are weakness, flaccid paralysis, and hyperventilation. And CVS, they include, it depends upon the value of potassium in the blood serum. Increased T-wave amplitude comes up when the values are 6 to 7 milligrams per liter. Prolonged PR interval. QRS widening and loss of P wave occurs when the values are 7 to 8. Sine wave pattern at around 8 to 9. And ventricular fibrillation asystole when the values are more than 9 milligrams per liter. This is ECG pattern showing tall T waves, prolonged QRS interval, and prolonged PR interval. The tall T waves, loss of P wave, and then ventricular arrhythmias, widening QRS complex. Diagnosis excludes pseudohyperkalemia and transcellular potassium shift, excludes the oligorenal failure, stop NSAIDs, ACE inhibitors, then assess the potassium excretion. Then you have to measure the transtubular potassium gradient. I am talking about this term, transtubular potassium gradient. You must be wondering how to measure it. You have to take two samples, one of blood sample and urine sample, and then measure the potassium concentration in both the samples. The gradient will tell the transtubular potassium gradient. If it is less than 5, then it usually responds to fluorocortisone. If it is more than 10, its cause is primary or secondary hypoaldosteronism. And the transtubular potassium gradient is more than 10, there should be decreased circulating volume or low protein diet. Treatment, the principle should be more than 6 milligrams per liter should be treated to minimize the membrane excitability, to shift potassium into cells, promote potassium loss. If you are posted in ICU, you must know the treatment of hyperkalemia. First is calcium gluconate, 10% solution in 10 ml of ampule. It should be given over 5 to 10 minutes. Repeated if no change in ECG is seen after 5 to 10 minutes. It helps to protect the myocardium from toxicity of potassium. Second is the insulin glucose drip. 10 to 20 units of regular insulin in 50 ml of 25 to 50% of dextrose should be given bolus, followed by 5% dextrose infusion. The effect usually begins in 15 minutes and peaks in 60 minutes. Then sodium bicarbonate, 7.5% of 50 to 100 milligrams is given as IV slowly over 10 to 20 minutes. Then beta agonist, salbutamol, 20 milligrams in 4 ml line is given by nebulization. Then loop and higher diuretics are the other treatment choice. Cation exchange resins, sodium polystyrene sulfonate promote exchange of sodium for potassium in GIT. 25 to 50 grams in 100 ml of 20% sorbitol 3 to 4 times a day should be given. Hemodialysis is the last option. This shows tall T waves. The anesthetic implications of hyperkalemia. ECG monitoring should be done. Succinate choline, which causes hyperkalemia, should be avoided. Potassium-free solution should be given. Avoid acidosis. Potentiators and neuromuscular blockers. Mild hyperventilation, it should be done. Now coming to sodium balance in normal sodium, plasma sodium is 135 to 145 milligrams per liter. Hyponatremia. Hyponatremia is when sodium plasma concentration is less than 135 milligrams per liter. There are 3 types of hyponatremia. Hypotonic hyponatremia, also called hypoosmolar hyponatremia, isotonic hyponatremia, hypotonic hyponatremia. Then the hypotonic hyponatremia is further of 3 types: hypovolemic, hypervolemic, euvolemic. We are coming to causes of hypoosmolar hyponatremia. There are 3 types: hypovolemic, euvolemic, hypervolemic. The causes of hypovolemic are usually the renal loss because of diuretics, mineralocorticoid deficiency, salt wasting, nephropathic, osmotic diuresis, renal tubular acidosis. The GI are vomiting, diarrhea, intermittent sweating. Then euvolemic causes: primary polydipsia, SIAD, arginine vasopressin, glucocorticoid deficiency, hypothyroidism, chronic renal insufficiency. Hypervolemic hyponatremia, congestive cardiac failure, cirrhosis, nephrotic syndrome. Then there is term pseudohyponatremia or hyponatremia with normal plasma osmolality, hyponatremia with elevated plasma osmolality. The causes of hyponatremia with normal plasma osmolality, they should be either hypolipidemia, hyperproteinuria, hyperproteinemia, and TURP syndrome. And hyponatremia with elevated plasma osmolality is hyperglycemia. The clinical features, mainly CNS symptoms comes. They include because of increased intracellular fluid volume. Severity depends on rapidity of onset and absolute increase in plasma sodium concentration. Asymptomatic or nausea, vomiting, depressed level of consciousness, confusion, agitation, stupor, seizure, and ultimately coma can occur. Cerebral edema usually occurs when the sodium concentration falls to less than 120 milligrams per liter. and cardiac symptoms occur when it is less than 100 milligrams per liter. How the diagnosis is made? For diagnosis, you need to note 3 things. First is the history, and then 3 tests: plasma osmolality, urine osmolality, urine sodium excretions. Now, plasma osmolality is calculated by the formula of 2 times the volume of sodium plus glucose divided by 18 plus blood urine nitrogen divided by 2.8. This will give the plasma osmolality. Then calculate the urine osmolality and urinary sodium excretion. This is a whole chart how to calculate the how to find out the cause of hyponatremia. If we go into details of this, it will be a long topic, so I will omitting on this. I will be stating coming on the treatment part. The goals of therapy is to raise the plasma sodium concentration by restricting water intake and promoting water loss to correct the underlying disorder. The principles are by giving 0.9% of 3 saline in case of hypovolemic hyponatremia and water restriction in case of euvolemic and hypovolemic hyponatremia. So when to treat? Usually when the patient is symptomatic or the plasma sodium concentration is less than 120 milligrams per liter. A rate of correction depends on absence or presence of neurological dysfunction. In asymptomatic patients, this line is very careful, need to be read very carefully. In asymptomatic patients, 0.5 to 1 milligram per liter per hour or maximum of 10 to 12 milligrams per liter per hour for the first 24 hours. And if there are severe symptoms of hyponatremia there, then you should give hypertonic saline. That is also 1 to 2 milligrams per liter per hour for the first 3 to 4 hours at the maximum of 12 milligrams per day. Then you need to know this formula, how to calculate the sodium deficit in the body. Sodium deficit is total body water, that is into the desired sodium minus the present sodium. Total body water is calculated by body weight into 0.6 into males and 0.5 into females. This is a formula to calculate the sodium deficit. Now, how to measure change in plasma sodium? In fistulate sodium minus the serum sodium divided by total body water plus 1. So I will be coming to one case history that will tell us how to calculate it. A 45-year male, 50 kg by weight, presented with altered sensorium agitation. Diagnosis of hypoosmolar hyponatremia is made. Plasma sodium is 110. So first we will calculate the total sodium requirement, and then how much fluid we have to give. Desired sodium minus serum sodium into total body water. Desired sodium is 130. Our patient sodium is 110 into 0.6 into body weight. That will calculate the deficit is 600 milligrams of sodium in the body. So if we give inflates 3 saline, the osmolality is 513 minus 110 divided by 30, that is total body weight, body water plus 1. It's come to be 13 milligrams per liter. 100 ml will collect 1.5 milligrams per liter. So if you need to correct 10 milligrams in a day, then we have to give 800 ml of 3 saline at the rate of 34 ml per hour. If we correct more than this, rapid correction can lead to osmotic demyelination syndrome, that is also called central pondymyelosis, chronic hyponatremia, flaccid paralysis, dysarthria, dysphagia, anesthetic implication of hyponatremia. Plasma sodium should be more than 138 milliequivalents for patient undergoing elective surgery. Lower levels can result in significant cerebral edema. If it is hyponatremia, decrease in MAC and should be done intraoperatively. Agitation and confusion can result postoperatively. Now coming to hyponatremia. Plasma sodium concentration more than 145 milligrams per liter. The causes are impaired thirst in case of coma, hyponatremia, solute diuresis, diabetic ketoacidosis, non-ketotic hyposmolar coma, excessive water loss in case of diabetic insipidus or sweating. Then it's of further three types: hypernatremia with low body sodium content, hypernatremia with normal sodium body content, hyponatremia with increased body sodium content. Hyponatremia with low body sodium content. This occurs because water loss is in excess of sodium loss. Occurs in osmotic diuresis, diarrhea, sweating. Hyponatremia with normal total body sodium content occurs due to water loss, diabetes insipidus, central diabetes insipidus or nephrin diabetes insipidus. Then hyponatremia with increased total body sodium following administration of large amount of hypotonic saline solutions. The clinical features are again mainly CNS. They are altered mental status, irritability, weakness, focal neurological deficit, may lead to coma and death. Prone for intracerebral or subrecurrent hemorrhage also. Diagnosis, there is a further cascade of how to calculate the diagnosis of making a diagnosis of hypernatremia. We'll meeting on this, we'll come on goals of therapy. To correct the water deficit and to stop the ongoing water loss. The principle, the correction should be done over 48 to 72 hours. Hypotonic salines like 5% dextrose should be given. Plasma sodium should not be lowered by 0.5 to 1 or not more than 12 milligrammes per over 24 hours. To calculate the water deficit, you have to calculate with the formula of plasma sodium minus 140 over 140 into total body water. Rapid correction may lead to seizures or permanent neurological damage. Anesthetic implications are increased requirement of anesthesia required, enhanced uptake of inhalation anesthetics by decreasing cardiac output, predisposition to hypotension, hypoperfusion of tissues, decreases volume of distribution and reduction in dose of intravenous agents. Now coming to calcium imbalance in the body. Normal plasma calcium is 8.5 to 10 milligrams per liter. 50% is in ionized form, 40% is in protein bound, 10% is complex with anions. Hypocalcemia is less than 8.5 milligrams per liter. The causes are hypoparathyroidism, vitamin D deficiency, either nutritional or malabsorption, hyperphosphatemia, precipitation of calcium in pancreas or rhabdomyolysis, chelation of calcium with blood transfusion or rapid infusion of large amounts of albumin. This is the calcium metabolism. It occurs between the GI, then there is an exchange between the kidneys and the bone. Hallmark of hypocalcemia is tetany. Paresthesia is circumoral region and extremities, laryngospasm, bronchospasm. Abdominal cramps, urinary frequency. Hypotension, arrhythmias. Latent hypocalcemia is occurs with the presentation of Chapkowski signs and Clausius sign. This is how is a Chapkowski sign. ECG will show prolongation of QT interval. Treatment is symptomatic hypocalcemia in case of emergency is only done with 10 ml of 10% calcium gluconate over 10 minutes. IV calcium should not be given with bicarbonate or phosphate containing solutions. Serial calcium measurement should be done. Correction of the coexisting alkalosis should be done. Anesthetic implications are hypocalcemia should be corrected preoperatively. Serial ionized calcium levels monitored. Potentials and negative inotropic effects of barbiturates and volatile anesthetics. Laryngospasm can occur. Alkalosis should be avoided. Now coming to hypercalcemia. The plasma concentration of more than 10.5 milligrams per liter. The causes are hyperparathyroidism, malignancies, Paget disease of bone, excessive vitamin D intake, granulomatous disease, milk alkali syndrome, drugs like thiazides and lithium. Clinical features are anorexia, nausea, vomiting, weakness, polyuria, ataxia, irritability, lethargy, and confusion. ECG changes show prolonged PR interval, widened QRS complex, shortened QT interval. This is a formula for calculating the corrected QT interval. Treatment is hydration with normal saline, loop diuretics like furosemide, hemodialysis. If the urine output is and sodium and potassium measurement should be done. Severe cases of bisphosphonate, pamintronate 62 milliequivalent 80 mg IV over 8 hours. Calcitonin 2 to 8 units subcutaneous should be given. 90% due to malignancy and hyperparathyroidism. Anesthetic implications are saline diuresis, potassium and magnesium levels should be measured, decreased dose of neuromuscular blockade, CVP and pulmonary pressure monitoring should be done in case of this. Hyperventilation should be avoided. Now coming to the last but the most ignored electrolyte in the ICU, magnesium, hypomagnesemia. Plasma levels are less than 1.7 millicuries per liter. Causes are inadequate intake, reduced GI absorption because of malabsorption, small bowel or biliary fistula, severe diarrhea, prolonged nasogastric suctioning, renal losses because of diuresis, hyperparathyroidism, drugs like theophylline, diuretics, ethyl alcohol, aminoglycoside, amphotericin. The clinical features is patient is usually asymptomatic, is associated with hypocalcemia and hypokalemia. The symptoms which comes are anorexia, weakness, paresthesias, confusion, seizures, or coma can occur. Cardiac symptoms like atrial fibrillation potentiates the digitalis toxicity, and ECG shows prolongation of PR and QT interval. Treatment should be immediately done with 2 grams of IV magnesium sulfate in asymptomatic, and symptomatic patients should be done with 1 to 2 grams of IV over 10 minutes. 1 ml of 50% solution contains 4 milligrams of magnesium. Things which need to monitor while giving magnesium are tendon reflexes, respiratory rate, and urine output. Anesthetic implications, they are not major specific anesthetic implications. Coexistent hypocalcemia should be taken care of. Hypermagnesemia. The plasma levels are more than 2.5 milligrams per liter. Causes are usually antacids or laxatives, iatrogenic, hypothyroidism, adrenal insufficiency, lithium administration. Clinical features are hyperreflexia, drowsiness or skeletal muscle weakness, hypotension, prolonged PR interval and widening of QRS complexes, and finally respiratory arrest. Treatment is 10 ml of 10% calcium glucan IV over 10 minutes, loop diuretics with half normal saline in 5% dextrose, peritoneal hemodialysis. Anesthetic implications are monitoring tendon reflexes, respiratory urine output, potentiates the negative inotropic effects of anesthetics, neuromuscular blockade decreases by 25 to 50%. Thank you.
Thank you, sir, for the talk.
Any questions? Thank you.
Thank you. We'll wind up today's session. Tomorrow morning we'll start the scientific paper presentations at 9 a.m. and I request the volunteers to kindly reach at 8 a.m. Thank you so much for joining us and attending today's proceedings.